अनेकदन्तं भक्तानाम् एकदन्तमुपास्महे एकदन्तमुपास्महे शुक्लाम्बरधरं विष्णुं शशिवर्णं चतुर्भुजं प्रसन्नवदनं ध्यायेत् सर्वविघ्नोपशान्तये अगजा आननपद्मार्कं गजाननमहर्निशम् अनेकदन्तं भक्तानाम् एकदन्तमुपास्महे एकदन्तमुपास्महे.
Good morning, everyone. Wish you a happy new year. Welcome to 26th Indian Academy of Pediatrics, Twin Cities branch, Hyderabad annual conference. A warm welcome to everyone. We'll go to the first session, that is Senior Pediatrician Dr. Y.C. Mathur sir's oration. Year after year, every year, we conduct the oration as a protocol. May I invite the chairperson, Dr. C.N. Reddy Garu, President, Indian Academy of Pediatrics, Twin Cities branch, to chair the session. May I request Dr. Sunkoj Bhaskar sir, Dynamic Secretary, IAP TCB branch, Hyderabad, to co-chair the session. I invite Dr. Rajiv Chandra Mathur. Sir is the son of Dr. Yuvraj Chandra Mathur, is a senior pediatrician, to co-chair the session. Today's topic is Early Childhood Development, Nurturing Care, IAP Vision 2021. We have none other than President, Central IAP 2021, Dr. Piyush Gupta sir. Welcome, sir. Over to the chairpersons to conduct the oration. Thank you.
Thank you, Dr. Srinivas. Good morning, all of you. I warm welcome to second day of 26th IAP TCB convention. Yesterday, we have successfully completed the first day of conference. And I welcome all the seniors and chairperson and Dr. Rajiv Mathur, son of Dr. Y.C. Mathur Garu. It is my pleasure and honor to introduce Dr. Y.C. Mathur oration. Dr. Y.C. Mathur, everybody knows, he is our greatest pediatrician, stalwart of pediatric community. Dr. Y.C. Mathur grew up at an age when Medicare was not even in its infancy in India. Dr. Mathur sir was particularly concerned about the child mortality in his childhood, having lost his brother and a few playmates at a very tender age. This inspired him to be a doctor and, more importantly, a child specialist. transcending the barriers in low-income yet respectable homes, burdened with responsibilities of being a male elder. Dr. Mathur studied night after under street light and dared to become a doctor. His earlier schooling had been in Adilabad, where his father was a government school teacher. Later, he joined the Jagirdars College, now Hyderabad Public School, as his uncle was a warden of the school. After schooling, he joined City College and later Usmania Medical College. He passed his MBBS in 1957, DCH in 1958, and MD in 1961. He joined AP Medical Services in 1958 and worked as an assistant professor in Nilofer Hospital since 1962. He became the professor of pediatrics in 1970. Dr. Y.C. Mathur, sir, pioneered the concept of social pediatrics to offer a package of comprehensive healthcare solutions in India in 1970. For the first time in the country, a Department of Social Pediatrics was established at the Institute of Child Health, Nilofer Hospital, Usmania Medical College, Hyderabad. A multidisciplinary team of social pediatrics was formed with the professor of social pediatrics as its leader. He pioneered in the Hyderabad mix, vegetable protein mix, in association with the National Institute of Nutrition to bridge up the calorie gap in rural areas and urban slums, which is evaluated now in various national and international programs. He did 1 year WHO and UNICEF course for senior teachers in child health, London, Newcastle, upon the tiny UK and Bombay, India. He was stimulated by the work of Professor David Morley and Dr. Fred Miller and started novel and practical schemes in the total care of child in India. He has been tutor for the international course for senior teachers in child health, WHO and UNICEF, and has trained several batches of international and nutrition teachers of child health in conducting surveys in rural areas and provide comprehensive child care in their own country. He has been advisor to WHO on several occasions like MCH, family planning, multi-purpose workers training, and medical education. He visited Nairobi, Kenya, and Indonesia as WHO advisor. He was invited to participate in the United Nations special session on children. He has been awarded FAMS, FCGP, FIAP, and also Senior Hinds Award of Great Britain. He has clearly shown that a professor of pediatrics can be a good teacher at college, guide to postgraduate, run outpatients, look after the children's ward, and also work in the rural areas of urban slums. He has been Vice President of Indian Academy of Pediatrics, National Executive, and has been President of Indian Academy of Pediatrics, AP State, and Twin Cities branches. In the year 2001, he was elected President, Indian Academy of Pediatrics, National President, Indian Academy of Pediatrics. He has over 90 publications in national and international journals. He has contributed chapters in several books. His reference is mentioned in many textbooks of pediatrics, P and SM international journals and bulletins. He has been outstanding and popular clinician and teacher and has made a mark in his field of pediatrics. A very popular pediatrician in Andhra Pradesh, and is considered a leader of professional body. He is hardworking, intelligent pediatrician, dedicated to profession. He is also connected to several social organizations and active member of several professional and service organizations. He is blessed with two sons, late Dr. Nitin Chandra Mathur. Now, beside me sitting Dr. Rajiv Chandra Mathur, and his son-in-law is also there in this event, Dr. Shailesh Mathur, and all of whom are pediatricians. And I wish him a good health and active life on behalf of Indian Academy of Pediatrics, Twin Cities branch. Over to Dr. Bhaskar for the introduction of today's speaker, orator.
Thank you, Dr. C. N. Reddy. Good morning, you all, and welcome to this prestigious oration. It's a pride and honor for me to read the resume of Dr. Piyush Gupta. He is MD, FIAP, FNNF, FAMS, Professor of Pediatrics, University College of Medical Sciences, New Delhi. He is a renowned academician, teacher, researcher, author, and editor of several books. Published more than 200 papers and edited and authored 30 books. He was the editor-in-chief of prestigious journal Indian Pediatrics from 2008 to 2013, International Editorial Board member, the Journal of Pediatrics, USA, member World Association of Medical Editors. He was awarded by the Royal College of Pediatrics, UK, American Academy of Pediatrics, Indian Academy of Pediatrics, National Neonatology Forum, India, and National Academy of Medical Sciences, India. He was awarded the National Teacher of Excellence Award in Medical Education by Vice President of India. He is a technical expert and advisor to Government of India, WHO, DBT, UNICEF, and ICMR. His major initiatives were workshops on thesis and scientific paper writ. His thrust areas are on nutrition, child survival, and medical education. He was the ex-Joint Secretary, South Asia Pediatric Association. To his credit, this is going to be the 11th oration. And more than this, he is our president of Central IAP for the year 2021. And he had took up our journal to a higher levels with his excellence. Thank you, sir, for accepting our request to deliver this oration. Now I request you to present, sir.
Thank you. The organizing team of the 26th Annual Convention of TCB IAP PEDICON 2020. I am really honored to get this award, this oration instituted in the name of Professor Y.C. Mathur, sir. This is a, can you see my screen slides? Hello? Can the slide be seen?
Yes, sir, we are able to see you and we are able to hear you, sir.
Okay, but you cannot see the slide as of now.
Kindly, have you shared the screen, sir?
Yeah, but it says host has disabled participant screen sharing. So you have to enable my screen sharing.
Yeah.
The host, you have to enable my screen sharing so that I can share. Yeah, now it is enabled. Can you see it now?
Yes, sir.
Can this,
Yes, sir. We are
you
able
can
to
see the slide?
Yes, sir.
Okay, then I will start. Thank you so much. So, first of all, I thank the organizing team for the annual convention of TCB IAP PEDICON for giving me this opportunity to deliver this very prestigious oration in one of my very favorite and very respectable past president of the IAP, Professor Y.C. Mathur, and in whose honor this oration has been instituted. And it's a honor that I will be speaking today on my vision for the IAP for 2021 in the field of early childhood development. I thank the chairpersons, Dr. Reddy, Dr. Bhaskar, and Dr. R.C. Mathur to be there and again asking me to present this particular oration. So to start with, the first 3 years of life are critical. This is the period where maximal brain growth occurs. Child-parent attachments are formed and pre-academic learning starts. Early child development is dynamic and is influenced by genetic, biological, psychosocial, and environmental factors. Now, there can be some adverse factors like poverty, stunting, etc., and which are significantly outweighing the protective factors that include educated parents, stimulatory home environments, etc. And the imbalance between the adverse factors and the protective factors negatively affects the brain growth, physical health, and psychosocial development in young children that results in faltering or a downward deviation of the developmental trajectory. Now, if you can see in 2017, the Lancet reported that around 250 million children, that is 43% of under 5 children across the globe, uh, from low and middle income countries, they are not reaching their expected developmental potential. So this is a huge, more than 40% of children are deprived. And if you see, the risk varies between significantly by low, middle, and upper middle income countries. If you can see India, these are all purple zones. So all the purple zones that you can see, the prevalence of not achieving developmental potential is between 40 to 60%. And even more than that are in some areas of Africa where it is still more than 60%. So we are also in the bracket of between 40 to 60%. Now, if we look beyond the risk of poverty and stunting, there are both low maternal schooling and child maltreatment are related to poor outcomes. And when you add these factors to poverty and stunting, the risks for poor outcome increase dramatically, and they can go up to 75% risk with all the other factors also added for the same. So these are the various other risk factors that contribute to early child development, uh, to a delayed child development that include already said the poverty, nutritional deficiencies, food insecurity, high crime communities. That's one of the reasons why in Africa the prevalence is so high. Low quality resources, family stress, and child abuse and neglect. And the children in low and middle income countries are exposed to a greater number of risks. Now coming to what do we mean by early childhood development? Early childhood development is not simply neurodevelopment because we confuse development with neurodevelopment. In the MBBS, we are taught that growth is a quantitative term and development is a qualitative term, and they are different. But here, in the context of this program, early childhood development includes everything. This includes child's cognitive growth, social growth, emotional and language development, as well as it also includes their physical growth. So this all is part of early child development in the context of this terminology. So to highlight again, the early childhood period encompasses several quite distinct phases. It includes from conception to birth and birth to 3 years, again, with emphasis on first 1,000 days. Then preschool and pre-primary years, that is 3 years to 6 years or age of school entry. And some definitions also include 6 to 8 years of age. So early development includes children from from conception to 8 years of age, but depends on the focus, may be different in different scenarios. Now, why invest in early childhood development? Now, we don't have any such investment in Indian context, but as calculated by WHO and other agencies, that every single dollar invested in early childhood development can provide a return of up to $17 in terms of national or the global gross development and income. Now, there has been a constant debate on nature versus nurture in early childhood development. Various agencies dealing with early childhood development, like WHO, UNICEF, Early Childhood Developmental Action Network, and Partnership for Maternal, Newborn, and Child Health, they have been working on ECD for over the years. This has led to the model which is highlighted here, nurturing care for early childhood development. That is also in short known as NCECD. Now, NCECD is a holistic approach that provides framework for not only survive and thrive, but also to transform health and human potential. So this is the importance of nurturing care. So parenting and nurturing care, as you can see, there are 5 components. They are evidence-based and they are proven to be effective in low and middle income countries. Now these are, as you can see in this pie, one is the good health, the second is the optimal nutrition, then there are opportunities for early learning, responsive parenting, and safety and security. It is believed that the provision of nurturing care can enhance child development even in the presence of adversity. We have been facing these adversities for last 1 year, and it is time that when we are reopening, we have to focus on all these issues and take care of the adversities that we have been through in the past years. Training modules have been developed for community health workers that can be adopted according to the point of evolution in a country, wherever the country is placed in terms of nurturing care and early childhood development. So these are the 5 main areas where we have to work upon when we are talking about parenting, nurturing care, and investing in early childhood development. I will repeat: nutrition, healthcare, love and security, that means security and safety, and you can also say protection from danger, responsive caregiving, and early learning, that means opportunities to learn and discover the world. Now, nurturing care is fostered by a supportive environment. That is the ecological model you can see here that is projected by various international agencies across various programs also. So it starts basic, the first core activities or the first interventions start within the family. So there is the nurturing care by parents and caregivers. That is where the IAP is focused, that one has to enable or empower the parents to look to this or to provide a nurturing care environment within the home. And then the parents have to be given the capacity to provide the nurturing care. Now, who will give this capacity to provide nurturing care? The capacity obviously has to be, the focus has to be the pediatrician. And as we know that 70 to 80% of pediatric services in India are provided by the members of IAP who are working in private sector. So only enabling the government sector or putting a program across in ECD in government sector to pediatricians will not work. We have to involve our fellow pediatricians who are working at grassroots level in providing care to these children in the private sector and their parents. So they should have the capacity to provide the nurturing care. So it is important, thus becomes our duty as a custodian of child health in Indian Academy of Pediatrics, that we should enable the pediatricians across the country, across the length and breadth of this country, to enable them to provide or to empower the parents to create an environment that will foster nurturing care in the families. And finally, we are at IAP are committed for the health, nutrition, education, social and child protection services that will be a part of training that will be imparted to the pediatricians. And national policies are already in place. As you can see, the India's country profile estimates that 45% children are at risk of early childhood development. So just to highlight, this is a holistic approach to not only to survive and thrive. These are obviously survival is the first thing. Survival, thriving is first thing. And the second thing, more important than that, once we have achieved that survival to some extent, is to transform health and human potential. These are the various evidence-based interventions, again taken from that Lancet paper of 2017. And you can see the various interventions at every stage in adolescence, adulthood, in pregnancy, every trimester, labor, birth, neonatal, infancy, early childhood, and school age. So what IAP during the next 3 years will be focusing on early childhood development between 0 to 3 years. So these are the interventions that we need to do: neonatal disease prevention and treatment, healthy home care and nutritional support, promotion of optimal infant and young child feeding, and high quality early childhood care and educational programs. So how can this be done? I will be coming to that when I unfold the program that is to be run during the next 2 years. Now, new evidence and longitudinal outcomes have shown that these interventions work. The birth cohort studies have shown that long-term follow-ups have shown that if there is a growth failure in the first 2 years of life, this may have extensive effect on the later childhood development. And the deficit and disadvantages which a child gets when he or she is deprived of the childhood development potential, these are carried not only into his adulthood or adolescence or in the profile of the country, but these are carried over into the subsequent generation as well. The strategic action plan all over the world include, again, 5 main focus: lead and invest, focus on families and communities. That's where IAP is playing a part, that the focus on family and communities. And number 3 also, the strengthen the services. So these are the 2 areas where, rather I would say 3 areas, because we are again taking a lead. We are investing almost a budget of almost 4 to 5 crore in next 2 to 3 years into this, and with focus on families bridged. The pediatrician will act as a bridge between the IAP and the family to empower the parents and strengthen the services that are provided to the parents and children by the pediatricians. Now, if you can see this country report, this is the country profile, and 45% children, that means approximately 70 million are at risk for delayed child development. The burden in India, if you can see, they are the risk is in young children are at risk. The lifetime cost of growth deficit in early childhood is estimated to the tune of 154%. And the threats to early childhood development: increased maternal mortality, low birth weight, already stated child poverty, young mothers, under 5 stunting, and preterm births, and again, violence and discipline that we envisage to take care of by the early learning opportunities. Now, coming to one by one, in the health sector, I highlighted 5 points important, which are to be taken care or which are to be covered under the ECD. In the health sector, the care seeking for pneumonia has improved. So we can boast of that at least 75%, but still it is much less than the desired goal of 100%. Antenatal care is still limited only to 50%, and postnatal visit again 50 to 60%. How many women, pregnant women with HIV are getting the care, and children? No data is available at present. In the nutrition sector, early initiation of breastfeeding, I am sorry to say we are still stuck at around 40% only, and exclusive breastfeeding in only 55%, despite so much of our efforts going into it. But so this also needs to be strengthened. It is not only we have been making noise, but obviously the noise has not resulted that much of results or impact that was envisaged or that was thought that it will create. Minimal acceptable diet, according to the recent Comprehensive National Nutrition Survey, the minimum acceptable diet is only available to 8% of children. So that is even less than 10%. That was really surprising. Early learning, absolutely no data except for early childhood education, where 40% attendance in there. Responsive caregiving, the concept is almost missing because when in a pediatrician's visit also, the responsive caregiving advice from the pediatrician chamber is based on their individual preferences and the time available each pediatrician. So our endeavor is to build up this responsive caregiving advice in the practice of each and every pediatrician when they are talking to their parents. And again, security, safety, no data about the discipline, but the basic amenities, sanitation, still only 60%. And that is the main emphasis of Prime Minister's drive to provide sanitation, basic hygiene, and waste disposal facilities to every citizen in the country. Now, India has a policies for facilitating environment for early childhood development. Now, these include the certain policies such as there is a paid maternity leave, there is a policies for child protection. We have a international code or again IMS Act that include breast milk substitute. We have something for child abuse. We have plenty, and we have the POCSO Act also. International conventions, obviously we have the convention on the right of children, and there are protocols on safety of children, child trafficking, and child prostitution. If we just have a look at the 2030 Sustainable Development Goal, that states that by 2030, all girls and boys should have access to quality early childhood development. Here again, the focus is on quality. You see, all the should have access to quality early childhood development, quality care, and quality pre-primary education, so that they are ready for their primary education. The indicator is the proportion of under 5 children who are developmentally on track in health, learning, and psychosocial well-being. So this is again our focus, that if through this program we are focusing and we are trying to bring up this indicator, reach this indicator of increasing the proportion of children so that they are developmentally on track. At present, we can say by the country data that we saw that this proportion who are developmentally on track is approximately only 55%. So the aim is to increase it to at least 70 to 80% in next 2 to 3 years. Coming to the health, community health seeking attitudes. Now, when do parents go to a pediatrician? Parents go to a pediatrician for medical attention related to acute or chronic illnesses or for immunization. They don't go to the pediatrician for a well child visit. The concept of a well child visit, in which other aspects of child health and well-being are discussed, like maybe what kind of food the family is giving, the two main burgeoning issues are today are the junk food and the screen time that are being taken, that are consuming a lot of attention and creating problems in early childhood. They start from early childhood. So this is concept of well child visits is almost foreign to both parents and pediatricians. If India has to meet the 2030 SDG goal, there needs to be a paradigm shift in the knowledge, attitude, and practice of all the stakeholders, and that includes not only the policy makers. Policy makers are sensitized. We have to get sensitized, and the service delivery health personnel, that means the pediatricians and the healthcare workers who are working in their clinic, they have to get sensitized, finally to be transferred to the families and parents. So this year, 2021, is an exciting time of transition. Last year, we pledged our commitment to promoting ECD in the health policies that Government of India has already done. The rollout of Rashtriya Bal Suraksha Program, RBSK, was a proof of this. But there are still a lot of grounds to be covered in the next decade. And this can only be done if the private health sector that serves the major chunk of children in our country, they join the initiative to help our children survive, thrive, and transform. And this can only be done if we promote the concept of well-child visits and public realizes it is a strong felt need from their children. And the idea now is to integrate the nurturing care, early childhood development in the day-to-day practice of the pediatrician. The only way parents can be convinced about nurturing care and its benefit if we, the community of pediatricians, we have this belief and we are willing to incorporate it into our own clinical practice, and that too with conviction and dedication. So this was about the preamble of the early childhood program. Now I come to what are the vision and what are the programs are for this year and coming 3 years, that this program will start in 21 and is to be carried out in next 3 years to 2023. So there are two small limbs of this program and one big limb. The smaller limbs are IAP WHO collaboration, where the focus will remain on advocacy and pre-service education. And the second limb, again supported by WHO, where the again about the sensitization, where Indian Pediatrics this year will be publishing a separate special supplement on early childhood development. IAP will organize a series of lecture on ECD. You can say that this oration is a part of this series of lecture and nurturing care at national and state level. So at least through this lecture, through this oration, I hope that people in not only the Twin Cities, but the entire Telangana, they are oriented and they are sensitized to the concept of early childhood and nurturing care. We hope to prepare a position paper again on early childhood development and nurturing care by IAP and other stakeholders. Our partners in this, already the WHO and IAP have, WHO and UNICEF have committed, Ministry of Health has committed, and in the coming PEDICON, that is a hybrid limited PEDICON we are holding at Mumbai in February, we are having a WHO, IAP, UNICEF, Government of India plenary session on early childhood development. And if you must have noticed, the theme of the current conference is also nurturing care for early childhood development. Then coming to the pre-service capacity building, it is important that not only the current generation of pediatricians, but the coming generation of pediatricians are also aware of the focus on early childhood development. And this can only be done if this program or the sensitization can be included in undergraduate and postgraduate medical curriculums. So that will be the another focus this year, to make some recommendations from IAP on incorporating ECD in UG and PG curriculum, and finally submit them to NMC, and then advocate and be after them to incorporate this into the UG and PG curriculums of PG curriculum of pediatrics. As I said, we will publish a supplementary issue of Indian Pediatrics where you will have around 15 to 20 articles covering the entire range of ECD, and you can pick and choose, or if you have time, you can read the entire. So this will again be sent free, the supplement, to all the IAP members, again on the as a soft copy, and those who can who want the hard copy can order it from the Indian Pediatrics. This is the list of all the topics that will be available in this issue, so I am not going into those details. Now coming to the main program, that is the IAP Nurture ECD program, which will be a flagship program for the Indian Academy of Pediatrics this year. The flagship program, what is our goal? As I have been saying from the beginning, the focus in this primarily now will be on improvement in outcomes related to holistic child health, growth and development. The emphasis will remain on early childhood. That means between 0 to 3 years. So this particular program, we are not taking above 3 years. So we are just concentrating on 0 to 3 years. And the aim is that we aim to improve the practices of the caregivers, that means the pediatricians. And finally, as I said, they will act as a bridge. So who are the ultimate beneficiary? Ultimate beneficiaries are children between 0 to 3 years. They include both those children who are developing normally or children who are at high risk because of some biological factor, like if they are low birth weight, preterm, NICU graduate, having malnutrition, growth faltering, or developmental faltering, or if they have some psychosocial disadvantage coming from the low income literacy group, single parents, or other risk factors. And obviously, the children with special needs, such as those having developmental delays, disability, and birth defects. So these are the children who will be covered or the intended beneficiary under this program. What we will do, capacity building of pediatricians to popularize the concept of well child visits. We already have 8 visits which are coinciding with the current IAP immunization recommendation. That is at 6 weeks, 10 weeks, 14 weeks, 6 months, 9 months, 12 months, 18 months, and 24 months. We propose 2 additional visits at 30 months and 36 months, that is 2.5 years and 3 years, to take care of the entire first 3 years of children and incorporate the concept of well child visit within the immunization session, within the other session, and other SOS visits of the parents to the children, parents to the pediatrician. So the nationwide training workshop will be conducted. The training workshop will be conducted with the objectives of to build up the capacity of and the skills of pediatrician in communication, building of professional relationship with parents, and counseling and planning of activities with the parents to popularize well child visits, to incorporate the practice of sensitization and imparting skills to parents and caregivers, to develop a uniform system of monitoring growth and development, to empower pediatricians to recognize whether a child is typically developing or high risk with special need, and to incorporate inquiring about parental illness in the well child visits. Administratively, it will be governed by a steering committee and a project advisory group. This is the stepwise approach, the plan for next 3 years. We will first generate the baseline data on existing knowledge, attitude, and practices by conducting a small study and survey, develop, and based on the results of this baseline data, we will plan the sensitization activities and prepare the material. This is a mammoth task: preparation of facilitator participant modules, preparation of parent resource material, and then parent information material, whatever to be given to the pediatrician in these 200 workshops that we plan to do over next 3 years. So first, we will do the sensitization activities with the national meeting of stakeholders, and this is the structure that is almost uniform to all other IAP activities also, followed by a national program. We'll have zonal TOTs, again one in each zone, and again followed by 200 district workshops. So we plan to have the zonal TOT by July, August this year, and the next phase of the rollout, that is the next 6 months of this year, we will have at least 100 district workshops, and 100 will be carried out in the next year, that is in 2022. Again, the components, what all be the components that will be included, I have already stated the good health, those 5 components, and each component in turn has a sub-component that will be dealt with in detail when training the pediatricians and the parents. About the good health, that will include immunization, growth monitoring, developmental monitoring, vision, hearing, and water and sanitation, hygiene, oral health, skin health, maternal illness, and identification of red flags. Nutrition, what is recommended, how to recognize the micronutrient deficiencies, what deworming is to be done, when is to be done, and what are the various do's and don'ts of nutrition. Amongst the opportunities for early learning, appropriate media use, screen time need to be emphasized. The policies need to be known by the pediatrician, need to be known by the parents, how they should arrange their toys and play for their children, read to their children, the role of learning to communicate between the children, their peers, and the parents. Then there are other opportunities for early learning by enrollment in play school or Anganwadi, how to instruct other caregivers, and the do's and don'ts of social, emotional, and pre-academic learning. Responsive parenting will include components on sleep hygiene, parent-child interaction, and bonding activities other than promoting the emotional wellness and self-regulation on child. Safety, security, these are going on one limb. This is going on government level. Birth registration, sanitation, drinking water, and first at site. So, and what IAP needs to do again, we need to develop the red flags for maternal and domestic abuse, child abuse, and safety words to alert the parents, differentiate or train them in differentiating between good touch and bad touch. So these are the various measures imbibed in safety and security of children. That will include their safety and security not only at home, but during their travel and going to various places. This is the Gantt chart. So you can see the activities start. This is the planning phase in 2020. I just signed an agreement this morning in IAP office for funding for to the tune of almost 4 crore, and this we will be doing in 2021. 100 workshop in this year, 100 workshop next year, and the most important part that has never been done before in such kind of programs is the impact evaluation. As you can see, the last 1 year we have inbuilt for impact evaluation. So we not only want to do these interventions, we want to see how our interventions have worked. And this is most important because if we want to do similar programs in future, here only we are concentrating on 0 to 3 years. If we want to carry it over to 3 to 6 years or maybe up to 8 years, we need to see how well our interventions have worked, what are our lacunae. So this, I think, where we are not doing anything obviously for the parents, pediatricians, but we are just collecting data on impact evaluation remains the most important part of that is the third year of this program, complete program evaluation. And we will be measuring the short-term outcomes in the impact evaluation as well as the long-term outcomes. The way forward, going from here, the recommendations, science says start early, expand political will, create environments, use the health sector and support the system enablers. The focus on 3 years, why 3 years only? Firstly, I have already highlighted because there are enough opportunities in this age group for intervention through health services. The SDGs call for equitable opportunities, all countries to prioritize the most vulnerable, and we hope that through this small effort of IAP in the big ocean, it's just like a drop, we are able to make a significant difference. Children need a safe environment, they need consistent loving attention, and these are the various contributions of ECD to achieve the goal. As you can see, early childhood development contributes not only to childhood development, but indirectly to these sustainable goals by eradicating poverty, hunger, improving nutrition, ensuring healthy lives, ensuring lifelong learning, achieve gender equality, and promote peaceful society and strengthen the means of implementation. So improving ECD is the key to achieve the SDGs, and finally, this is going to be achieved by our activities in IAP this year. So this was a small program that I presented before you, and I request all the branches, state, subspecialties, all the members, all the participants to wholly support IAP during the activities of this program so that we can work for the betterment of a better society. I'm thankful here to Dr. Shamila Mukherjee, who helped me design the entire project for funding and for implementation. Thank you. Thank you once again to the organizing team and for conferring this prestigious YC Mathur Sir oration during this annual conference. I bow to you. Thank you. Thank you very much once again.
Thank you very much, Dr. Piyush Gupta sir. Now I request Rajiv Chandra Mathur sir, son of Dr. Yuvraj Chandra sir, to felicitate our President IAP, Dr. Piyush Gupta Garu. Thank you, Dr. Piyush Gupta sir, for navigating us through the Vision IAP 2021 and sharing your words of decades of wisdom. Thank you very much. Now I request our office bearers, President and Secretary. Thank you, sir. to felicitate Rajiv Chandra Mathur and Dr. Shailesh Chandra Mathur, sir, who are the so, sons of Dr. Yuvraj Chandra Mathur, continuing the legacy of a senior pediatrician. Thank you very much. Thank you for your time. We'll move on to the next session. Your attention to Bhaskar, sir.
Thank you, sir, for your excellent high-end, high-profile oration. And thank you for revealing your IAP Presidential Action Plan. I think we are privileged to have those plans, probably first-hand from your face. Thank you, sir. And honestly, yours was the unanimous choice by the entire IAP TCB 900 members to have this oration to be delivered by you, particularly son of our Dr. Y.C. Mathur, sir. Dr. Rajiv was very particular about your being the participant as the orator for this.
Thank you, sir.
Thank you, sir.
Thanks
Now I
to the
request
entire-
our Dr. Rajiv to say a few words.
There is a message from Dr. Y.C. Mathur. He was indeed really happy and pleased to hear that Dr. Piyush Gupta is delivering his oration. And he has sent his immense thanks to you for choosing a topic which is very dear to him. And that was his intention and goal since his inception into social pediatrics. On behalf of Dr. Y.C. Mathur and his family, we would like to thank you for delivering an excellent program for the IAP future and for the children of India. And I would also like to thank the Twin City branch of IAP, Dr. Bhaskar and Dr. C.N. Reddy, for being excellent hosts to holding fantastic
sir, for his
programs
blessings
in
and from
IAP.
the-
Thank you. Thank you very much, Dr. Piyush, Dr. and IAP also.
Thank you so much. Thank you.
Thank you, sir.
Thank you very much, sir. Thank you.
Couple of announcements. The posters round has started. They are being assessed as we speak. It will go on for the next hour. We have the gold medal paper presentation this afternoon between 12 to 12:45. Another thing is I request all the senior members of IAP TCB, EB members and other committee members for IAP TCB PEDICON to kindly be here at the valedictory. We will be giving some thank you placards and plaques to all of them. I request them all to stay here during the valedictory post the lunch. Now coming to the next session, we have a very interesting talk, a talk of today's time, update on the hexavalent vaccines. I request Dr. P. Venkateshwar Rao, Senior PATS member and Senior Election Commission for IAP in the past, to kindly come up on the stage as the chairperson. For this talk, we have none other than Dr. Naunihal Singh, a very senior pediatrician in the city of Hyderabad, MD of Tanveer Hospital. He's been practicing general peds with a special interest in adolescent. He happens to be in the very high hierarchy in the nation when it comes to adolescent pediatrics. I request sir to kindly give us a talk on hexavalent vaccines and update. Thank you.
Good morning, everybody. I'm very happy to see a direct contact after a very, very, very long time, almost about 1 year, which we had been missing. And especially this idea of hybrid conference. I think this is the first hybrid conference which the Twin Cities have planned, if I'm not wrong. So it's a great pleasure to be in person with everybody. And just now, we had a very good oration by Dr. Piyush Gupta, where he has discussed about the significance and importance of taking care of the child right from conception till 3 years, and then followed by 6 to 8 years also. Hyderabad and Telangana pediatricians have formed a Lakshya 1000, in which we have gone one step further where we are asking everybody to take care of these children prior to conception, that is preconceptional, 3 to 4 months earlier, so that we have a good sperm and a good egg. So that we should request from our society, Dr. Piyush Gupta, to add that point also, because that's very important. And second point which has been emphasized in this is about the vaccinating the children, because the children are the future of our country, and the economy, quite a lot depends on them as well. So today I'm going to talk about the hexavalent vaccines, the type of hexavalent vaccines which are available and which is beneficial for our population. So the role of IPV in current epidemiological scenario, what is the role of IPV? That's very important. IPV has been eradicated from India almost about 1.5, 2 years back. But again, we are finding quite a number of cases which we are going to discuss. What really matters when it comes to choosing a hexavalent vaccine? Which vaccine we should choose? Which is good? There's always a confusion about it. So we are going to just clear a little bit of mist on that, but still all the vaccines are good. Then protection against the key antigens, that is the most important factor, because whenever we are giving any vaccine or any medicine or anything, we need to have an effect of that. So what is the effect of key antigens and the long-term impact? Whatever we are doing, we need to have a long-term, we don't want a short-term effect on anything. And use in special population, and what is the real-world experience? So we are going to discuss about all this. So now we have been seeing that globally, the polio had been eradicated. There is a lot of hue and cry that polio is not there, but still in the previous 12 months, it has been found that quite a good number of WP1 and CVDP has been reported in many of the countries, especially in our neighboring countries like Pakistan and Afghanistan. So that's going to be a threat for us as well. So we have to be much more careful about this, because this virus is going to, again, may come back to our country also. What are the precautions we are going to take? WHO reconfirmed polio as a public health emergency in January 2020 again. Since the CVDPV2 outbreaks after removal of OPV has been particularly difficult to control because of rapidly waning intestinal immunity against type 2 polio virus. So what should be done about that? What are we going to do? What precautions are we taking, and how are we going to control our population about that? So there is a program rationale to include IPV. So IPV has to be included, and it has to be given to all the children, and the government of Telangana and government of India has also planned that, and every child should get at least 2 to 3 doses of IPV, whether it is a full dose or it is an intradermal dose. Government is planning to see that IPV is included in it. So why are we including it? Because to reduce the risk associated with type 2 cessation, lower risk of re-emergence of type 2 polio virus. Once we immunize all the children, then the re-emergence becomes a little less. Facilitate interruption of transmission if type 2 outbreaks occur, and to boost immunity against type 1 and type 3, thus hastening polio eradication, not only from India, but all over the world as well. So now, how effective is a single dose of IPV given at 14 weeks? It has been seen that in meta-analysis, where studies have been done, it was found that a single dose of IPV gives a protection for type 1 up to 33%, type 2 41%, and type 3 47%. So a single dose is going to give only up to 41%, and 2 doses of the same gives the protection up to 79 or 80 to 90%. So a single dose of IPV may not provide adequate seroconversion, especially against type 2. So we need to think more about it, we have to be more careful about it, and we have to give more number of doses for that. Children are protected against type 2 for the first 3 to 4 months of life. Then now, What about the 2 fractional doses of IPV? When the single dose was given, it was only about 41%. 2 doses made about 80 to 90%. When 2 fractional doses were given, and the studies were done in India and Bangladesh, it was found that the protection is between 70 to 80% only again. So the fractional doses are also not going to give more than 90-95%. So we need at least 95% of protection for the polio as well. So what is the possible IPV schedule which we should be following? Initially, 2 doses intradermal is not recommended by IAP. IM single dose of 14 weeks does not give total protection. Again, 2 doses recommended primarily by IAP requires DTP at 8 weeks and no standalone IPV. So it is a incomplete without booster. So booster has to be given to boost up the seroconversion. Now again, 2 + 1 doses. Recommended series by IAP requires DTP at 8 weeks and no standalone IPV. Now the best way is, which is recommended by IPV, is 4 doses, 3 + 1, which is 6 weeks, 10 weeks, 14 weeks, and again a booster at 1.5 years. So this will give very good protection. So we should try to see that wherever possible, we should try to give 4 doses, but we should not deprive our children for the lack of money, because that is very, very important. So, role of IPV as an adjuvant to immune response. It has been found that in 2 models, wherein baboon and the mouse model, addition of TLR7 agonist to an aluminum adjuvant, that is acellular pertussis vaccine, converts it from Th2 inducing vaccine to a more potent Th1 and Th17 inducing vaccine with a higher protective capacity, equivalent or greater than the WP, that is a whole cell pertussis vaccine in murine model. It was not done in human model, but it was done in murine models. So what really matters when it comes to choosing the hexavalent vaccines? What we need to do is, we need protection against key antigens, that is DTP and polio, which is very, very important. Then the long-term impact, how long does the protection last? Use in special populations, especially in preterms, which is the vaccine which is more effective in that, which can be given also. And what is the real world experience about these vaccines? So it has been found, the studies have shown that when vaccines have been given in different vaccines, that is a WP vaccine, 2C vaccine, and hexavalent vaccines, it was found that the diphtheria antigens which were there were almost about 100%, 49% and 94% in different vaccines, and whereas polio had been there quite good in the hexavalent vaccines, which are acellular, and IPV was added in that. So all the vaccines were very good. So all vaccines which are having polio in it were quite effective and quite good. And the pertussis factor was also found to be very good in hexavalent vaccines which are pre-mixed, to be mixed, and the whole cell also. In whole cell it was a little less, but in the pre-mixed vaccines and the acellular vaccines it was found to be quite good. So protection against the key antigens like diphtheria and tetanus, it was found that the diphtheria factor was almost about 900% in to be mixed vaccine, pre-mixed vaccine it was almost about 49%, and WP vaccine it was 94.9%. Whereas in tetanus it was almost about 100% all the 3. So all the 3 were very good for the tetanus. Protection against the key antigens, polio and pertussis, which are very, very important, and it was found that all the vaccines had very good effect on polio, and adding up as IPV as an adjuvant acted as an adjuvant. So there was protection was almost about 100% in the vaccines where acellular vaccines, whereas in WP vaccine it was almost about 80 to 90%. In pertussis, it was almost the pertussis toxin vaccine was the most important one, and in that also it was found that the acellular vaccines were scoring a little better than the other one. So protection against the key antigens in Infantrix hexavalent vaccine was almost about 89% efficacy, and the other two were almost about 78%, and WP data was not available in that. In long-term impact, all the antigens were found to be having an impact of almost about 7 to 15 years for all antigens, and especially for the hepatitis B, it was almost about up to 15 years. Whereas in pre-mixed vaccine, it was found to be 4.5 years, and for hepatitis B, it was 9 years, whereas in WP, the data was not available. Use in preterm. This is also very important because all the vaccines cannot be given, they are not indicated, they are not been accepted. So these are Infantrix, which is to be mixed vaccine, is recommended based on more than 10 studies done in preterm infants, more than 1600 grams, and pre-mixed vaccine was not approved for preterms, nor WP is also not approved. So the real-world experience on the effectiveness studies which were done in Sweden and Netherlands, it was found that the to-be mixed vaccine was having a more than 20 years experience, whereas pre-mixed was 7 years, and WP was not available, and global experience were only 3 years. So the reactogenicity profile of 3 hexavalent vaccines, which were done in Indian trials, were found to be, all the 3 vaccines were quite effective, but the WP had a little bit of pain and tenderness. Swelling was a little more in that, redness, but that doesn't last long, and that's not the main criteria for giving these vaccines. But the only thing is, we need a long-term protection, which was shown to be a little more better in these studies. So what does IAP recommends? 3+1 schedule of IAP in all private practice. In the government sector, they are giving, I think, about 2+1. And Infantrix hexa is the only hexavalent vaccines with up to 89% efficacy data included in its label. Infantrix hexa demonstrated 97 seropositivity against pertussis, whereas WP demonstrated 68 anti-PT response in their respective Indian trials. Infantrix has demonstrated 98 to 100% seropositivity against polio, whereas WP demonstrated 88. Only Infantrix has extensive experience to support vaccination of preterms as a full-term infants. So it is almost the same for the preterm as well as the full-term. It can be given in both. So these trials have been there for almost about 20 years of clinical experience and all. So basically, going to that, more than that is, whatever vaccine is more effective for the children, that should be given. And as far as our experiences go, the acellular as well as the WP vaccines, the protection for the longer period is same for both the vaccines. So any of the vaccines can be given, but as far as possible, try to get the polio factor in the vaccines. So the hexavalent vaccines are more beneficial than only DPT and OPV and HIV. So that's the message which we want to send, because hexavalent vaccine should be given to almost all the children of our country as well as everywhere to protect and eradicate polio also. Thank you.
Thank you, Navanyal Singh. You nicely explained how to take compulsory, make it mandatory in IAP, 3+1, ideal choice. Thank you so much, sir.
Thank you.
I think it's more useful for practitioners and take-home message for our patients. Very nice. Thank you.
Thank you.
Thank you, sir. That was very, very informative. I request both Dr. P.V. Rao and Dr. Navanyal Singh to kindly come on this side for some felicitation. Thank you. Now I request Dr. M. Rangaya, Managing Director at Neo BBC Hospital, very, very senior pediatrician, very passionate teacher, and very active in IAP activities, especially when it comes to media, whether it is print or newspapers, TV, radio. where he actually makes sure there is a lot of awareness and a lot of advocacy of IAP activities is brought to the fore for the general public to moderate this new session. Most of the focus on today's topics is on developmental pediatrics, which is what is going to be the key message for the Central IAP for the next 3 years. For the first talk, I request Dr. Preeti Nagaraj to kindly come up on the stage. The talk is on scholastic backwardness in children. What is the role of pediatrician? I request, sir, to introduce Madam.
I request Dr. Preeti Nagaraj. She is Professor of Pediatrics, very active member in IAP TCB, as well as PATS. I request her, please.
So good morning, everyone. A very happy New Year to all. Thank you, Rangaya sir, at the outset, I would like to thank the TCB organizing committee to have given me this opportunity to stand. As Navni sir said, that it's been a long time that we are having a conference, and we are, it is not online, and we are seeing each other and interacting. So it's a very pleasant feeling. So most of the pediatricians might be facing in their clinics the parents coming and saying, doctor, my child is having exam, and give some medicine where the child should score 100 on 100, or the child should score the excellence in the maths. Or some parents might come that the child learns everything at home. He is thorough in answering. The moment he goes in the class, he is stuck. He doesn't answer anything. And there is a surge sometimes. If you are seeing, especially on the Saturdays, second Saturdays, most of you would agree that parents come with a report card because that's a parent-teacher meeting in the morning, and they come in the evening to the clinic and say, teachers had said, my child is very lazy and sometimes he doesn't copy from the board. Thank God, madam, that nowadays WhatsApp and all are there, so I am sharing the homework and all from my other friends. So it's been done. And sometimes some parents may say that my child is very active, and he goes on answering for anybody. Teacher is asking question to somebody, he just raises his hand, and instead of getting his chance, he goes on answering. And we as pediatricians have so many things to answer to them. So in the next 10-15 minutes, I would try that what all we should do when such questions come up and the parents we have to answer to the parents. Scholastic backwardness is the most commonest educational problems encountered in the pediatric practice and in children. So how is it defined? It is defined as performance below the 2 standard deviation for what is expected of that age and the class in which the child is studying. So what can be the different causes of this scholastic backwardness? There can be problems in the child only. Problems can be there in the family. Problems pertaining to the school, or there can be problems from the society. So which are the factors which are intrinsic to the child? There can be learning disorders. There can be problems with the health of the child, or the child can be a slow learner. So when we talk about learning disorders, it is basically there is a maturational gap between the sensory and motor developmental deficits, and this can result in dyspraxia, dyspraxia or gross motor incoordination. So this is written after the diagnosis. This is a dyspraxic child who doesn't have the concept of spacing. He doesn't know to follow the line, and he presses too hard on the writing paper. And when he erases so much that the paper is torn. There is a visuospatial and visuoperceptual functions, and the child has trouble with drawing. Child is unable to recognize the words. There is difficulty in discriminating left and right hemisphere. So when the child is thinking the right, it comes, this all we know that we are more of into the music, rhythm. The child starts to daydream. On the left side, the child thinks in terms of lines, words, and numbers. This we all know. The child having a lack of attention, frontal lobe functions, ADHD. Disinhibition. This was what I was telling. That the mother enthusiastically tells that the child is answering, prematurely standing and answering for every question teacher asks. My child is so bubbly in the class. No. This is the problem the child has. Child is answering prematurely or taking out of the turn. Impulsive the child is. There can be problems with writing, spelling. There can be difficulties solving the problems, language skills, social skill, and problems with memory. There is an intrinsic ability of the child to register this information, and this is lacking mainly. So regarding learning disability, what do you think? This is not simply a thing which is difficult to learn. As I was saying that my child is so lazy and child is so careless that doesn't copy from the board, and I am helping the child from the parent group and doing, no. So when we are labeling the child to be stupid, lazy and careless, it is not so. It is a learning disorder. And it is not a mental illness, and it may not be a teaching technique default. So it can be a hidden neurological handicap. It can be a syndrome. So what are the characters of a learning disability? There can be discrepancy in potential and performance. The child may be normal, average, or an above average intelligent boy. He might be proficient in very many other activities. These boys have reversing letters in common, mostly seen before the age of 7 years. So what is the prevalence? Globally, the prevalence is between 5 to 7%. India has a prevalence of 10%. Boys have the boys to girls ratio is 3:1. This is obvious because maybe the boy is brought to the health facility more oftenly. So LD cannot be prevented, but early identification and remediation can help circumvent the problem. So why there is a learning disability? It can be hereditary. It can be genetic, especially so children with Turner syndrome, Fragile X syndrome, or Williams syndrome. Some endocrinal problems like hypothyroidism or congenital adrenal hyperplasias, we find that this is very common. A very interesting study has been come up from Pune, where the LBW babies were followed up for 6 to 12 years, and then they documented that these babies had learning disabilities. And there is a very big study, a cohort study from Kerala, MKC Nair et al. They had seen that the maternal complications, the mother having PIH or mother having GDM, these babies had a global developmental delay and language issues were much commoner in these babies. So where is the difficulty? The child may not read at all, the child may lag behind the other children, or the child may not be able to read appropriate to his age. When it comes to spelling, the child may not be able to spell regular words or even his name. He may not be able to count numbers. Handwriting might be very clumsy and illegible also, and where the child might be losing the marks in the class. These children sometimes may be confusing the left and the right and forgetful, and this child may not be appropriately using the words which are needed. So mother might be teaching the child at home very nicely, and when it comes to recollecting and remembering and telling orally in the class, the child is not able to find the right word when talking. And when you ask the telephone numbers or this thing, the child may not be able to tell it in a proper sequence. So what will happen? Secondary effects of the child will be that the child will not be able to read properly, and there won't be independent learning. The child will not be able to write. He will be lagging in the class. He will not be able to express in the language, and he may not have much friends. And receptive language difficulty, where the child will not be understanding what has been said. So he would not perform the activity which has been asked from him. So when the child has been asked, when the child comes, such children comes to your clinic, and you tell them to narrate a story, tell us essay, they may not be able to do. Or if you tell that you have been made a leader in the class and asked to do an activity or making a notice board or write something, they may not be able to decide properly, they may not be able to complete that assignment. And as I told before also, the language would be difficult, they may not be able to pronounce properly, or they may not respond properly. The concept only will be difficult for them to understand. So there will be difficulty definitely in comprehension also. So when they walk into the clinic, if you are going to ask them which way you had come, or what are all the signals you caught, or what were the landmark points, of course they may remember the Domino's and the McDonald's, I don't say so, but many times they will not be able to recollect the events. And if you are asking, when you are assessing a child and is lacking, mother may say that the child has not performed well, and you want to say what was your study plan, they may not be able to give that plan. Especially so in the adolescents, when you are seeing, you ask them what was your daily schedule when you are preparing for the exam, they may not be able to give that. So their concentration would be poor, they might be daydreaming, they will be easily distracted, they're poorly organized, and they may not be able to complete the task. So they will have a poor self-esteem, lack of confidence. They may not have much friends, and they may not be able to keep that friendship. They may be difficult in having a social adjustment. So after the learning issues, we think that there can be some problems with the child. Chronic illnesses like your bronchial asthmas, the child having a seizure disorder on AEDs. So this might be the cause for a school absenteeism, and then the child not able to attend the class will impair the neurodevelopment of the child. Sometimes the children might be on drugs, especially so anti-epileptics, and that may cause their wakefulness. They may not be very much alert in the class, and that may be having a school absenteeism, school dropout because of the illness itself. Slow learners are the people who have a good IQ between 70 to 80, but they have a borderline intelligence, so the program for them should be an activity-based learning, and teachers should take time for them to teach. So what can be the issues relating to the family? There can be, this is a big study coming up from Tamil Nadu, where they have analyzed that the abuse in the father, alcoholic father, poor education in the father, and lack of stimulus was very statistically significant in that study, where the child was having a scholastic backwardness. Sometimes the parents might come to your clinics and say, see, doctor, I have put him in the best of the tuitions, and I am teaching, I am forcing him to do it, and still the child is not getting the marks. You scold the doctor. This many would have encountered, that you tell, doctor, you tell how to become like you, and give some tonics. Give some good tonics that the child learns and child performs well. So pressure from the parents is too much, and the expectation is too much. And there can be an other end, where the parents are total negligent. So here comes the word of parenting. So we should not be an authoritarian parent. So as I say, sit at this time, read here and there, you should be going. So it should not be a dictator type of thing, nor you can be too permissive or a neglect parent. So parenting has itself a big session to go. But what I would tell you is, you should be an authoritative parent, where you will be more responding, you will be stricter, but you have a rules, and you will be there for the child, and you will be empathizing and sympathizing with the child. Sometimes there might be separation, and the child is put into the boarding school, especially so for the intermediate preparation for IITs and NEET and all. So they are sent to the boarding school or the hostel, and the child was doing very good, and now suddenly is not doing anything, and they have removed from the star batch to the one step down, and how I have to go. So this can be a complaint with which the parents oftenly come to us. There can be conflicts in the family, constant fights in the family. As I quoted before, parental education and attitude. This was a study done by in Tamil Nadu, and also from Karnataka, Gulbarga, where they have found that there is a scholastic backwardness in children with this. Sometimes schools have a lot of pressure from the curriculum or the attitude of the teacher, very cursive teachers, and lot of homework they will give. You all would agree that even online classes, lot of homeworks and projects are being given, so students are really exhausted doing that school work. What can be the societal factors? The societal factors might be the lack of resources, many responsibilities shrug on the child, or poor nourishment. which can cause a chronic anemia, iron deficiency anemia in the child and causing a scholastic backwardness in the child. Cultural factors can be there, and as all know, gender discrimination is the one which can cause a scholastic backwardness in the child. The government school, especially lack of furniture, toilets in the government school can be one factor. So how to help the child to improve and maximize their academic potential? Demystifying them, identifying the underlying cause, bypass strategies and remediation of the skills. We help the child by strengthening of their strength and counseling the family and individual. Sometimes pharmacotherapy is needed and special schooling is needed for the child. So how do you demystify? You identify the child and come to the terms with their strengths and weaknesses, and this should be done non-judgmental. You should be non-judgmental. You find out the underlying cause and resolve any family issues if they are there, and if you find that there is anemia and all those things, that has to be corrected. Proper nutrition advice should be given to these children. What are these bypass strategies? See, in children with dysgraphia, oral exams can be taken instead of giving them a written assessment. So remediation of the skill, intervention of to strengthen the weak links in the academic skills. GLAD scale, this is a very important scale that is a graded level assessment drive. This is developed by our own NIMH. This is to assess the scholastic skill. This is graded according to the class in which the child is there, and this helps to assess the child. How to do the strengthening of the strengths? So in addition to addressing the weaknesses, the strengths and talents of the child should be identified, and that should be developed, like nurturing the athletic skills or creative talents in the child. Activity-based learning, especially so in the slow learners, we should do. Family counseling and individual counseling plays a very important role in understanding and dealing with the issue together. Medications, if needed for especially ADHD, and special schooling is necessary. Here, nowhere I have mentioned that IQ assessment should be done. That is not a part and parcel of this. Unless there is an intellectual disability, then we are going to do IQ assessment. Otherwise, psychotherapy and counseling play a very important role. So, I would conclude by saying the key messages that scholastic backwardness contributes to school dropouts and causes mental health difficulties, and it's a growing concern. Early intervention based on multimodal approach with involvement of teachers, parents, and pediatrician and mental health workers play an important role. And if the child can't learn the way you teach, teach him the way he can learn. Thank you.
Thank you. Thank you.
Thank you, Madam.
Elaborated
That
very
was-
nicely, Dr. Aditya Nagaraj. Now I invite Dr. Kalyani Srinivas. He is Professor of Pediatrics in Nilafar Hospital, and he is ACVAP member, and he awarded the best medical teacher of Government of Telangana State. Congratulations, sir.
Thank you, sir.
To Dr. Kalyani Srinivas.
Good morning, everybody. At the outset, I thank IAP TCB, President Dr. C.N. Reddy Garu, Dynamic Secretary Dr. Bhaskar sir. Good morning, Chairperson. Indeed, it's a privilege to spend time with you on the podium. My session will be interactive. Our job, as you all know, as a clinician, is no less than a detective. Day in and out, it's an exam for us. And my earnest appeal to each one of you is stick to the basics. Examine every case in detail. From head to toe. As you know, our job is no than ACP Pradyumna. He will ask you, Daya, kuch to gadbad hai. When you have this feeling in your heart, it is a problematic case, you revisit this child. We are no less than a James Bond on the field, and we don't have a gun also to shoot. Always this gun is on us. let's go to my first slide. My salutations to all the frontliners who are doing amazing job. Last 9 months, they have not slept, they have not eaten. They are just in the service of the mankind in this difficult time. People have lost lives, people have lost employment, everything, but doctors, nurses, paramedical, they are on the foot. Kindly accept my salutations. Ladies and gentlemen, I'll just take you through the eyes of the baby, the face, the skin, some part of the CNS. Let us see. My first case, a 2-month infant with anemia, recurrent transfusions, hepatosplenomegaly, mild proptosis is the clue. Any guesses? We have taken an X-ray. Any guesses? Normally, we don't see the bones in a chest X-ray, but this examination of the bones, as you can see, poor corticomedullary differentiation, marble bones, the diagnosis is out. It is nothing less than the osteopetrosis. The diagnosis is very clear. Here, we don't need any test. A simple X-ray, visibility of the bones will take you to the diagnosis. Another case, you can see this 3 months baby with jaundice, hepatosplenomegaly, signs of liver failure on the abdomen, abdominal veins, hepatomegaly, jaundice. A closer view on the eye can pick up a cataract. Most of us, I request to use a good torch to pick up a good, interesting diseases, not with the mobile torch. So eyes are a window of opportunity. Please use the torchlight often, because this is the case of galactosemia, easily treatable. You stop the lactose-containing milk, give lactose-free diet, the child will be all right. So before the liver failure sets in, pick up the glycogen storage diseases, Wilson disease, galactosemia, to prevent the treatable causes of liver cell failure, including tyrosinemia. I'm sure we all know this, but it's an appeal from our side. So the cataract, you can see the baby onto your right. This is a missed cataract, very subtle cataract, which can be picked up by the intuitive, very astute clinician, often miss. This cataract we have picked up, and the diagnosis is very clear. Small baby, IUGR baby. The diagnosis is, yes, our PGs, IUGR baby with cataract, newborn. The diagnosis, yes, you're right, torch infection. So this is a clinical clue here. This child, you can see there is ataxic gait. The child was walking with lot of imbalance, ataxic gait. Once again, the simple clue in the eyes. Conjunctival congestion, dilated vessels in both the eyes, squint in the left eye for lateral gaze. Diagnosis is, this is ataxia telangiectasia, very early form of telangiectasia. With time, it evolves. So as in the natural history of the disease, as an astute clinician, you pick up these signs early. These are all subtle signs. You pick them early, diagnosis will be early. To prevent the next stage of the disease, we can intervene where possible. Another similar case where we have the baby and the mother with telangiectasias. Very rare cases. It took us more than 15 years collection. And as you can see, from the eyes, we are going to the chubby cheeks, dimple chin, rosy lips, teeth not yet erupted, obesity. What's the diagnosis? Yes, PGs? Guess what's the diagnosis? Simple history has given a clue. This baby is on erra chukkala mandu, traditionally used by the traditional medicines people to get these features. So, betnesol induced, that is steroid features. So, simple history in this, the drug history will take us to the diagnosis. We don't need any investigations. Treatment is master the inactivity, stop the drug. If needed, taper the steroid to prevent the withdrawal effects. Now, another case, yes, spot the diagnosis. Anything in the lips? This child, we have taken X-ray. There is a cardiomegaly. Cardiothoracic ratio is increased. What's the diagnosis? Baby has a heart disease. Echo shows AV canal defect. What's the diagnosis? PGs? I want it to be interactive. What is there on the right side of the lip? What is there on the left side of the lip? Yes, I can hear the answer. Absent right depressor oris angular oris brevis muscle. So absent right depressor anguli oris brevis muscle. Here you can see the right angle of the mouth is not coming down. So when the baby is crying, there is a lot of job for us to do. Examination is very easy in a crying child. Auscultation also is easy in the respiratory system. So please don't miss up this absent right angular oris brevis muscle, often associated with heart disease. Some of them could be a cyanotic heart disease also. Another similar case, once again absent right anguli oris brevis muscle. This baby had a large PDA. Going to our next case. What is this? Yes, PGs? Hair. You can see these are the silvery hair. The eyebrows are also silvery. Yes, what is the disease? This has immunodeficiency also. What is the syndrome? Excellent. Griscelli syndrome. We have a series of cases. Worldwide, 205 cases are reported. We have a series, myself, Dr. Preeti Madam, Dr. Srilata, we have published this case of a series of 5 Griscelli syndrome, simply diagnosed by the color of the hair, color of the eye, and the skin hair, and basic investigations. So these children often have immunodeficiency. They have got the tendency to go to HLS. The prognosis is very poor often. They may go on to bone marrow transplantation. These are the cases which you need to catch early to counsel them, prepare for the bone marrow transplant, prepare for immunotherapy upfront. Let's see the video. Yes. Ptosis, excessive cry, irritability. Yes, what's the diagnosis? Ptosis, excessive cry, irritability. See, beautiful people, they got it in their bag. Yes, you can see this is the snake bite. So any child, comatose, irritable, ptosis is the clue. Ptosis is the clue, neuroparalysis is the clue. Ask the history, was the child playing in some courtyard? Take the history properly. You see the baby has improved with timely treatment with, as you all know, anti-snake venom, supportive treatment. So here, ptosis is the clue, history is the clue. Now, let's go to the next. 2 months male infant on multiple anti-epileptic drugs, almost 5 drugs we are exhausted, resistant seizures, different type of seizures, multiple seizures, infantile spasm, basic investigation profile is normal. What's the disease? Multiple anti-epileptics, resistant seizure, all basic reports are normal, only EEG is showing infantile spasm. As you all know, few diseases take time to evolve. In this corona pandemic, when everybody is masked, I had to unmask this mother to pick up the diagnosis. What's the disease? Pages? Yes? In this corona pandemic, mother was with the mask, like all of us do. I had to unmask to pick up this adenoma sebaceum. She also had chagrin patches. I told our lady PG to examine her in detail, and there was a fibroma on the foot too. As you know, the diagnosis is without touching the patient, just a simple glance at the mother, tuberous sclerosis, the drug of choice, vigabatrin, ACTH, prednisolone. You know, even sometimes the MRI may be normal for the baby. So here, without touching the baby, without touching the mother, a simple glance at a look at the mother gives us the diagnosis. No investigations are needed. So, as I told you, in newborn they present with infantile spasm. As the child grows, these adenoma sebaceum develop later. You may be lucky to pick up, but in the newborn, there will not be any clinical clues. Recurrent seizures with EEG or infantile spasms, that's a diagnosis. So all characteristic lesions may evolve later. We have to catch the natural history of the disease at the early stage. This interesting child brought to us with sudden onset of facial puffiness. You can see swelling of the face, swelling of the lips. Diagnosis? Angioedema, right? Here the complement levels are low, C4 are low. Diagnosis? Yes, PGs? Hereditary angioedema, treatable, right? Now, this is a spotter. Case 10, hoarseness, constipation. Diagnosis? About 5 months infant, hoarseness, constipation. Yes, please. What's the diagnosis? Excellent. Congenital hypothyroidism. TSH is high. Spotter for hypothyroidism. But my request to you is, we have to screen every baby for hypothyroidism. This treatable cause of mental retardation. This child was brought in this stage. We are too late. This is also, as you know, hypothyroidism. It is too late to diagnose. Let's ensure neonatal screening at birth. Let's do screening for ROP for all the neonates, for the high-risk neonates at least. Let's do hearing screen for the high-risk babies. Let's seriously increase the use of growth charts to diagnose the causes of short stature. And this is always sitting on our head to avoid the legal issues. This is my take-home message, and this is very clear. Diagnosis, you can see the skin involved, mucosal involvement, drug-related Stevens-Johnson syndrome, because it was involving more than 30% of the body. It is a toxic epidermal necrolysis, carbamazepine induced. So after treatment, baby has improved. Once again, let's use safer drugs, safer for the baby, safer for the community, safer for everybody else. Now, let's see. Yes, diagnosis. You can see ptosis, some involuntary movements. Baby also has hypotonia. What's the disease? Spotter. My tribute to Professor Narasimha Rao garu. Preeti madam is bubbling with answers. So you can see hypotonia, ptosis, and involuntary movements. Leigh disease. Identify them early, treat them early. The incidence of Leigh disease is on the rise. I respect Dr. Subramaniam sir, Dr. Alivalu madam, Dr. Indrashekar Rao sir. It is increasing. It's a clinical diagnosis. Once again, most of the investigations are being done now, but they are expensive. So not to miss this, catch them early. Okay, MRS will give double lactate peak. Here, in the Leigh disease, the mother history is very important. There is a history of consanguinity. Mothers usually don't take non-veg. They are usually veg, and they are from tribal background, especially Surapet, Nalgonda. Many cases are trickling in. We have to catch them early, give B complex, CoQ, etc. The empirical treatment. MRI is not needed. Excellent. So this is a case of hypotonia. You can see tongue fasciculations and poor voice. Audio, are it? It's a case of hypotonia, severe hypotonia, more proximal, more for the lower limbs. You can see the fasciculations in the tongue. If you see carefully, yeah, this took us more than 1 hour to record the fasciculation. Yes, diagnosis? Hypotonia, tongue fasciculations, poor voice. మ్యూట్ లేదు ఫుల్ 100%. So severe hypotonia you are seeing. The case of, you're right, spinal muscle atrophy. There are 5 types, 0 to 4. Classical weakness, hypotonia, areflexia, proximal hypotonia involving more of the lower limbs. The tongue fasciculation is the characteristic feature. Now treatment is available, so it counts, it goes into crores. Studies are on in the clinical trials in our own Nizam's Institute at Hyderabad. The drugs with the nusinersen and supportive treatment, genetic counseling. We have to pick them early, hand over to the clinical trials. Let's see. Yes, there is a swelling. This was referred to us with bronchopneumonia. There is a swelling here in front of the, just above the sternum. What's the disease? PGs, please. Let us make it lively, yes? There is a crepitus. What is the likely possibility? You have a crepitus. Child referred to us with very severe bronchopneumonia, severe RD. Subcutaneous emphysema with crepitus is pneumomediastinum. So you can see the investigation suggestion of surgical and mediastinal emphysema. In fact, this emphysema, the air went into the C7 to D7, cervical and thoracic indentation of the thecal sac. It has gone on to the, it is compressing the spinal cavity also. So this is a very, very rare surgical emphysema, pneumomediastinum, and into the spinal canal also. 2 months infant with focal seizure. What's the diagnosis? Yes, 2-month infant with focal seizures. Left upper limb, you can see there appears to be a weakness and paralysis. Anything else? Child is very dull, very drowsy. Diagnosis? Can you see anything on the chest? Can you see anything here? I'll give you a better picture. Anything here? Diagnosis? Focal seizure, left paresis. What is this? Ecchymosis. Diagnosis? Spotter. You can see these are the skin bleed, ecchymosis, late HDN. This child did not receive vitamin K at birth. Preventable. We need to stabilize this child urgently. Give vitamin K, treat the seizure, take care of the vitals, investigation later. Treatment first, stabilization first, investigation later. Clinically, you know, you are going to get a intracranial hemorrhage. Let's ensure vitamin K at birth. That is our mission today, every day, the whole of this year. This interesting boy, fatherless boy, terrible headache, vomiting, giddiness, increase. He's on 7th class. I've seen him 2 years back. This headache increases 7 years. Just before the exam, every month. Fatherless boy working in one of the corporate hospital, mother, naturally labeled as functional. What I should do at the thigh, what is there? Tickle our brains. He had hypertension, nobody recorded his BP, weak femorals, both. So this is the report as expected, as you all know, severe coarctation of aorta, almost at 13 years of age. I was surprised to see the report. We have cross-checked, and balloon angioplasty was done in one of the corporate hospitals where the mother was working and child was all right. Therefore, the message with this case is examine the case in detail, especially if needed, investigate before labeling any child as functional. So revisit every functional cases. Maybe there is some cause underlying. This is an interesting case. Mild cyanosis. These days of gadget-oriented, evidence-based medicine, SpO2 is 74. Heart rate okay for the age. SpO2 is low, but arterial oxygen saturation is normal and above normal. What's the disease? SpO2 is low, mild cyanosis, arterial oxygen PaO2 is high. What's the disease? Anything striking? I'll give you a clue. Yeah. This is called saturation gap. Means to say high arterial oxygen, low pulse, low oxygen saturation on pulse oximeter. Here we can see SpO2 has shown 74, then arterial saturation is high. What's the disease? PGs? Okay, we have taken their blood
Sir, in the
onto the
interest
filter
of time,
paper.
I request sir to kind of try
Done.
to.
Last slide, sir. Thank you.
Thank you.
Filter paper on the blood. What's the disease? This blood, this appearance, what is the disease? Meth hemoglobin was high. Normally, as you know, less than 1.5. It is high, 33. The case of meth hemoglobinemia, once in 5 years, 10 years, we see. This was given timely treatment with methylene blue, vitamin C. I congratulate our team, Nilofer, Dr. Alivelu Madam, she is here, Preeti, Swapna, Dr. Nirmala, the whole neonatology team from Nilofer. Excellent case. A case of the decade for me. Meth hemoglobinemia, not commonly seen. This season, we use a lot of steam, but be careful. These are the scars with steam. Please take care. Let's be gentle. Follow all the safety precautions. Fire related also. Take home message quickly. A prudent history taking, meticulous repeated clinical examination, pivotal high index of suspicion with proper counseling where needed. Monitor the evolving and unfolding clinical status. Let's be aware of the epidemiology of the prevailing diseases, be it the poisonings, be it the infections. Prioritized and focused examination. Start treatment first, investigate next, at least both parallel. Don't wait for the treatment in clear-cut cases. A dedicated team with a proactive approach, devoting time to the patients and commitment to the patient care, a hawk eye on moving trend from the infectious diseases to allergy, autoimmunity, malignancy, and the ever-emerging lifestyle disease. So on a lighter note, these parents have taught me how to collect the urine sample without the limitations. It is an amazing photograph, collecting the urine, because they have this at home, right? So let's follow the social distancing, mask and sanitizer. Thank you very much for a patient listening. Thank you, sir.
Best cases of 18 Spartas collected from 15 years. Very useful for postgraduates as well as practicing pediatricians also. Congratulations.
Thank you,
Dr.
sir.
Srinivas.
Thank you, sir.
Now I invite Dr. Rishikesh, Assistant Professor of Child Psychiatry. He is a Professor of Child Psychiatry from Nilafar Hospital.
On the sidelines, we've just had the poster presentations being assessed by Dr. Narayan Reddy and Dr. Tilak. And they have just now been felicitated by very senior pediatrician, our professor, Dr. Indrasekhar Rao. Thank you, sir.
Good morning, all. I'm Dr. Rishi, Assistant Professor Child Psychiatry in Nilofer Hospital. We are going to talk about mood disorders in children. I'm going to talk about especially only in children and adolescents, not talking about adults, only adolescents and children. So basically it involves core deficits in emotional regulation. The core deficits in emotional regulation will be very high or very low. If it is very low, then it is a depressive disorder. If it is very high or euphoric, it can be a manic episode. So only emotional regulation will be there. As per Nelson, there are only 2 or 3 disorders described. But if you take in Rutter's or child psychiatry, there are other emotional regulation disorders like ODD, conduct disorders, everything, they come into emotional regulation disorders only. But in mood disorders, we will be talking about here only major depressive disorder, manic hypomania, bipolar disorder, bipolar 1, bipolar 2, and cyclothymia, and their treatment management issues. And here is the graphics. When there is a normal mood, what is mania? When it is very high, it is mania. When it is between normal mood and mania, it is hypomania. When it is normal mood, when it is very low, then it is severe depression. And in between normal mood and severe depression, it can be mild depression or slight depression, or depressive cognition, which not fit into criteria of severe depression. So coming to major depressive disorder, there are 3 main criteria which should be fulfilling to diagnose depression. That is decreased energy or easy fatigability, low mood or pervasive low mood, and decrease in pleasurable activities. These are the 3 primary criteria which should be fitting to diagnose depression. Of this, one should be present. Along with them, decreased appetite, decreased sleep, increased irritability or decreased activity, increased appetite or decreased appetite, increased sleep or decreased sleep, and poor memory, issue with concentration, poor scholastic performances, ideas of worthlessness, severe suicidalization, ideas of guilt, all these come into picture of to fit into a diagnosis. Based on the fitting criteria, if it is 1 plus 2, if it is mild, moderate, severe, can be diagnosed based on the how much symptoms are present. In dysthymic disorder, usually the disorder will be continuous for 2 years period with poor appetite or overeating, insomnia or hypersomnia, low energy and fatigue, low self-esteem, poor concentration, poor decision making, and hopelessness. In this, the overall diagnosis should not be fitting into mania or depression. It should be hypomania or mild depression or slight depression. So it is continuous over a period of 2 years. And to diagnose dysthymia, the illness should be more than 2 years period without fitting into mania or depression. If that fulfills the criteria, probably it is a dysthymic disorder. Usually seen in most commonly borderline personality issues around adolescent age group. Usually see in these cases where they usually threaten to harm themselves, self-disorder, chronic emptiness, what they feel is chronic emptiness, nobody is there for me, and usually starts around 14 to 15 years period and continues throughout the lifetime, if he is going into borderline personality disorder. So this is the new inclusion in DSM-5 criteria. Previously it was not there. It is a disruptive mood regulation disorder. It is basically severe recurrent temper outbursts, which are very explosive and doesn't represent temper tantrums. 3 episodes should be present per a week and continuously for a period of 12 months. Then if it is there continuously, then probably it could be, we can diagnose disruptive mood regulation disorder. It usually starts around an age group of 5 years. It can present as early as 3 years, but at this age group, usually we diagnose opposite defiant disorder. It can present little late, 5 years of age. What the difference between ODD and disruptive mood regulation disorder is, ODD will be, continuous defiance will be there. But in disruptive mood regulation disorder, there will be normal phase for few days, followed by increased outbursts of emotional disturbances, where the child will be very aggressive, verbally, physically, violent, can be violent also sometimes. That's how you can diagnose disruptive mood regulation disorder. The high-risk groups are parents or siblings with depression, exposure to chronic adversity, where history of bullying is there in the school or at home or nearby places, neighborhood. If there is bullying, the child may go into higher chance of going into depression. Previous episodes of depression, if they are there, an early stage of depression, probably in late adolescence, they can present with depression again. Disruptive behavior, substance abuse can increase the depression, can be a comorbid presentation along with depression. Other psychiatric symptoms like anxiety and learning problems can be prone for depression. Deliberate self-harm and suicide attempt. This was I was telling about borderline personality disorder, where usually deliberate self-harm will be present, usually starts at the adolescent age. Any child who is attending to hospital recurrently, previously Srinivas Kalyan was saying, examining thoroughly before ruling it out functional cause. So any child who is presenting with recurrent physical complaints, or sometimes they say they have pain abdomen, sometimes they say they have headache, sometimes they say they are feeling vomiting, sometimes they say they don't want to go to school. The repeated absence of school, repeated physical complaints, all this can be a sign of depression. So rather than neglecting, causing it as a functional disorder, rather than it as labeling us, he's acting or he's doing it deliberately, look for the causes, take the history. If you look into properly simple history, like what will give you a clue is any fights in the family, recent change in the school, or any recent abuse on the child, any abuse. It could be physical abuse or could be a sexual abuse also sometimes. Any abuse of the child or any bullying in the school. If you talk to the child, child will give you a clue whether he's suffering from what. What is it? I've seen so many cases in Lofer coming with a lot of physical complaints. When we see the cases, we think that it's functional. They come with chronic headaches, they come with pain abdomens. The most of the problems will fit into depressive cognition, mild to moderate depressive disorder, basically. So there can be a physical complaints. So once a child or adolescent repeatedly attending a pediatrician or a practitioner could be depression, you have to pick it up. Chronic physical health problems definitely will be a reason for depression and low mood and decreased energy. And multiple physical complaints, as I told you, if there are multiple physical complaints at one point of time, probably it could be depression, especially when the child is below 7 years of age. More than 7 years of the age, children tend to not to complain about these complaints. They pick up more better complaints to present illness. But below 7 years of age, they usually complain these complaints because it is based on the cognitive ability of the child. Below 7 years of the child cannot think hypothetically. Because if I say this, it may go wrong. It may happen like this. My father will react like that. My mother will react like this. He can't think below 7 years. So that's why these complaints will be there. Most of the times below 7 years of age. More than 7 years of age, he'll be presenting more typical complaints, which will be fitting into exactly the illness. He knows how to enact the illness. He knows how to. And I've seen seizures which are actually looking like seizure. So I have seen pain abdomens which are actually pain abdomens. They know when to act, when not to act. Usually we commonly come across history like, మీ వాడు నైట్ లెగిచి ఏడుస్తాడా, కడుపు నొప్పి చెప్తాడా, అండ్ దట్ ఫెలో నోస్ కడుపు నొప్పి ఉన్న నైట్ లెగిచి ఏడవాలి అని తెలుసు వాడికి. 7 years, more than 7 years. He gets up in the night and complains that he has a pain abdomen. To make it more look real, that means he's asking for some help. He's asking some help that he needs something, which parents are not listening. Probably if he comes to us, probably we have to listen more. We have to talk him more. If you want, send the parents out and talk to him for 5 to 10 minutes, then it will give you a clue. Rather than threatening him, most of the times we usually threaten, injection istan cheppu, dark mood వేసేస్తాం, ఇట్లాంటివన్నీ usually doesn't work with the kids. If you start saying that, you will be another parent like them. So it doesn't fit into treating disorders like child psychiatric disorders. So I fit it both into these things, differential diagnosis and comorbidities. When it comes to comorbidities in child psychiatric disorders, almost 50 to 60% of illness have comorbidities. Every autism has intellectual disability. Every ADHD case has SLD. Almost every case. 50 to 60% cases of child psychiatry has one or the other comorbid disorders. It doesn't present with single illness. So there will be a associated comorbid disorders. So what are the comorbid disorders that can present with depressive disorder? Could be autism, ADHD, bipolar disorder, anxiety, trauma-related disorders, stress-related disorders like post-traumatic stress disorder, recent loss of the father, or recent loss of a friend, any exposure to an accident can be an issue. Conduct disorder can be presenting as disruptive mood regulation disorder. Substance use disorder can look like, again, disruptive mood regulation disorder. Neurological disorders like tumors and endocrine disorders. Hypothyroidism especially can look like depression, where there will be decreased energy, low mood, unable to concentrate, poor scholastic performances. As the age grows, he will become more and more lazy. Can be a possibility of depression. So I try to combine both differential diagnosis and comorbidities in this. So when you look for one diagnosis, there will be another diagnosis. As Preeti Madam was saying about specific learning disorder, when she was talking about specific learning disorder will not exist with only specific learning disorder. It can be only, it can be associated with ADHD, it can be associated with depression, it can be associated with anxiety, it can be associated with low intelligence. So once IQ is more than 80 only, then only you can say a specific learning disorder. If it is below 80, you can't diagnose SLD. You can't certify SLD. It should be above 80. Treatment, supportive psychotherapy, especially when the case of mild depression are there, probably you have to look into supportive psychotherapy where we have to sit with the child, talk to him, along with the parents, we have to counsel them to increase the environment at the home rather than the child itself. Because the environment of the child will be only two. It will be school or parents. Half of the time he spends the time in the school, little time in the home. So there should be problems either in the school or at home. So if you look into these issues, probably it will help you to pick up where it is. So probably you have to talk to the parents, help them understand why the child is behaving like that. Then probably they'll learn how to manage the child. Cognitive behavior therapy, it is very higher form of therapies where we use, in case of mild to severe cases, as a first line of therapy or as an augmentation therapy. In this, the negative cognition will be there. Negative to self, negative to environment, negative to others will be there. Where the child will be thinking that, నేను వేస్ట్ నాకేమీ రాదు, వేరే వాళ్ళందరూ నన్ను వేస్ట్ లాగా చూస్తున్నారు, నాకు జరిగేదంతా తప్పు జరుగుతుంది. సో ఇట్స్ అబౌట్ నెగిటివ్ టు సెల్ఫ్, నెగిటివ్ టువర్డ్స్ అదర్స్, నెగిటివ్ టువర్డ్స్ ఎన్విరాన్మెంట్. ఇట్స్ లైక్ దట్. ఇఫ్ ఇట్ ఈస్ దేర్, then probably you have to, somebody looks at him, I'll give you an example. If somebody looks at him, he thinks that, వాడు నా గురించి ఏదో మాట్లాడుకుంటున్నాడు, నా గురించి ఏదో తప్పుగా అనుకుంటున్నాడు. That's what he understands. Negative to others, negative towards attitudes towards others happens. That is basically a negative cognition, what is going on in his mind. Basically, that fellow is not thinking about him. But that cognition is changed in CBT. They have to understand that cognition, make him understand there is a very long procedure to do a CBT. It's not very easy to do. There will be homeworks, there will be tests given, they should understand what should be done. And it's almost a 15-week session. It took almost 6 months to improve the child. So CBT can be augmentation therapy. And interpersonal therapy, when there are problems, especially in adolescence, problems with siblings, problems with peer group, problems with the teachers, improved communication with them can help you to improve the interpersonal therapy. Medication, the approved medications are all, as you know, for depressive disorder, FDA approved or SSRIs, most commonly fluoxetine is used, can be used as early as 6 years of age, and more than 12 years you can use sertraline and escitalopram. Only FDA approved are fluoxetine and escitalopram. Fluoxetine you can start as early as 5 years to 6 years of age at 10 mg, wait for 2 weeks, severe improvement you can make it 20 mg, maximum dose you can go up to 30 mg for that age group only, and wait for the improvement, and side effects should be monitored. The most, at that age group, the most common side effect will be gastritis and vomitings. No major side effects will be there. But if the child has any history of saying that I have severe suicidal ideation, or I am trying to kill myself, what I look in a child, when we see a child of depression, if below 2 years old child, if he says that I want to die in any situation, it is a serious issue. So when you are giving fluoxetine, what happens is, it increases the urge to kill themselves. That side effect will be there. That's why there is a black box warning given for US FDA, where if you are giving a tablet of tablet of fluoxetine, you have to monitor the child for early suicide. The urge will increase because there is increased energy because of suicide. Previously, there was only idea is there to commit suicide. Now it gets into an action. So that happens with fluoxetine. So basically, escitalopram can be given. Sertraline after 2 years can be given. Other additional drugs are there, new drugs are there, that can be given in adolescence, and mostly these are the common drugs which are issued. Coming to bipolar-related disorders, bipolar 1, bipolar 2, cyclothymic disorders, bipolar disorder NOS. I skipped bipolar disorders NOS because of the 15 minutes I can't cover the whole mood disorders. It is very difficult to cover, so important disorders I try to cover. Symptoms of manic episode, here there are elevated mood, increased self-esteem and grandiosity. The self-esteem is so much increased that he says that he can beat anyone, he can be a collector, he can be a prime minister, he can be an IAS officer next day, he can talk to KCR, he can move PM for doing so many things, he can discover vaccine for COVID. The grandiosity can be that much extent. Decreased need for sleep. This is very important thing. Decreased need for sleep. Basically, if somebody doesn't sleep, or for 2 or 3 days, they'll fall little irritable and all those things can happen. But in these cases, though they don't sleep, they'll be as active as they have slept for almost 12 hours. They'll be very, very active, very talkative. Pressure of speech will be there. Right now, what I'm having, racing thoughts and flight of ideas, where they usually, flight of ideas is something where when they are talking something, to give you an example, if I'm talking about my job, I'm a doctor, I'm a pediatrician and as well as psychiatrist, I'm working in Nilofer Hospital, I see a TV there. A TV lo em program vastundi, then he starts shifting. That's a clue for him. That's flight of ideas. From here to, he'll shift there. From here to, he'll shift to the lights. From there to chairs. That is basically the flight of ideas, which is present in severe manic episodes. And goal-directed activity will be there. Increased sexual drive will be there. Psychomotor agitation, excessive pleasurable activities, and poor judgment behavior. This is the basic difference between manic and hypomanic episode. Poor judgment behavior. This symptom should be present for more than a week and causing personal, social, and occupational dysfunctioning. This can be sometimes present whenever you achieved something. This manic, elated mood, ecstasy can happen for some time, or day or two. If I get off from the stage, now I feel ecstasy that I have presented. That I'm not manic. But if it is present for more than one, and if it has dysfunction in personal, social, and occupational dysfunction is there, then only we can diagnose mania.
Sir, we are, in the interest of the time, I request you to look at summarizing, sir. Thank you.
Okay, hypomanic episodes, this is same as mania episode, but judgment is not affected. The performance will be increasing. Cyclothymia is the same. 2 years of illness will not be fitting into hypomania or manic episodes. Summary of graphics, severe mania. I told you what it is there previously, the same thing. In bipolar illness, you can see the graph. There will be episodes of severe depression, one episode of mania. Then only you can call it as bipolar 1. Bipolar 2 is severe depression and hypomania episode. Though there is no mania episode here, only hypomania episode. Cyclothymia is hypomania and slight depression episodes. There is no manic episode, there is no severe depression episode. This is a graphical representation, you can easily get it. Differential diagnosis, same ADHD, ODD, borderline personality disorder, substance abuse, neurological conditions, medical conditions, and medications. Treatment, pharmacological management is the mainstay of treatment. Second generation antipsychotics, aripiprazole, risperidone, quetiapine, below 10 years and 12 years, more than 13 years, olanzapine is advised. Lithium is one of the drug which is more safer, but you have to monitor for the side effects, can be given after 12 years of age, and have all the RCTs which are required. It is better for mood stabilization, anti-suicidal property, works in both bipolar and as well as depression. And observe for the comorbid conditions, because I told you, all the cases will have one or the other comorbidities. If there is a comorbid condition, you have to treat it, otherwise there will be a lapse. Thank you. Thank you for the opportunity. I am the student of Dr. Indrasekhar Rao, sir. I studied under pediatrics in 2003 and 2004 when he was HOD. And grateful to Dr. Bhaskar sir for giving this opportunity, and IAP TCB also, and my teachers from pediatric department. Thank you very much.
Thank you.
Thank you,
Thank
sir.
you. Almost all we are facing every day such cases, whether it's functional or disease, difficult for doctor and difficult for counseling parents also. Thank you, doctor. Very well explained. Now, last topic is not a physical, virtual. Dr. Srinivas Jakka is a senior pediatrician in Ankur Hospital.
He is going to join us
He trained in
virtually.
allergy in UK and extremely is passionate about his teaching. Now,
Sir, I started sharing. Can you see my screen?
Just please be online. Yes, we can start the talk, Dr. Srinivas. We are able to see your slides. Thank you.
Sir, am I audible?
Yes, yes.
Okay. At the outset, I would like to thank IAP TCB and Dr. Sunkosh Bhaskar for giving me this opportunity. I'll try to stick to my time. We're going to talk about asthma mimics in children, or the conditions that can mimic asthma closely. So when we see children with recurrent wheeze in our clinic, we are faced with the questions: does this child have asthma, or could it be something else? Do we need to start this child on treatment, or can we wait and watch? So I have made it very simple. The diagnosis of asthma. Whenever we see a child for the first time in the clinic, we don't need to definitely give the parents a diagnosis of asthma, because as we know, there is no definitive diagnostic test for asthma. Rather, we can tell the parents the probability that the child can have asthma. The probability can be low, intermediate, or high based on the factors that suggest asthma or the factors that suggest alternative diagnosis, the so-called red flags. So we'll be mainly discussing about these red flags in our talk today. So as we all know, the factors that suggest asthma are the characteristic symptom complex of cough, breathlessness, and wheeze. Wheeze, which is noted by parents or documented by physicians, is particularly important. The symptoms are usually episodic in children. Chronic symptoms are less common. The variability of symptoms is very important. It can be a diurnal variation or seasonal variation. And the variability can be confirmed by spirometry as well. Atopy in the child and family is very important. And response to therapy, either by reliever or control medication, will confirm the diagnosis. And this is from the GINA guidelines. And we recently did a study on 250 wheezing children. And these factors hold good for our population as well. Coming to alternate diagnosis, any cause that can cause narrowing of your airway can mimic asthma. That can be in your bronchial wall, like airway malaisias, bronchiectasis, or compression from outside due to a mass or lymph node or anomalous vessel, etc. It can be a problem with your airway lining, like cystic fibrosis or ciliary dyskinesias. There can be problem in your lumen, like a foreign body or endobronchial tumor or TB. There can be protracted brachial bronchitis, which is more and more recognized condition. There can be aspiration during feeding or swallowing or aspiration of reflux material. And others, which are actually more common or recurrent viral infections, tuberculosis, upper airway problems, congenital heart disease, and immunodeficiency states. So we need to watch these conditions which can closely mimic asthma. So what are the red flags that can suggest alternate diagnosis? In the history, symptoms present from early on, from birth or newborn period, or from under 1 year of age, we should always be cautious and suspect other conditions. When there's a family history of unusual chest problems, then again, we need to suspect cystic fibrosis or neurological conditions. When there is severe upper respiratory tract disease, we need to suspect ciliary problems or immunodeficiency states. Persistent moist cough. Typically, the cough in asthma is dry cough, but if the child has persistent moist cough, we need to look at cystic fibrosis, bronchiectasis, and persistent bacterial bronchitis. Excessive vomiting, we need to think about reflux. Paroxysmal bouts leading to vomiting, we should think of pertussis, although post-tussive vomiting is common in asthma as well. Swallowing difficulties, we need to think about any swallowing problems, especially neurological problems, children with neurological problems. Associated with lightheadedness and peripheral tingling, we need to think about panic attacks and dysfunctional breathing, which we are seeing more and more in this current lockdown phase. Stridor or abnormalities with the voice or cry, we need to think about laryngeal problems. If there are focal signs in the chest, we need to think about congenital anomalies, bronchiectasis, tuberculosis, etc. Finger clubbing is very important. All children with chronic asthma or symptoms unresponsive to treatment, please look at clubbing, and that will give a clue to cystic fibrosis or bronchiectasis. Usually, children with asthma, there is no failure to thrive unless it's a very severe uncontrolled asthma. So if a child with asthma or suspected asthma is failing to thrive, think about other causes like cystic fibrosis, reflux, and immunodeficiency disorders. If there are focal or persistent radiological changes, we need to think about congenital anomalies, cystic fibrosis, and other conditions as well. And I will illustrate this with few case reports which we saw in our clinic recently. First is a 6-month-old baby diagnosed as bronchiolitis at 2 months of age. However, unlike what is expected, the baby continues to have persistent wheeze since then, treated with several courses of antibiotics and bronchodilators without much improvement. And when we saw this child, the child had mild retractions and diffuse monophonic wheeze. So the red flags in this child are early onset of 2 months of age, persistence of wheeze, not responding to the treatment, and a monophonic wheeze. And whenever we see a monophonic wheeze, we need to think about some problems in the large airways. So went on to do a bronchoscopy in this child, and you can see that there is some tracheomalacia, which is not very clear in this child, but there is a right bronchomalacia. So this child has tracheobronchomalacia. Coming to the next patient, we have a 6-month-old baby early onset of symptoms from 2 weeks of age. The child had recurrent episodes of respiratory distress for which the child was admitted and treated as recurrent pneumonias. When we looked at the chest x-rays, the baby had a varying patchy infiltrates bilaterally. Outside, the child underwent a bronchoscopy and CT chest, which was normal, again treated with antibiotics and bronchodilators. When we went into details of the history, there was a history of vomiting since birth, varying from small posits to large vomits associated with poor weight gain. And when we asked the mother how the baby is in between feeds, there was a history of arching, stiffening, clenching of fists, and drawing up of legs. All these symptoms are worse on lying down posture and improving in upright posture. And this gave us a clue that the baby couldn't have a reflux. And we did an upper J contrast study. The baby had a severe reflux. And we treated the baby with anti-reflux medications and anti-reflux measures, following which the baby improved. So this is a child with GERD with aspiration. Recently, we saw an 18-month-old child, sudden onset of cough for 2 days without any prodromal symptoms. She was treated with antibiotics and bronchodilators by the pediatrician for 1 week. There was no improvement after 1 week. So this is the first chest X-ray, and then the pediatrician repeated a chest X-ray after 1 week. As there was no improvement, he referred for second opinion. So we repeated a chest X-ray in our clinic, and then this shows asymmetrical findings. There's hyperinflation on the left side with a mediastinal shift, and there's a focal segmental collapse, atelectasis. So this gave us a sudden onset of symptoms with no prodromal symptoms, and this asymmetric findings gave us a doubt that this could be an inhaled foreign body. And we did a bronchoscopy, and this showed aspirated peanut in the left bronchus. Okay, and this was removed by a bronchoscopy. So this is a child with a foreign body aspiration. The next case is an 8-year-old female child, recurrent episodes of cough from 2 years of age. Again, used several courses of antibiotics and nebulizers without much improvement. Tried on a steroid inhaler for 6 months. There was no response to that. And when we saw this child in the clinic, the mother gave a history of wet cough with expectoration. And on examination, the child had clubbing and bilateral prattles. When we checked the sputum, there was a growth of Pseudomonas and Staph aureus. And when we did a CT scan, you could see that changes of bronchiectasis. When we did genetic studies, there was a mutation called DETA-F508, and that gave us a diagnosis of cystic fibrosis. The child currently is on treatment for CF, and the child is doing reasonably well. However, unfortunately, the child has developed bronchiectasis. This is an interesting case. Recently, we saw a 2.5-year-old child, poor weight gain from 1 year of age. The child was treated with nebulization every 2 months during colds and coughs. However, for the last 6 months, the breathlessness got worse to the extent that the child is breathless even at rest. It's an interesting family history, first degree of consanguinity in both parents, history of TB in paternal grandmother. The first child is admitted to the hospital starting at 2 months of age and then admitted several times for recurrent pneumonias. Unfortunately, the child died at 9 months of age due to pneumonia. Third pregnancy, mother was noted to be anemic, and there was intrauterine death at 9 months gestation. The fourth is our current child, and the fifth child remains well. So the red flags are poor weight gain, no response to treatment, worsening of breathlessness, which became persistent now, and it's breathlessness at rest, and there is a strong family history. So when we saw this child, the child was noted to be hypoxic and tachypneic with retractions. The chest X-ray, first chest X-ray, there was a diffuse ground glass appearance, and the CT scan shows extensive ground glass appearance with septal thickening. And we did a bronchoscopy, there was a milky fluid, and it was positive for PAS staining. The child underwent whole lung lavage. This is X-ray after that, and there is significant improvement in symptoms. And genetic testing showed a CSF2RA deletion, and the diagnosis was a pulmonary alveolar proteinosis, the genetic variant. So, summarizing, this is the most important slide. We know that the factors which favor asthma, but we need to think about the factors that favor alternate diagnosis, being the early onset of symptoms, persistent symptoms, especially the wet cough, no documented definitive wheeze, no history of atopy, no response to treatment, either a reliever or a controller, severe upper respiratory symptoms, excessive vomiting to what you expect in a normal child, failure to thrive, presence of clubbing and cyanosis, and focal signs on examination or radiology. However, This sounds very easy, but several difficulties in diagnosing asthma in the clinic. Why is the difficulty? Difficulty is because asthma is not a uniform condition. It's a combination of varied combinations of cough, breathlessness, and wheeze. And the predictive value of individual symptoms is poor. So we need to take the symptom complex as a whole. Many times there is a lack of parental awareness in symptom recognition, especially with regards to wheezing and breathlessness. Lack of resources, and the most important is the time. And the diagnosis of asthma and ruling out of the alternate diagnosis requires a lot of time in the clinic. And for my first visit, I take 40 to 45 minutes. And lack of resources like spirometry and other testing widely. Then the lack of documentation, whenever we see the children, they get with recurrent episodes, there is not enough documentation about the presence of wheeze or distress or response to treatment, which makes diagnosis difficult. And then there is a reluctance for diagnosis of asthma from the parents, and hence we as pediatricians are also reluctant to give the diagnosis. Therefore, the take-home messages are, asthma is still the most common condition causing airway obstruction. However, there are many other conditions that can cause obstruction of the airways and can mimic asthma. And these asthma mimics or alternate diagnosis can be identified by the red flags. And for that, a detailed history and systematic approach is essential. And prompt recognition and referral will ensure optimal outcome, not only for asthma, for all, but also for the alternate diagnosis. And whenever we see a child with asthma who is not typical or not responding to normal treatment, we need to look from a different angle and rule out the alternate diagnosis. And the saying, all that wheezes is not asthma, still holds good. Thank you once again.
Thank you so much, Srinivas. That was very lucidly presented with all those X-rays as well. Very, very, very educative for all of us here in the auditorium, as well as people who are virtually watching it over at home. Now I request Dr. Rangaya and all the 4 speakers from this session to kindly come on the side stage for felicitation. I request Dr. Surendranath to kindly come. Dr. Anil Tiwari, kindly felicitate our speakers and chairpersons. Now we will start the next session. For the next session, firstly, I would like to request Dr. Indrasekhar Rao sir to kindly come up on the stage. Sir has been professor and superintendent of Nilofer Hospital. Currently, he is the director and head of department of pediatrics at Navodaya Hospital. He is very well known to everybody in the state. So I request him to kindly come up to moderate a very interesting panel discussion on response protocol and approach towards outbreak of a mysterious illness in community. 12 to 15 months back, Corona was a mysterious illness. Recently in Andhra Pradesh, we had a mysterious illness. So we do look forward to getting guidance from our seniors. In case such a situation comes up, what do we do? What kind of precautions we take? What kind of interventions we take? And for him, the panelist is also extremely eminent. I request Dr. Narasimha Rao, Dr. S. Narasimha Rao, Dr. GVS Subramaniam, Dr. E. Arjun, and Dr. Alimelu to kindly join him on the dais. A very eminent, very senior teaching faculty we have on the stage with us to ponder on this topic and give us their advice. Sir, kindly take over.
This one. IS Rao, sir.
Forward idika. One second.
Forward, back. You can use arrows as well.
Which is the forward?
Forward, back. Back and let out.
Thank you.
2 minutes లో నేను అక్కడ వేసేస్తాను.
Good afternoon, all the delegates and the senior professors who are here, who are at their homes watching today's scientific programs. Friends, we worked together for long 26 years in the IAP TCB to make our conferences successful. I have a nostalgic memory of doing second IAP TCB at Gandhi Medical College in 1996. From medical colleges, we have moved to 5 stars. Nevertheless, the quality and academic dedication is increasing. Friends, the changed world has taught us many lessons. Nevertheless, the interest in academics has not reduced. Therefore, we are still here. I congratulate the scientific team and the team of IAP TCB for doing it so excellently. I also have an appreciation for the scientific committee for mysteriously choosing a topic for all the seniors and very seniors. Probably they wanted to do something magic, or they wanted to give us as a consolation rehabilitation topic to discuss. I really don't know. I met Ajay Mohan, he said, no sir, you are the experts. Friends, when we discuss here, we recall our rich experiences of 3 decades about the mysterious illnesses which are occurring and how we solved it in those days and still how we are doing. It's my pleasure to introduce esteemed colleagues, my professors, Dr. Narasimha Rao Garu, who was once together with me professor at Nilofer Hospital and presently is a professor on HOD at Komaneni Hospital. He also served as HOD of Pediatrics of prestigious Nilofer Hospital. My friend Dr. Subramanian Garu, a senior academician and foreigner, he worked in Kakinada for long years. Then he was former superintendent of Nilofer Hospital and now he is a professor at Bhaskara Medical College. Welcome you, sir. Waiting for your rich contribution. Dr. Arjun, the dynamic Arjun, as the name says, is IAP TCB member, very active. He has been our postgraduate, I know, and now he is managing director of Apurva Hospitals at Hyderabad. Last, the lady I am telling is dynamic, most loving Alivelu Madam, who is presently the professor and head of the department of neonatology of our Nilofer Hospital, and she is doing the good, great work. So all of us in next few minutes will tell you how the mystery and how we did it, your attention. So what is a mystery? The dictionary meaning is what is something strange and which is not known and not has been explained or understood, beyond one's power to know, to understand or explain. It is also beyond the ordinary thinking. Why mystery occurring? Child well, after 2 minutes child is not well. So this is life. For all of us also, we have seen with the COVID, life is a mystery, and now mysterious illness, whether it is man-made, divine, or it is a nature's fury showing on the human, whether what is happening. At this point, before we proceed to cut the ice, I want experience, spirituality, and science to ask Dr. Subramanian Garu, what is your perspective on the mysterious illness, how it evolved, and is it human or nature interaction causing these illnesses which we are seeing last 30 years?
Thank you very much, sir. Good morning, everyone. I thank the organizers for giving me this opportunity to be a panelist of this elite group. The most important questions what sir was asking me now is about these mysterious illnesses. So if we want to break the mystery, we have to get back to the history. So that's what the people say. But once it comes to these mysterious illnesses which we are coming across and is making media waves, which many a times there is a lot of public panic associated, there is a pressure from various circles, and the professionals are put to difficulty also because of these crisis situations. So we need to know a little bit about this and how, what could be the reason. So getting back to the conventional teaching of what we call the epidemiological triad of agent, host, and environment, we know the various agents, they do exist in the nature. They may be physical, they may be chemical, they may be biological, or whatever it is, the agents are there outside. Next comes the host. Host is also becoming more and more susceptible because of changing lifestyles, increased amount of stress the individual is subjected to. He is becoming more vulnerable irrespective of the age. Of course, the classic example being the COVID, which is not sparing any age group. We have come across the host. The worst part of it, but the most important thing all of us should consider is the environment. So what I personally feel is, once it comes to the environment, I can say one word: the man is in the midst of the disease. He is not outside the disease. He is in the midst. Literally, we are all submerged in a sort of what we call some sort of pollution, maybe pollution outside or pollution within. So what I wanted to say is, we need to make an introspection of what is this environment. I take it an external environment, which can be a physical, chemical, or biological environment, what may be there outside, which can act as a source. And let me clarify, these are all not watertight compartments. We must say, when there is an external environment and internal environment, they are in constant interaction with each other. We try to isolate ourselves because of self-identity. We try to identify ourselves separate from the environment and consider everything outside as a possibility. But actually, we are in constant touch and is in constant interaction with the environment by all means. Say, for example, the air we breathe in, the water we drink, the food we eat, everything is liable for contamination. These contaminations will not leave at that stage, and they enter into the system and they cause internal pollution also. So there is nothing like, practically speaking, the environment which is outer, which is we are virtually in contact. Every cell, every organ, every part of the body is in constant interaction with the environment outside. So therefore, these definitions or categorizations are merely conjectural, but not the real. So this point I wanted to tell. So regarding external environment, the technological advances which we have made, all these, I don't say our profession has not contributed to the development of what we call the various public health aspects of it. For example, we as pediatricians were in the forefront in terms of preventive pediatrics, say for example, immunization and other aspects. But there are certain areas which have happened over a period of time in the mankind where the attention is paid more to the external rather than to the internal. So this I wanted to highlight. The technological advances, we are so much fascinated, therefore we are more concerned about the development outside, but we have forgotten what is the development inside. I feel this point I wanted to bring it home to all of us. Because suppose if I wear a green colored glasses, I try to see the entire world in green color. So therefore, I feel whatever spectacles I wear should be transparent enough so that I can see better what is happening without a colored vision. So therefore, it is as important as to clear internum as that we feel that the environment should be pollution free. So in this context, let me admit that many a times man has paid attention everything to which is around to himself, but not to himself. That is the problem. So therefore, if he were to be considered what he is, if he has understood what he is, he would have had a better harmony within himself. So unless and otherwise an individual is in harmony within himself, he cannot be harmonious with environment. I feel, I can say most of the times, the present day man is not in a position to regulate his own thought process or emotions most of the times because of the situation and the stressors that are there in the outside. So the first and foremost, we all need to pay attention to become more conscious, more aware, and what exactly is there in what is happening within, with a tendency to introspection, so that we try to know what is our position and how we can relate to environment, so that we will be better able to handle the environment outside. So this is what I wanted to tell.
Thank you, Subramanian Garu. A question to Dr. Narasimha sir. Your experience at Nilofer Hospital regarding outbreaks of mysterious illness. Sorry, the wrong format has been loaded and we are correcting it. Start telling, sir. I have sent a different one. They have loaded a wrong format.
Good afternoon. We have now talking about my experience in Nilofer Hospital. Hope you are able to hear me. It is fine and nostalgic to me because my stay at Nilofer spanned over almost 3 decades, and there were many ups and downs. The Nilofer Hospital was quite demanding. The workload is such that it was quite demanding, both physically, mentally, and spiritually as well. No, if you recollect, in 2003, there was an outbreak, mainly affecting entire Telangana. In the month of May, there was an uproar in the, then an assembly session which was going on. There were few cases reported from Karimnagar. The children around 5 years of age were dying. And based on the information, then the combined government of Andhra Pradesh has constituted an expert committee. Rightly, it has constituted an expert committee. And the message was also communicated well to NICD, National Institute of Communicable Disease, New Delhi. And then we also started receiving cases around 5 to 10 per day with the features of acute encephalitis. Age group was around 5 years, and mortality was very high. It was varying from 48 to 49%. More than, almost half of the children were dying. Then, and over a period of couple of days, expert committee with the help of NICD, they zeroed down that it was Job B encephalitis, which was causing havoc. And it was announced in the newspaper. And then, since I was in charge of emergency services, including PICU those days, then somehow we, the faculty, Indra Shekhar was in second unit, and Dr. Murali Mohan was in head of the department, and then there Vikramjit Singh and Tilak Chandra Paul and myself. And Kalyani Srinivas were our assistant in ESR. Then we all met together and then started analyzing the case scenarios. And we came to a conclusion, it is not Japanese B encephalitis, it is something mysterious. We were not knowing exactly what it is, if it is not Japanese B encephalitis. Because those days, if it is any encephalitis which is occurring as an epidemic, it was always thought to be Japanese B encephalitis, excepting in 1 or 2 years, they thought it is non-exanthem measles. Then the same thing we made, because Murali Mohan was that time the principal and the additional director, who have communicated to the government. Sir, this is not Japanese B encephalitis. We would like to your audience to hear our voice. They have listened to us, and they have communicated same thing to NIMHAMS Pune, and then NIMHAMS Bangalore, NIV Pune, and NICD. It was also escalated to CDC Atlanta. Ever since then, the team of the team, they were visiting Nilofer Hospital. And they were convinced. They were convinced that it is not Japanese B encephalitis. But the question is, what it is then? But we were not in a position to suggest the alternative diagnosis. But we have given, at the request of the government, how to manage these encephalitis cases. The booklet was published. However, it took about 2 to 3 years for the NIV and NIMHAMS and NICD to thoroughly investigate viral etiology and also other etiologies. Finally, they have concluded that it was caused by Chandipura virus. And the same thing we have published, and that is missing, we have published because...
Dr. Narasimha Rao, I will be showing it, sir. Just give me a pass, I will show that.
Okay.
Thank you. We had a very rich experience of the Chandipura virus, the dramatic those days. Investigations were not so easy, but we coordinated, Nagabhushan Rao, myself, and Narasimha Rao, and Tilak, and all of us. We did excellent diagnosis. The old format was loaded. I beg your pardon for that. We'll just go back, and I'll tell Dr. Subramaniam, give you a perspective. This is the first slide for him. Our environment is our life, and sir, quick, sir.
Thank you, sir. Our environment is life, and if environment is not properly handled, we tend to be in the midst of the disease that I already told. So one thing what we hear, because we are too much fascinated about what we see around rather than by our own selves. So we think, so therefore we are not in a position to be in a harmonious relationship with the environment. So the harmony between the environment and the individual is very much important, but we focus more. So in simple words to say, if we are too much fascinated by frills, we fail to see the frog. So that's how it has happened. So we fail to look at, and therefore what I personally feel is the internal environment is more important such that we will be able to maintain a harmonious relationship with the outer environment.
Thank you, sir. Yeah, Dr. Narasimha, please take over.
Sorry, sir. So, a couple of sentences. Japanese bee encephalitis usually affects substantia nigra, and there is characteristically involvement of basal ganglion. What we have seen clinically, every one of us, sir used to make visiting rounds to ESR. We have found that there was characteristically brainstem was involved. And brainstem, consists of respiratory centers as a vasomotor centers, and this virus which has got a tropism to them, and it was knocking down their respirations. And that was the cause why there was high mortality. And our treatments were not really very effective. And that we have published and in the Journal of Tropical Pediatrics. Apart from this, I could come across in Nilofer Hospital some little or unknown entities, which were, I would say rather, they were little known about these entities. What are they? They are related to thiamine deficiency. Because those days, thiamine deficiency was not very well emphasized. The reasons are two. One is Nutrition Foundation of India more than once declared categorically in UN that thiamine deficiency is a not problem in India because of controlled milling of rice. Other one is textbook description was always dry beriberi, wet beriberi. Wet beriberi is a beriberi of Anasarca, which is Shoshan's beriberi. But there was no description about encephalopathic beriberi or cardiomyopathic form. And somehow we had a very good team in Nilofer Hospital with my assistants and other colleague professors. With the collaboration of CCMB, we could thoroughly investigate them and then conclude that one is encephalopathic beriberi mimicking as Leach's disease, mimicking as Leach syndrome. Other one was cardiac beriberi, which was presenting as pulmonary hypertension, often misdiagnosed as primary pulmonary hypertension and treated with sildenafil. And we have done such an extensive through the, in collaboration with CCMB and Nilofer Hospital, that for 256 patients, both mitochondrial and a nuclear gene analysis was done. Entire genome was done. And we could isolate a novel genes in the mitochondria and also in nuclear genes. And this was found only in encephalopathic form, not in cardiomyopathic form. And our conclusion is there is a genetic tendency for them to manifest with encephalopathic form. These are the three, little or mysterious diseases. We were thrilled. And our team was so enthusiastic. I know our postgraduates used to visit my house. We used to sit in my house and they draft the, analyze the data and they draft the publishing paper. So the message is, the good old saying is, please remember, good old saying is, eyes will not see which mind does not know. I would say, eyes would see, don't allow eyes to see only what mind knows. So I would say you have to just look, you have to just see, and then compare with your repository, your memory, which is your mind. Then probably you would come across, you would identify some new forms of manifestations of old disease or new disease itself. Otherwise, you will be struggling, you will be always trying to fit into what is in your repository.
Thank you, Dr. Narasimha Rao Garu, for narrating in those days how difficulty was there and how we investigated forward in these diseases, the Lays, Beriberi, and Chandipura virus. Now, a question to Dr. Alimelu. Those days she was an assistant professor. After she has become a professor, she worked in Nizamabad and now at Nilofer Hospital. She also has vast experience of the disease occurring of mysterious conditions. Will you please take 10 minutes to tell it,
Thank you so much, sir. So, good morning, everybody. So, it's my proud privilege to be here on the stage. This is a memorable day for me. I've missed my teachers and whom I think as legends, Dr. I.S. Rao sir being the moderator, the Subramaniam sir, Narasimha Rao sir, and as a student, I had worked so much under him, and of course, Dr. Arjun, who's so famous in his private practice. So thank you TCP for giving me this great opportunity. Thank you so much. So this case scenario, like this incident that occurred on December 4th, is more like not a mysterious disease outbreak, but this is to emphasize that what a great team can do. So, and I am grateful that Team Nilofer did such a great job on this day, from that day itself. And along with the public health organizations, our DIO and the JDCHI, who collaborated with the needed information to manage these cases. On December 4th, I remember it was around 3 p.m. in the evening. There was one 2-month-old baby, a 6-week-old baby, who was admitted with sudden feeding difficulty, dullness, and developing encephalopathy, was choking on feeds. And this baby was brought to the ESR. And after that, another second case. Within about half an hour or 1 hour, another case. Then another case. Almost all less than 2 years, all infants. And they almost have the similar scenarios of drowsiness, encephalopathy, and seizures, and immense respiratory depression, which was worsening on phenobarbital, which was given as a treatment for seizures. And my PG there, I remember Dr. Srivatsa telling me it was strange that there was a rigidity of the chest wall. So when they're trying to intubate because of the respiratory difficulty, there was a difficulty in the chest rising. So this was a very important clue. And by evening 8:30 or 9, we came to know there was some mistake in the vaccinations given at a center very near to Nilofer, and almost 47 admissions immediately in the next 48 hours occurred with very similar scenario, and the rigidity of the chest wall was an indication that this was a serotonin syndrome. So the weakness, vomiting, nausea, drowsiness, and the rigidity of chest, including the seizures, were all serotonin syndrome. So this came to, after a little investigation, it was known that instead of a paracetamol tablet, which was routinely given after the vaccination, was mistakenly given tramadol. So they were 300 milligrams tablet of tramadol Unfortunately, the paracetamol and the tramadol packing was very similar, the same light blue colored and the same white tablet inside. So the sister, whoever gave it, did not read that it was tramadol. She just broke the tablets without seeing what the medication was, and very, very high doses were given to these infants. So if you look at the scenarios, most of them were less than 2 months and 2 to 3 months. So these were all the very, very young children, very, very young infants who were given the 6 weeks and 10 weeks dose of DPT polio, the pentavalent vaccines which are given at Nampally, along with the rotavirus and the polio vaccines. And the maximum of them, if you see the presentation, there was hypotonia and seizures with the other symptomatology of serotonin syndrome. And with great difficulty, naloxone was brought to the emergency room. And to say that what great teamwork can do, not only all of the professors, pediatric postgraduates, assistants, and including our anesthesia team, which there was an SR, I remember she sat down very closely monitoring the baby. She used to give naloxone, looking at the pupils and also the respiration and the monitoring the heart rate. And dramatically, you won't believe the improvement. As soon as naloxone was given, the eyes which were all closed would open and the baby would start breathing normally. So treatment was so dramatic, and that was an experience, and it taught us that what a great teamwork can do. So kudos to the Nilofer team. And thank you. And there another experience at Nilofer Hospital, which was actually what I had seen at Nizamabad. So if all of you remember, during about 3 years back, there was the government policy was to stop all toddies, all illegal toddy production and sale was stopped. So at that time, at Nizamabad, we had literally about 150 adult patients who were being admitted with alcohol withdrawal syndromes. And we somehow strangely had some encephalitis-like cases in pediatric ward which were presenting to our casualty. So these cases, actually, I just kept looking at these children, and they were all very young. Actually, some of them were just hardly 1.5, 2 years. And when I see the babies had an encephalitis, seizures, altered sensorium, very irritable, very sweaty, and very cold peripheries. So I was thinking they were hypoglycemic, but sugars were not very low for them to have that sweating. They were around 60, but not below 60. So we were wondering what this was, and then when I kept asking the grandmother the history, I remember that child was hardly 16 months old, male child. I kept asking her, did you give any medicines, and edana mandu ichava? Mandu ante? Then she said, yes, I gave a medicine. I said, what medicine do you give him every day? She says she gives him toddy every day morning before she goes out to the work, because the child has to sleep, the mother had died. So that's how the history came out, so the importance of history. And the toddy was something that the child became dependent on. So it was an alcohol withdrawal symptom that presented at altered sensorium and seizures. And there was one more case scenario which we saw in Nilofer. Again, this was an 8-year-old male child who presented with altered sensorium and seizures. On history taking, again, I came to know that he was taking more than 100 ml twice a day since the last 4 years. He goes with the grandfather, he goes to the field and has toddy in the morning. And if I remember, Dr. Subramanian sir also attended. We presented this case in the PESH, that is PESH's Pediatric Epilepsy Society of Hyderabad, where all the neurologists were surprised. They were giving me the diagnosis of NMDA receptor encephalitis, which is very typical with psychiatric manifestation. But this was
Dr.
again...
Alimelu,
Thank you,
for an excellent narration of a magical events of toddy, inhalation, tramadol, etc. These are historical. In your Nizamabad time, you have seen children being administered infants with some medicine, and they reflected in the radiological findings.
Sir,
will you please tell on that?
Just half minute, sir, with you. Just one.
Go ahead.
As Madam said, about 4 years back this has happened, and the message to House is, whenever there is an unexplained illness which will not fit into any of the known syndromes, and where there is a scope for involvement of more systems, most of the times we may be labeling it as a mysterious illness, as we have been seeing in the media recently also. But most of them, they will have underlying toxic syndromes. Many a times these toxins, if they tend to influence, in this case, in the instance case, madam said, the parents were admitting, we used to give liquor to our children. Most of the times the liquor was added with kicking agents like chloral hydrate and others also. This child, because we could not give it for the first few days only, has developed this restlessness and other things. Some of them were about to be intubated also. The fellow used to kick the doctor out and jump out of the PICU also. That's how they presented. Most of the children were aged between 5 and 10 years. There was literally a case clustering of about 5 to 10 cases in PICU of Nilofer. What I mean to say here is, whenever there is an unexplained illnesses, and all the children, they tend to present with the same type of symptoms, let us suspect it could be possibly due to toxic cause. Just I wanted to confirm.
Thank you.
Sir. Thank you. So this, again, a very interesting X-rays. Can you see something abnormal in this? Dr. Preeti and Dr. Kalyan Srinivas, who were with me in Nizamabad, have also been instrumental in picking up these cases. Can you all make out? Those are not artifacts. That is mercury installation. It is mentioned as para in their local language. They believe that giving mercury to these infants and children, that it acts as an antibiotic and it prevents repeated respiratory tract infections. So they give this either through the nose or through the mouth, thinking that this will make them stronger and they'll fight out the infections. So we found these, if you look in the chest X-ray, it's become finer. Because as the baby started to breathe, it broke. It's a liquid metal, isn't it? All of you aware. It's a toxic metal that has broken down and given a starry appearance in the chest X-ray. And if you see, this baby's stomach still has the mercury. So we would easily miss this out. Again, very detailed history taking. This helped me because actually I remember the grandmother telling me that she had given me, the child was given para. And since then, the child's respiratory distress worsened. So, and when I insisted on what para was, she gave me her mobile and made me talk to their local pediatricians from Nizamabad again, where that person told me para would mean locally that it is mercury. So they go and buy it as tulam from the person who does the goldsmith. So they buy it as tulam and put it into the baby's mouth, thinking that this is protective. So what was unfortunate is even educated people from good family also do this. So we had to make them aware that this is a very toxic material. And we've taken even our ethics committee.
Thank you, Dr. Alimelu.
We'll be doing research on this.
The very interesting narration of instilling mercury into the nostrils causing pneumonitis and things. Very, very nice, interesting we have. Another interesting episode I will be asking. Now, we have seen so many epidemics. Another thing, Babu, that we have seen farmers' children in Muzaffarpur, early morning, they have no food. Parents will be working in the fields. They consume the lychee which is produced there. By afternoon, they are drowsy, and again, they are going into convulsions and coma. It is a lychee encephalitis. Computer. So I ask a question to Dr. Arjun to elaborate on this incident of mysterious illness which has caught the interest of the media and the government attention. Hundreds of children were admitted in the hospital. Some of them died and some of them recovered.
Thank you, sir. At the outset, let me thank the team PEDICON TCB for giving me an opportunity, and thanks to the mentors who are sitting here. My message may not be out of live experience of handling a mysterious illness, but nevertheless, every pediatrician has to be well-read and well-informed about what's going on in the country. So as you know, you must have read in the papers in 2019, this particular illness which is known as lychee encephalitis, otherwise known as chamki bukar in local language of Bihar, where it was there in 2014 also. In 2019, major mortalities have happened, and close to 150 children have died of lychee encephalitis, or otherwise known as hypoglycemia encephalitis. As sir was saying, typically the poor children were starving overnight and glycogen stores were depleted. Again, the the other alternate pathway was invoked, so further leading to the starvation ketosis. But the lychee consumption, because that is the only staple food available, and as they were working in the lychee orchards, so that contained MCPG, that is methylene cyclopropyl glycine, which is more hypoglycemic. So this caused further hypoglycemia. Of course, the teams that have investigated have found that this is not the entirely main reason for it. Child has to be malnourished, child has to be having a starvation, then excess consumption of lychee fruits. So this particular toxin was causing hypoglycemia, resulting in encephalitis. And by the time they could investigate and find out the reason, nearly 150 children were they died. And similar thing that is happening in Jamaica and other African countries where ackee fruit consumption was also noted to have a similar form of illness. I want to say that any mystery illness is like a medical thriller unless it is fully investigated. And most of these mystery illness, either they are viral induced or because of ingestion. So like the injections which are causing what has happened in our Nellore district. But most of the things are all neurotropic viruses like Nipah, Zika, or our own COVID. So the policymakers as well as every physician, if they watch the movie Virus, that will clearly depict how to investigate a mystery illness. In fact, it's almost a lifelike situation they've depicted in that movie, how to investigate a mystery illness.
Thank you, Dr. Arjun. We will go into the investigation part little later. Now, Dr. Most recently in the media, there was so much of flare, publicity, breaking news, all attention is deviated only towards the epidemic or the episodes which occurred in Eluru. Will you please give briefly, sir, and also tell how we should go forward regarding the media attack on the doctors after narrating the Eluru incident?
So this was another mysterious illness that caught the attention of the public in the recent past. We all have witnessed for about nearly 72 hours. There was continuous calls in media, everyone was focused on the Eluru only, including WHO, because we are in the midst of pandemic of COVID. Naturally, once there is an outbreak of something or some mysterious illness is to be there, naturally it draws the people attention as well as media attention also. So all the patients, nearly several hundreds of the patients in a span of around 48 to 72 hours, they were affected with neurologic symptoms, and most of them presenting only the features of altered sensorium, seizures, and also some had loss of consciousness also. And as per the media reports, they themselves were telling they could not recall what has happened to them. But the great fortune or blessing of this event was there was no mortality. We all should remember, if there were to be mortalities in any illnesses like this, it creates a big panic. It presses the public panic button. And it is very difficult to handle the media as well as public, as well as from the, we'll have pressure from the policymakers also. So we must be mindful of that. Fortunately, in the instant episode, there were no casualties or there was no mortality. Only one incidental death was there, but that person did not die because of this problem. That's what it was reported. So coming back to, so this was a classic case where the patients had typical neurologic symptoms and several were affected, and all the age groups. In fact, to some extent, children were more affected. As they say, the children are more vulnerable for lead poisoning and other heavy metal poisoning, probably. So this was the case. And most of the children who were admitted were again discharged safe and went home. So this clearly shows there is outburst of cases, especially from one geographical area. We need to be mindful. Frankly speaking, when we were students, I think we have missed several measles epidemics and others. We must admit that. So it is high time a clinician cannot compartmentalize himself from the public health officials. He has to take the details from which area the patient is coming from and what symptoms he is presenting. And same type of cases were presenting to the emergency department. There is a need to inform the public health authorities. So in this instance case also, they took all the precautions. Government has taken all the initiatives. They were very careful. And most of the patients were affected, but they recovered. What I mean to say is, there was tendency, because media naturally they will be more enthusiastic to give sound bites to the public. They come and ask for our opinion. We must be little guarded and must exert constraint before we draw any conclusion clinically. Suppose initial investigation did not throw light, if we immediately say it is a case of a functional disorder, it looks awkward for us at a later stage. What I mean to say is, we have to exert restraint while managing the media. I think Valvelu Madam will be enlightening us how to handle the media and other things in our later point, and we must be careful. Thank you.
Friends, a take-home message at this point, Nilofer experience for all of us, media persons will be always hovering around day in and day out to create some sensational news and put in the print media and television. As a hospital authorities, or in the individual private hospital setting also, any sensation, please restrict the entry of the media. Let not every person to talk, the ward boy, the nurse, coordinator, etc. Please identify a spokesperson of the hospital. That is what we have done in Chandipura. We made our RMO room, it has our media room, and identified spokesperson, either superintendent, HOD, or any other professor, will take the notes from the department meeting and present it to the media, and same thing will be forwarded to the government. This is very, very important to create, not to create misunderstanding, not to bring down the government reputation, and also to request the government to do properly. This is very important. At this point, I will ask, this my thing, how we should respond. Part 1, we have seen from the experts, the Chandipura virus, the Lace disease, Eluru episode, para, and so many intoxication, so many incidents. But now, COVID after COVID appearance, our mind has changed. Anytime, with changing lifestyle, the family atmosphere, access of children who are at home to so many things, they are likely to get the mysterious illness. Now, having identified these with the expert panel, I must say one tribute to my mother hospital, Nilofer Hospital. It is an ocean of diamonds and corals, no, material. When we work there, when we learn there, it is for the eternity, and we are giving academic knowledge to the medical fraternity. You have seen all the testimonials and the works our doctors have done. Now, when the response protocol, what should be the approach? When a new thing today evening, all diarrhea may be coming to Nilofer or to the Gandhi or somewhere. What is? Be alert, identify a team, quickly identify, take action, and do follow up as per the standard operating guidelines. Identify the outbreak, organize the response to disease outbreak, investigation process initiate immediately, 24/7. Epidemiological investigation should start. Communication, which next slide I am asking Almelu. Data maintenance, what you do, government will not. Data making, now the technology, entry the data into the internet, and laboratory coordination. Our hospital may not have all the laboratory investigations, coordinate with other parallel laboratories and start the epidemiological investigations. Review the whole process after time, maybe every day, and then go forward. Be alert, quickly identify, take action, and take the follow-up action. As head of the team, Dr. Narasimha Rao, I will identify outbreaks and organize response to the disease outbreak. In the case of Chandipura virus case in Nilofer Hospital, from a file photo.
Thank you, sir. I think I should narrate my experience at Gandhi Hospital. When there was an outbreak in 2009 in a slum called Olakpura, I was heading the Department of Pediatrics in Gandhi. As I narrate what I have done, what we have done as a team of the department, I think we'll just specifically point out what we were doing at each stage. One morning at 9 o'clock, in the year 2009, I think one of my assistant professor who was on night duty came to my room and told, sir, there were plenty of gastroenteritis cases admitted last night. Then I went along with him to the PICU and saw it was full. Then what I thought is I should call my colleague Professor J.V. Rao and also other assistant professor, Nirmala was there, and Usha was there. And we have had a meeting, departmental meeting. And then they also saw those cases, and we have identified and defined what is the case. So we had to do a case definition. And then having done that, then we have discussed what are the strategies and the logistics. In that process, we also made arrangement to collect the data, to document the data, which includes demographic data and clinical as well. And then we have got, at the request, superintendent has given one secretarial service to put them on Excel sheet and start analyzing them. Then we have drafted what is the protocol, what should be done to these cases. And we have isolated them in a separate ward, and then we have indented extra IV fluids, extra medication, and also put a request for extra nurses. And we have drafted more postgraduates to be on duty. And also requested superintendent, he has obliged that laboratory services should be available 24/7, because those days it was difficult in government setup. And all those things were done, and then we have given a written report to the administration of the hospital. They in turn escalated it to the government of Andhra Pradesh, and the government of Andhra Pradesh has, without any red tape, has taken timely action. What were the action? One, they have updated our department of virology in Gandhi Hospital. Gandhi Hospital, there was a virology department. However, it was not very well functioning, but they have updated it. And then the government has identified Fever Hospital as a nodal center for virological identification, or the cause to age identification. And the government, in turn, has passed on the information to the central government, and then National Institute of Communicable and Enteral Diseases, Kolkata, was made involved. And they have visited us. And we have totally treated around 196 cases, if I remember correctly. And that photograph is one of those photographs. It was taken in PICU when we were dealing with this outbreak. And the team from the NSCDE, they appreciated us. The only thing they changed was, because we were not knowing etiology, we were giving Taxine, parenteral. They told, sir, it is not likely, that is not necessary. Start azithromycin. We have started azithromycin. Meanwhile, Fever Hospital has identified this is the cholera LTOR. And then it was an outbreak. Totally, 196 cases, none of them have died. And then one of the Sunday, our department, along with me, and the HOD of the SPM, Dr. Shastri, we visited the slum. And in the slum, we have visited the houses. 1 minute, sir. Households. And there were plenty of illegal tanning industries. Those effluent from tanning industry, they were going into the drainages, and drainages where water was seepaging into the drinking water, which were laid down just adjacent. And that was the cause. And this report we have prepared with the help of Community Medicine Department and submitted to the government. And the government has, after a couple of years, it has repaired those drainages and pipelines. And these were the things which we have done in a Gandhi hospital. I think they hold true even now. Thank you.
This is a live narration of how things occurred in Bolakpur, how entire pipeline which is getting connected with sewerage is changed and saved the lives in the slums. Now, a quick question to doctor. Now we have completed everything, only logistics and how to go forward, take home message. Subramanian Garu, will you please initiate outbreak investigation? Quickly tell us 1, 2, 3, 4 for how we should go forward.
So it is a high time we should realize we should work in tandem along with epidemiologists. We cannot stand in ivory towers. we need to work whenever there is an outbreak, we need to inform, we have to report it. As clinicians, what we need to do is we have to arrive at possible clinical diagnosis, possible provisional clinical diagnosis. We may not reveal it to press, but we should have a working label. We have to assign a working label. We have to go ahead with the management, out of which the most important step would be one of providing supportive care. But we may need additional laboratory support. Toxicological screening many times may be needed. I told you one of the most important problems where the community gets affected is usually the toxicology screening may not be done. Naturally, it will take time. In these recent episodes also, they took nearly 1 week time to give some report about it. So therefore, toxicology screening may be needed. And we need to work along in the terms of data collection and also data analysis and interpretation, also along with public health. And we need to suggest advocacy to just now, as SR said, he has visited the spot. So that's called what they can do the spot mapping. They have to make a spot diagnosis where the problem is there. When there was a GE epidemic, I was called in to give an opinion there. And there also, all the children were affected mostly. The water lines were contaminated with sewerage lines. Luckily, Madam Poonam Malkondaya was there as West Godavari district collector at that time. She was a microbiologist. She has taken water samples and already she had formulated her own opinion. What I mean to say is, if we apprise the administrators and policymakers also the possible causes, naturally they try to do the necessary intervention at the earliest point. So therefore, we should not think that as clinicians, it is not our job. Sometimes unless we go to the area, we may not be able to identify the problem. So therefore, we need to work along with epidemiologists in identifying the problem and trying to find a solution. The most important thing is one of communication. Sir has nicely told, the concept of spokesperson is very ideal. It avoids all problems. Otherwise, it appears as though the doctors differ and patients suffer. So that situation should not arise, each person speaking their own content. So there should be a consensus, one statement, one official statement should be there, that is from the spokesperson. Communication is very, very important. Communication is not alone with outsiders, but also within the department also, among ourselves. Co-professionals also, we need to communicate in a meaningful and an effective manner. And of course, we have to exert restraint while dealing with media, which tend to be more sensational rather than sensitizing. Thank you.
Friends, off the line, what is your success? Your success is your communication. How you are communicating. In your home, how are you communicating with your wife, spouse? That is, makes a difference in your attitude. How you communicate with your friends. How you communicate with the patients and the parents, being in the medical profession. The communication is very, very important. The art of communication with the body language and feeling. Truthful, be tactful. Apart from that, coming to the infectious disease or outbreak, communication of documentation. Whatever you document in the hospital, be it nursing home, be it general hospital, documentation is what everybody will see and it has a legal validity. And so also, documentation of what you discussed with the people, this is a dictum. Communication of documentation and documentation of the communication. May I request Madam Alimelu to tell how the communication system she established and what is the role of media and spokesperson in a hospital.
Thank you, sir. So like sir has mentioned, whatever we give, even a small mistake from our side can be like a simple slip of tongue can become sensational. So it's very, very important, and especially the young doctors, young pediatricians should be aware that even though we are handling the case, we shouldn't be directly talking to the media. There should be one identified first spokesperson from a hospital or an institute or a hospital. So at any time that only one person talks about it, and we select that first respondent who will give us we better select somebody who will give us the just to the point note to the media. And maybe a second respondent just in case the first respondent is not available, but anytime it's just one person who speaks all the time. And he responds with just basic details, like so many cases of diarrhea have been admitted since morning so and so. So that would be that's the enough basic details to be needed, no speculation. So like we recently saw in Elur. So we heard somebody talk about another virus, another drug, and some mysterious again an illness. So such kind of speculation shouldn't be given. only unless we are sure of about anything, the cause. And the case is noted. We have to tell them the clear number of the patients that have been admitted and clear details about the investigation that have been sent, and simplify the technical information, not too many technical jargons. This will confuse them and there is a scope of misinterpretation. And the last one, the most important one is telling about the government role. So that's very important to tell what the government is taking, the action that the government is taking. Thank you.
Day-to-day interaction with the government is so essential to update the government, particularly Department of Health and Secretary Health, about what we are doing, and requesting them to visit to the facility, which we have done all these things. Thank you, Dr. Almelu. Now, coming to our organization, IAP, what is the role of IAP in spreading the public awareness, giving health education through TV and media, and community confidence and not to become panic in the parents? How IAP should act? Dr. Arjun, will you please elaborate?
Sir, even before the print media comes and informs the public, as everybody is having a smartphone in their hand, the parents themselves upload the video clips and make it viral on the WhatsApp or other media. So now we have to take this dimension to our account, where the social media has become the first respondents or first information, and also making it viral and causing panic. That is when the print media says, okay, this is the breaking news. And as you know, that causes a lot of panic and anxiety. It's a moral and professional duty on the part of IAPN or a pediatrician to allay the anxiety and reduce the stress of the family, because the family trusts your family physician, that is your friendly pediatrician. So as a golden duty of every IAPN to give correct information and also try to give some guidelines how to react, how to prevent. So, and IAP can play a bigger role by preparing short video clips or giving a press notes, or at least counsel the gatherings, the parental groups and other groups. So IAP has got a larger role to play, and also, as you see, I've been requesting UNICEF, WHO and the government also to involve IAP in every kind of disaster management of any mysterious illness or any kind of, pandemic or epidemics that are coming time after time. And let me submit to you, at Apurva Hospital, we've taken it on as a responsibility to treat about nearly 500 COVID patients just on a video consultation, and barely 10 patients were admitted. We didn't have any mortality, because those days in July, August, September, you saw the COVID was literally causing so much of panic, and people were resorting to suicide and whatnot, and they ended up spending crores of rupees. So, and irrespective of whether you are a pediatrician or a physician, to respond to any epidemic, everybody was responding. Like the gastroenterologists were responding, the CT surgeons were responding. I thought pediatricians are no less. We are better equipped to respond to any epidemic and allay the anxiety. We did our bit, and I'm sure in the days to come, IAP will play a bigger role, and every pediatrician should take it on themselves. Thank you.
Thank you, Arjun, for telling involvement of our private pediatric doctors and their hospitals in the community management of a mysterious illness. If it has some first reported to them, and then subsequently they should identify and choose when they should refer to a tertiary hospital, when they can manage, start investigating at the peripheral level. Very nice point. Thank you very much, Arjun. Now, this is for me. Friends, these outbreaks occur, panic occurs, media flares. In the news, we see breaking news. But nevertheless, India is in the forefront of our preparedness for any panic in the health grounds. We have ICMR, our country's prestigious organization, the dedicated network of the institutes. We have National Institute of Virology, Pune, with which we all had an excellent interaction of this thing, culture of the virus. We had National Infectious Disease Laboratory at Calcutta, Primate Breeding and Research Center at Maharashtra, Microbial Research Genome Valley at Hyderabad, then again the All India Institute of Medical Sciences, and so many other institutes have been added. So India is always prepared, and we are doing an excellent work in being alert number one, being initiating the process of investigation, being identifying the special illness whichever is occurring, and quickly we are giving. We are the leaders and pathfinders for the whole globe. Closing remarks, friends. Events and experiences in the past have shown that new microbes will come, new microbes or new elements will come, and again will emerge and cause heavy toll of life and financial burden, which we have seen in the last 1 year. How much of financial burden? Families have been down. There is no income. Economy is down. And this is going to happen. And challenges will occur every time at home or in the nation. We being the citizens, the challenge is very much for it. We can effectively meet by strong national commitment, not to criticize and be with the government decision, strengthening our health system at our level and skilled human resources, training, in-service training. For example, for the COVID vaccine, the training is going on, dry run is going on, alertness is going on. From 5th, we are giving the vaccine. That shows the India's preparedness and India's alertness, and we are all should be part of that. Last but not the least is intersectoral and inter-country cooperation. Now we have an excellent inter-country cooperation. We have seen lively with the COVID preparation and COVID management, classification, and also prevention with the vaccine, Oxford vaccine, and also from the Russian vaccine, several vaccines. This is the inter-country cooperation. When a crisis comes, all of us should come up like a family. That is Jagadaika Kutumbikam. That is a saying in our ancient history. True to that, we should do it. Closing remarks. It's a great opportunity and a challenge for all of us sitting here or listening to this, and protect and save children. Why are we doing all this? We being a pediatricians, we are the custodians after mother and father of the children. Anything happens to children is our responsibility, and we should do. IAP or government hospital, medical college teachers or pediatrician, we should do it together, come together and do it. I thank IAP for giving this opportunity for a senior professors. I thank audience for thing. Any 1 or 2 questions to the learned faculty you can ask after this. Thank you very much.
Thank you, sir. That was a very, very extensive coverage of the topic of how to respond to an unknown disease, a mysterious condition in the community. Friends, on the stage, we have at least 150 years of pediatric experience in front of us. Can we please give a standing ovation to our stalwarts, our professors, who've done so much service for the community that we can't, this is just not enough respect that we can give to them by just standing and giving them a standing ovation. Thank you so much, sir. I now request our panelists and our moderator to kindly come on the side stage for some honors. I request Dr. P.S. Murthy, sir, to kindly come and felicitate our eminent speakers from the stage. Thank you. For the next talk, we have another 2 stalwarts coming up as chairpersons, Dr. Yashwant Rao, PATS General Secretary for 2019 and 20, and Dr. Garlapati Lakshman, who's been the President of PATS for 2020. I request you to come up for a keynote talk, Key Attributes in Choosing a Right Pneumococcal Conjugate Vaccine in Day-to-Day Practice by Dr. Surendranath. I request Dr. Lakshman to introduce Dr. Surendranath, sir, as well.
రాలేదు ఇక్కడ ఎన్రేగా
Shall we start? So, Dr. Surinder, are you ready?
Yeah.
So I welcome Dr. M. Surendranath, pediatrician, President PATS 2021, Vice President ID Chapter CIAP, is a member, active member of AC VIP, and is a current HOD Vijay Mary Hospital. I am honored to welcome Dr. Surendranath for this session. He is my senior in school and in the college and in the service and in the practice and in the academy. I am honored to welcome him. Today is going to speak on key attributes in choosing right pneumococcal vaccine in day-to-day practice. Over to Dr. Surendranath.
Good afternoon. Vaccines are given just to prevent the disease. At the same time, the transmission of disease should be curtailed. The idea of giving vaccine is the personal protection, and at the same time, it should also reduce the transmission of the diseases. Coming to a pneumococcal conjugate vaccine, it is not a vaccine of a single bacteria. Don't think that it is a vaccine of single bacteria. It is a cocktail of 10 bacteria or 13 bacteria. Not like a COVID vaccine, you are attacking only one virus. Here we have about 90 serotypes of pneumococcal bacteria, out of which 15 to 20 serotypes do cause the pneumococcal diseases. And the disease spectrum is also, it is not one disease. It attacks lung, it attacks ears, it attacks brain, it attacks blood also. So a different spectrum of diseases are there reported with the pneumococcal bacteria. So when you are making a vaccine, you should take as many serotypes possible so that you can give a good coverage. In fact, it started as a 7-valent vaccine. After 7-valent vaccine, what happened is, so whatever the serotypes which they have included, the disease has come down. The serotypes which are not included in the disease have gone up compared to the diseases which are caused by the serotypes in the PCV7. Following that, they had to add some more bacteria into that. They made PCV13, and now they are making PCV15, and in future, within 1 or 2 days, we may see PCV20 also. So, you think that this is a vaccine with multiple bacteria in that. It is not a single bacterial vaccine. So, that's where what happens is, whenever you use some 13 bacteria, for example, in PCV13, there are some other serotypes which are likely to increase the incidence. So, the research is essential to include as many number of serotypes so that we can cover as many number of serotypes which are causing the disease. At the same time, one more thing is important. The epidemiology of the country is also you have to take into consideration, because in some countries some serotypes are existing, in some countries some serotypes are existing, and there is a lot of research went on which countries the serotypes are essential to be included in the vaccine. When you take this into consideration, so it is always number of serotypes in the vaccine has a definite advantage over limited number of serotypes. So with this introduction, yeah. With this introduction, we'll just see what are the attributes when you choose a vaccine for a pneumococcal bacteria. So whenever you choose a vaccine, you want to give the best to the patient. At the same time, you want to prevent the transmission of the disease. I'll just go through them. As I told you that pneumococcus can cause otitis media, pneumonia, and meningitis. So one bacteria, you can prevent all these diseases. Not only that, within 2 years after the birth, most of the babies will have pneumococcus in their nasopharynx as a carriers. So this carrier state also should be reduced. Otherwise, what happens is these pneumococcus can be transmitted to the older age group, above 65 years, who are death rate and morbidity is mostly seen in the either older age group or less than 2 years. So we need a vaccine for less than 2 years. At the same time, when you give a vaccine we should also reduce the transmission of the disease by reducing the nasopharyngeal carrier state. Because these carriers are the persons who transmit the disease to the older people in their house, and above 65 years, those are affected whenever there is nasopharyngeal carrier state is there in the infants. So our vaccine should also cover to reduce the nasopharyngeal carrier state in infants. In turn, a herd effect is seen, and above 65 years, people are also protected. So during this my talk, I'll just see PCV covers broad spectrum of the disease burden, and mere serotype differentiation to a broad disease coverage, does it hold any relevance? Is a PCV impact that extends beyond pneumococcal disease prevention desirable? Or a PCV in the National Immunization Program, what character of the vaccine you should take into consideration? And what places does the heritage of the PCV hold? We have the PCV since last 21 years. In fact, this is the 21st year that pneumococcal vaccine has been introduced into the market. Initially, it was PCV7. In 2011, PCV13 came into the market. Now we have 3 types of PCV vaccines available in India. 2 already we know that one PCV10 is there. Another new PCV10 has come into the market. I think it is going to come in today or tomorrow into the market, which will be available for the usage in your clinics. And the PCV13, which is there almost since last 10 years. So when you see the serotype coverage, so PCV10 doesn't have 6A, 19A, and 3 serotypes are not there in PCV10. And the local, our Serum Institute, they also have 10 serotypes in their vaccine. They have removed 3 serotypes which are there in the PCV13. They are serotype 3, 4, and 18C. So the maximum number of serotypes covered are because of the PCV13. As I told you, I have already explained you what vaccine has to do. The vaccine has to prevent the disease occurring in the lungs and in the ear. And at the same time, it will also prevent meningitis. And it should also reduce nasopharyngeal carrier state, which indirectly reduces the disease burden in the older age group. So this is the disease spectrum. You can see otitis media, we see a lot of cases, but we never bother about the prevention of the otitis media, though morbidity has been described whenever the infant has a bilateral otitis media, the patient may go into the deafness also. So recurrent infections of the ear are never taken seriously by us. But prevention of otitis media is also very important. At the same time, pneumonia, we all know that pneumonia is one of the dangerous disease which is increasing the under 5 mortality. Almost it is the front runner for the mortality of under 5. Meningitis, we do see the incidence has come down after using the vaccines. And bacteremia, less than 3 months children, they may have a bacteremia which we are not able to detect because we don't do cultures routinely. So let us see the disease burden. When you select the vaccine, disease burden should be there. So then Streptococcus pneumonia is the leading cause of vaccine preventable pneumonias in less than 5 years. We all know this. And total number of severe pneumonias are reported about 25 lakhs and about 4 lakh deaths are there. Apart from Hib and influenza, Streptococcus pneumonia is one of the major cause of preventable pneumonias in under 5. And the mortality also, case fatality is highest in the infant age group. In fact, almost 20% of the death rate has been reported whenever there is an invasive pneumococcal disease is there. And meningitis, we know that in infants how morbidity exists, and a lot of the people who recover also, about 58% of patients experience residual effects of the IPD. Same way, extreme age group, that is above 65 years or so, the most of the deaths occur because of the invasive pneumococcal disease in 65 years. And the case fatality is highest even in the extreme age groups. As far as India is concerned, we are almost contributing about 25% of the pneumococcal deaths in the all over the world. So we are the leaders even in the pneumococcal deaths. And in Indian picture, the meningitis study which has been conducted in the multicentric trial, what they have shown is almost 82% of meningitis are caused by the Streptococcus pneumonia. Rest of the 20% are because of the Hib and Neisseria meningitis. So highest prevalence is observed in the 1 to 11 months of age group. So this is the age group which is most important, and the vaccine is required for these children. And this study concluded that the burden of bacterial meningitis among the children under less than 5 years is highlighted, and predominance of Streptococcus pneumonia as an important etiological factor has been reported. And pneumonia also, number of episodes of pneumonia, almost about 36 lakhs in India. And deaths also 3.5 lakhs occur every year in India. Otitis media, this is in fact most ignored problem of the children in fact, because most of us not routinely use a otoscope in our clinic. We are likely to miss only on a clinical basis, most of the times we treat. So the prevalence is almost 30% in children, whoever has a nasopharyngeal carrier state of the pneumococcus. And bilateral acute otitis media is seen in almost 70% of children who have pneumococcus in the nasopharynx. So once you prevent the nasopharyngeal carrier state, we can definitely prevent the otitis media in these children. So almost all the serotypes have some disease pattern in fact. The 3 serotypes which are not there in the PCV10s, serotype 3 is one which causes necrotizing pneumonia and empyema. And at the same time, serotype 4, that is invasive pneumococcal disease and outbreak serotype. 18C is also outbreak serotypes. So what does it mean? Outbreak serotype means that serotype, nasopharyngeal carrier state, will not be there. Whenever that serotype attacks any child, there may be some outbreaks because they don't have immunity against that serotype because they don't have that pneumococcus in their nasopharynx. So almost outbreak serotypes are 1, 4, 5, and 18C. These serotypes, though they cause the disease less, but at the same time, they can cause outbreaks. So prevention of these serotypes is also important. And as I told you, 4 and 18C are there only in the PCV13. And as far as the serotype coverage is concerned, we all know that almost 65% of coverage is for the PCV10s. And the new PCV10 about 70%, and with PCV13 it is almost 80%. This was a study which has been published in the WHO position papers, in fact, which has shown that in Asia, serotype 6A, 19A, and 3, all put together, it is about 5 to 6% incidence is there. So presence of these serotypes in the vaccine definitely will prevent the most dangerous disease which is caused by the 19A. This was the Indian study which has shown that out of microbial resistant serotypes which are existing in India, almost PCV13 covers about 90% and PCV10 about 72%. So coming to the effectiveness of 13-valent vaccine again as the serotype 3. People say that serotype 3 PCV13 is not effective. So they say that whether the serotype 3 is there in the vaccine or not doesn't make any difference. But there are some studies which have shown that even the serotype 3 effectiveness has been reported in some of the studies. But overall what they say is the effectiveness is not that much because of the thick walled capsule for the serotype 3. But there are some observational studies which have shown that almost reduction of 60 to 70% even for serotype 3. This was a study which has shown that there is some effectiveness against the serotype 3 also. So coming to since last 20 years, after introduction of the PCV vaccine into the market, there is enormous reduction of invasive pneumococcal disease in wherever it is in the national immunization programs. Almost 30 to 40% reduction of pneumonia is there. Wherever there is national immunization program, it is there. Acute otitis media, something around 30 to 80% efficacy has been shown in different countries. Most important thing is the herd effect. Once the PCV13 is in the national immunization program since almost 9 years in US, what they have observed is the incidence of invasive pneumococcal disease or pneumonia above 65 years is very less for the serotypes existing in the vaccine. So after assessing this, there is a herd effect which is protecting above 65 years. Now the CDC recommendation has changed a little bit because previously what they used to tell is after 65 years, routinely give PCV13 for the senior citizens. Now they have changed recommendation saying that you give 1-to-1. You talk 1-to-1. If the patient wants it, you can give. Otherwise, you need not give. Because the incidence of PCV13 serotypes, invasive pneumococcal disease caused after 65 years has come down because of vaccination of the infants in the national immunization program with a coverage of 90%. The herd effect is the most important aspect, which has been proved beyond doubt by the PCV13. The other vaccines also, serotype PCV10 also has to proven to some extent, in fact, nasopharyngeal carrier state has come down and the serotype diseases have gone down. So that is the advantage of the pneumococcal vaccine. In fact, herd effect is one of the best example where protection of older people will be there when you vaccinate the children. So these are the various statistics which are showing that the reduction of pneumonia, invasive pneumococcal diseases in various countries, which I have already told you, and acute otitis media also has come down. And in the Japan also, what they have shown is the reduction of nasopharyngeal carrier state has led to the reduction of the acute otitis media in the children. And this is what US, France have shown that after introduction of the vaccine, there is a drastic reduction in the serotypes which are existing in the vaccine. Nasopharyngeal carrier state has come down, and in turn it helped as a herd effect. Another advantage of the vaccine is it has reduced the antimicrobial resistant serotypes which are there in the community also. So after introduction of the PCV13, there is almost antimicrobial resistance against the macrolides, cephalosporins, tetracyclines, penicillins has come down, and we don't have multi-drug resistant serotypes existing in the community or nasopharynx of the children because of this vaccine. And this is what I have been telling, that herd effect is seen in more than 65 years of because of the vaccination of the children. You need not vaccinate the older people. That is what the CDC has decided now. Routine vaccination may not be required if you have the vaccine in the National Immunization Program. This was the comparison done in the 2019. This was a WHO paper. What is the difference between PCV13 and PCV10? They have clearly shown that whenever immunogenicity is concerned, PCV13 is superior for the serotype 3, 6A and 19A. Nasopharyngeal state is concerned, definitely for 6A and 19A, PCV13 is preferable. Invasive pneumococcal disease, okay. Serotype 3 and 6A, both are equal almost. For 19A, it is PCV13 is preferable. Overall also what they have told is PCV13 is preferable for these serotype 3 serotypes which are not there in the PCV10. Not only that, if you have a 6A in the vaccine, you can also prevent 6C disease caused by the 6C serotype disease also can be prevented. They have shown that 6C is also will be reduced if you have the 6A in the vaccine. But the same effect is not shown by the PCV10. 6C reduction has not been shown by the PCV10. So PCV13 is included in the national immunization programs of 125 countries, in fact. That was very huge number. Almost 120 countries are using exclusively PCV13. And even in India also PCV13 was taken into consideration because of serotype coverage is better than PCV10 in fact. And we are using this vaccine in the national immunization program where it comes in a multi-dose vial. All 4 BMRU states have started using this vaccine in the routine immunization program. Maybe we'll have another vaccine also for India for the routine immunization. We hope that entire India will be using this vaccine in the national immunization program so that we can reduce the pneumonia burden in under 5. So coming to the PCV13 advantages, PCV13 right now is recommended up to the age of 18 years as a routine vaccination. Up to 5 years, it is a routine vaccination. After 5 years, 5 to 18 years, for high risk in India, now the DGCA permits to give it to the 18 years. And this is the only vaccine which is approved above 5 years. The other 2 vaccines are not yet approved for above 5 years. If at all, if you want to give for a high risk child who is having a immunosuppression or somebody having a splenectomy or a hyposplenism is there, or somebody is having a cochlear implant, it is the PCV13 only we can give. We cannot give PCV10 after 5 years. It is not approved for use of after 5 years. So PCV13 is almost all the age groups you can give this vaccine, and this vaccine is permitted to be used in high risk even in the adults also. So coming to the conclusion, the key attributes in choosing right PCV is it should be able to cover the broad pneumococcal disease spectrum including invasive pneumococcal disease, pneumonia, otitis media. We want to reduce all the 3 burden. Why? And for that reason, you should have a good antibody level when you are attacking the disease caused in the lung or otitis media, where antibody penetration is much less. Even a low level of antibody, septicemia you can prevent, but prevention of pneumonia, you need a high level of antibody. A right PCV should have a broad disease coverage. The said PCV should be able to demonstrate an impact that extends beyond the pneumococcal disease prevention. That's what herd effect I told you. And PCV 13 not only demonstrates impact in invasive pneumococcal disease, pneumonia, otitis media, but also shows effect in reducing the nasopharyngeal carrier state, curbing the antibiotic resistance, and demonstrating the herd effect. Of available PCVs, PCV 13 is included in 125 national immunization programs and exclusively in 122 Pro. So PCV 13 is the first and only PCV to help to protect the children 6 weeks to 5 years, 6 to 17 years, and above 50 years also. It is recommended to be given. Above 65 years, as far as India is concerned, because PCV 13 is not there in the national immunization program. Above 65 years, though the US says that above 65 years it is only one-to-one discussion, but in India I think it can be routinely given even after 65 years also, which should be followed by a pneumococcal polysaccharide vaccine after 1 year. Thank you for giving me the opportunity, and I thank Twin Cities Organizing Committee, which was an excellent conference. In fact, we are out of form to deliver any lecture on the stage because we are used to the webinars sitting in front of the. So it is like a cricket match. So if you don't play, you will be out of form. So I think slowly we will get our form to deliver our talks on the stage. Thank you very much, and excellent conference. I congratulate the TCB members for doing a wonderful scientific program. Since morning I have been watching. So content was so good, and attendance was also so good. We hope that post-COVID era, slowly it starts. Thank you.
Sir, Murthy sir, any questions, sir? Murthy sir, Anand sir? We have 3 more minutes. Dr. Sudhir Reddy.
Yeah.
India compared to the one that is already there?
Whenever any new vaccine comes, it will be compared to the old vaccine only. They have to show the immunogenicity studies that this is not inferior to the existing vaccine. So that study they have already done, Pneumocil has done. They have shown that the efficacy of the vaccine, immunogenicity of the vaccine is equal to PCV 10 and PCV 13. Both studies are there, in fact. As you told that whether the serotypes existing in the Pneumocil are relevant to India. PCV 13 has all those serotypes, in fact.
Yeah.
There's no doubt.
Pneumocil
has 10 serotypes. Out of that, PCV 13 also has the same serotypes. So both the vaccines there is no problem as far as India is concerned. PCV 10 new vaccine, that is Serum Institute vaccine, have included 6A and 19A in there. Out of 10, they have included the 6A and 19A. As I told you, 6A inclusion will prevent 6C also. If 6A is not there in the vaccine, 6C is not prevented. And 19A is the one serotype. If it is not there in your vaccine, 19A incidence has gone up in some of the countries. Even in the PCV using countries, 2019 there are some papers which are showing that where PCV 10, old PCV 10 is in the national immunization programs, they are showing that incidence of 19A has gone up.
Yes, sure.
They have gone up. Though there is some prevention for less than 5 years children as far as invasive pneumococcal disease is concerned. But a functional antibody may not prevent for the older children. The functional antibodies may wane off very early. So as far as your question is concerned, both the vaccines are relevant as far as India is concerned, as far as serotype coverage is. The serotypes which are removed from the PCV 13 are 4, 3 and 18C. What they quote is the incidence of serotype 3 efficacy is not well known. So the existing of serotype 3, whether it is useful or not, some studies say it is useful, some studies say it is not useful. So they have removed the 3. And serotype 4 and 18C is removed, saying that the incidence of 4 and 18C is much less in India. It is less than, they say, 2%. That's what one of the slides I have shown, that 6A, 19A and 3, all put together it is around 7% as far as India is concerned. So having a 1, 4 and 18C is definitely preferable if you have money.
Yeah, surely,
And
sir.
as I
Can
told
we-
you,
can
presence
we-
of serotype
can
is
we-
definitely preferable. More number of serotypes are definitely preferable.
In the interest of time, can we please continue this discussion during the lunch break? It will be nice. All the questions that
Thank you,
can
thank
be
you.
there, we can actually, because I know this is
Thank
a
you,
very
sir.
hot topic right now.
Ritesh, we are concluding. Thank you, sir.
But
Dr. Surinath will be available.
give any vaccine, but give pneumococcal vaccine. That is important.
So thank you, Surendranath, sir. Sir will be available during lunchtime. We'll proceed on to the next session. I thank the organizers for giving us this opportunity.
I request,
Thank you.
I request Surendranath sir, Yashovan sir and Lakshman sir to kindly come on the side stage for felicitation. I request Dr. Rangaya sir, C.N. Reddy sir and Arjun sir to kindly come and felicitate our current speakers. The next agenda on today's program is something which interests the younger generation a fair bit. We have the quiz. No, sorry, before the quiz we have the gold medal paper presentation, Dr. Chandrasekhar Chowdhury gold medal paper presentation. For this, I request Dr. Vamshi to kindly come up coordinating for this session. And the judges along with him will be Dr. Anand and Dr. Subramaniam. I request the two judges along with the coordinator, Dr. Vamshi Kondle, who is also the third judge, to kindly come up on the stage. For this program, the papers, there was a lot of keen interest that came through. There were at least 30 papers which were kind of sent in for selection. Among them, the group selected 6 papers. These are by Dr. Grishma, Dr. Lohit, Dr. Maria, Dr. Pratyusha, Dr. Rahul and Dr. Vignesh. Now, we will be presenting one paper after the other in that order itself. So I would like to request the PGs to be ready with their papers as well. I request the judges kindly come up on the stage, sir.
Good afternoon, everyone. Request all of you to please stay back for the last session, which is the prestigious Dr. P.S. Murthy quiz for practitioners. I promise you it will be a very entertaining and learning experience for all of us. There are prizes even for the audience if you answer it correctly. And I'm sure all of us would love that experience of a quiz. So please stay on for the next session. Handing it over to the organizers now. Request those who had given their names for Dr. P.S. Murthy quiz for practitioners to please report to Dr. Pawan. Please be available. We'll be starting soon after this session. Dr. Nitesh, over to you.
Thank you, RS. Sir. Can I request the first PG, Dr. Grishma, to kindly come up on the stage so she can commence her presentation, please. Now, the presentation is such that we'll be giving 6 minutes to each presenter, and then there'll be 2 minutes of questioning by the judges. Subsequent to that, the next speaker will start the next presentation. Can I request Dr. Anant to come up on the stage as well, please? Thank you, sir. Thank you so much for coming.
Sir, but the timer is already started. Excuse me, the timer is already started there. Can you please restart the time? So, I welcome all the young doctors for this prestigious Chandrasekhar Chowdhury gold medal presentation. Out of lot of competition among the participants, it is been shortlisted and alphabetically the names are being declared. The first participant would be Grishma. The rules of the participation is like each student would be having about 6 minutes for their best to present with a PPT, and later 3 judges who is sitting here would like to pose some questions. So it depends on various factors like how your scientific content and significance is there, how the abstract and research design is there, and how the title is come up. Is there any new, something new they have found out in the study, and how the time has been maintained, and whether it is concise and clear message, that is take-home message is clear, and oral presentation, how the presentation, oral presentation is there, and then question and answers. The division of marks are there with the judges here, and for the student's sake, for the scientific content it would be 10 marks, for the abstracts and research design it would be 10 marks, and title it would be 5 marks, whether it is apt for the study, and the time 5 marks if you're managing and maintaining the time well, and the message how you have given from the study, whether anything new message has come out of his study, it will carry about 5 marks, and oral presentation, how you behave from the time you enter on the dais and how you are confidently presenting will carry about 5 marks, and question and answers will get a significant amount, that's about 10 marks, totally 50 marks. So whoever stands first among these 6, the names are, again I will say for the convenience sake, Dr. Grishma, Dr. Lohit, Dr. Maria, Dr. Pratyusha, Dr. Rahul, and Dr. Vignesh. So we maintain some secrecy. We have not given the guide names or institute names to avoid any bias. However, like we are trying our best. If any faults are there, please forgive, and it's a continuation process of learning. Thank you all, and we'll try to do the best. Thank you, and all the best to all the participants. Sir, judges, you want to say anything? Sir?
I welcome you all for presenting the papers, and you have to maintain the time, and you will see these 3 judges are here, and don't they take the more time, and whatever you want to express, and you can present the case, and we will see the. So, okay, thank you. All the best for all the presenters.
So I welcome all the participants and people who have given their papers. I think they are nearly 19 in number. All of them, I think, among them, they were shortlisted because of time constraints. We cannot run for all. Naturally, we are forced to go for a shortlisting, and we have done it. And all of you, please, not alone these 6 and others also, there is one saying in English, race run is more important than trophy won. So the one person may win the trophy, but running the race is more important. That means you are actively involved. That itself is an accomplishment. So please take it in that spirit. So don't think that people who could not get the title about the what we honor are not in no way less. So please kindly accept it in a sportive manner. And we are compelled to select only one person. Yes, sir? We are compelled to select only one person. Naturally, 5 will be left out. So to take it in a positive way, I wish all the best for you.
Sir, our President, Dr. C.N. Reddy, and Secretary Sunkosh Bhaskar, sir, were very generous. Actually, all the criteria were not met by all the participants. Everywhere there were certain deficiencies. Naturally, you are all students, but to encourage the younger souls, our President and Secretary Sunkosh Bhaskar, sir, C.N. Reddy, sir, has helped us in categorizing and prioritizing things to encourage. So, every participant will get a participation certificate. So, not to get disheartened, at least coming till the shortlist itself is a great achievement. So, all the best once again. Please, can you start the first slides for Dr. Grishma, please? The time starts now, when you start.
Good afternoon, everyone. I am Dr. Grishma, postgraduate second year in Nilofer Hospital. I am presenting a paper under guidance of Dr. Alivelu ma'am, Evaluation of Anthropometric Measurements as Predictors of Low Birth Weight in Newborn. WHO has recognized birth weight as one of the 12 global indicators for monitoring the health of community. Low birth weight neonates have relatively high mortality, morbidity, and retarded growth pattern. Indeed, birth weight is one of the best parameter which reflects the past maternal history and the future projectile of the newborn. In developing countries, 25 to 30% of infants weigh less than 2.5 kg at birth. In these nations, most of the cases are delivered in peripheries and accurate weighing scales may not be available at these centers. Hence, best anthropometric measurements can be used to identify low birth weight. Many studies have been done in our country and worldwide to determine the best parameter among all the anthropometric measurements which can be easily measured to predict the low birth weight. The aim of the study is to find out the correlation between birth weight and anthropometric measurements and thereby determining the best parameter among them to predict low birth weight. Methods. It's a cross-sectional study done at Nilofer Hospital. Duration is from September 2019 to December 2019. The participants of the study are 1,635 newborns, and the following anthropometric measurements are recorded within 24 hours of birth, like weight, head circumference, chest circumference, mid-upper arm circumference, calf circumference, and thigh circumference by appropriate methods as per WHO standards. And statistical correlation of these measurements with birth weight is being done. Inclusion criteria is the live inborn newborns of Nilofer Hospital from the above said duration. And exclusion criteria are sick newborns who are admitted within 24 hours of birth and babies with congenital defects. And relevant antenatal histories with following anthropometric measurements were recorded in warm environment using standard techniques and measurements. And birth weight, the naked birth weight of the babies was measured in the spring scale to the nearest 25 grams, and head circumference is measured using a non-stretchable tape at the placed over supraorbital ridges in the front, and maximum occipitofrontal circumference was recorded to the nearest 0.1 centimeters. Similarly, chest circumference, mid-arm circumference, thigh circumference, and calf circumference were recorded to the nearest 0.1 centimeters by appropriate methods using a trained personnel. And the results of the study, the male to female ratio were, among the 1,477 participants, 1.14:1. The mean birth weight of the study is 2.68 kg. Prevalence of low birth weight, that is less than 2.5 kg, it is 30.4%. And here we can see the sex distribution. Less than 2 kg is almost equal female and male, and 2.1 to 2.49 kg there is slight female preponderance, and more than 2.5 kg there is slight male preponderance. Overall male ratio is more than female. And this is the sex and weight distribution of the babies. And these are the mean values of the overall data. That is, mean weight is 2.68 kgs, mean head circumference is 31.79, the mean mid-upper arm circumference 9.01 centimeters, and calf circumference 9.26 centimeters. And correlation matrix between different anthropometric parameters. And we can see that there is good correlation between birth weight and mid-upper arm circumference, that is 0.74, followed by calf circumference, which has the next highest correlation, that is 0.72. And these are the validity indicators using ROC curve analysis for different anthropometric measurements and detection of low birth weight less than 2.5 kgs. We can see that for a cutoff of 8.9 centimeters for mid-upper arm circumference, there is a sensitivity of 87%. That means among the whole study, 393 newborns who were less than 2.5 kgs have the mid-upper arm circumference less than 8.9 centimeters. However, few newborns who weighed more than 2.5 kgs or have also MUAC of less than 8.9 centimeters. And these studies have good negative predictive value of 93%. And following mid-upper arm circumference, calf circumference with a cutoff of 9 centimeters, it has a sensitivity of 85% and specificity of 75%. And this is the data analysis of the all the parameters for the different cutoffs with good sensitivity and specificity values, which shows that mid-upper arm circumference has highest sensitivity followed by calf circumference. And the early identification of low birth weight babies is an important prerequisite to any initiative to reduce mortality. And the various parameters like male to female ratio, mean birth weight was similar to many other studies. And prevalence of low birth weight is 30.4%, is comparable to other studies also. And if we use a mid-upper arm circumference of less than 8.9 centimeters, it would be accurate in 87% of cases to detect the low birth weight. And 28% of times the cases will be incorrectly diagnosed as low birth weight. And 13%, that is a false negative rate, will 13% of low birth weight babies will be incorrectly diagnosed as not underweight, which is a very less number. And it has a good negative predictive value, that is 93% of times the healthy cases are correctly predicted as healthy. And these are the various studies conducted across the whole world. We can see the study conducted by Alves JB et al. With a sample size of 1024 with a mid-arm circumference of 9 centimeters, which is very nearer to our cutoff value, that is 8.9 centimeters, with a good correlation coefficient of R is equal to 0.79. We got R is equal to 0.84. Another study conducted by Jyoti et al. With samples of 500 mid-upper arm circumference is 9.9 centimeters. It has slightly higher cutoff value because they have eliminated the preterm babies, that is less than 37 weeks. So, mid-upper arm circumference can be used as a better predictor for low birth weight babies. In peripheral areas where accurate distal weighing scales are not available, the dice can be trained with using a measurable tape, like how we use a colored coded tape, Sharkey tape for mid-upper arm circumference from 1 to 5 years. Similarly, a color coded tape can be adopted to measure the mid-upper arm circumference, and even the next good parameter is calf circumference for early detection of at-risk low birth weights for the timely management. However, it is a hospital-based study. Similar many studies should have to be conducted in our community to recommend an exact cutoff and best anthropometric parameter to a marker of low birth weight. And these are the various studies conducted which have similar results, like mid-upper arm circumference and calf circumference their studies also, they got the results similarly. They also got mid-upper arm circumference and calf circumference as the predictors of low birth weight.
So, viewed from community perspective, what is the advantage of this anthropometry compared to recording the birth weight, according to you?
Sir, I think that there is no specific advantage, sir, but in peripheral areas, in developing countries like India, still many deliveries are being conducted by untrained eyes, sir. Their adequate weighing scales may not be available. They just roughly said, if we train those eyes using these color-coded tapes or something, just by measuring the mid-upper arm circumference, even exposure of the whole body is also not required. Just we can give 3 color codes. If it falls in this range, the baby is low birth weight.
So without
then we can refer to the higher centers for further management, sir.
Yes. So the screening would be much easier with a simple tape. They need not carry the bulky weighing machine. That is what you want. What about your comments on foot length? Sometimes some of the studies, they take the foot length.
Yes, sir, foot length is also a good predictor.
But you did not record, but do you want to make any comments on foot
length?
length?
Yes, sir. In many of the studies, foot length is also a good predictor of low birth weight. Even it's also correlating with gestational age also, sir, foot length.
Because the calf circumference and mid-upper arm circumference, there can be inter-observer variation.
Yes, sir.
Foot length may be more nearer to the truth. Anyhow, it's a good.
So anyway, you have not taken the foot length. That is the one you have omitted. And one thing, when did you record this head circumference, the exact after the birth, in addition to the other parameters?
Actually, to prevent the molding effect will be there, sir. Ideally, after 48 hours, we have to record, sir. But
So is it you have taken after 12 hours or 24 hours, or you have mentioned within 24 hours?
within 24 hours, we have recorded, sir.
But when you have taken, because of the molding may be there, some
yes.
swellings may be there in the head.
Yes,
So you
sir.
cannot take immediately after birth.
Yes, sir.
And thigh, the calf circumference when you have taken?
Sir?
Calf circumference.
Yes, sir.
Okay.
It's also a good predictor, sir. Followed by mid-upper arm circumference, calf circumference is also a good predictor of low birth weight, sir.
Okay.
You want to ask something?
So, you have presented well, but certain improvements have to be there, and someone has to point out the plus and negatives. Doesn't mean that when we show the wrong, your study is not well. You have shortlisted, that means it is good. So, when you write the references, you have to try to keep the newer references in the order. So, if you see, it is of 93, 91, 2003, and 1986. So, I would recommend to use new references because the science is progressing so fast. And that is one. And what are the actions you want to take? You have done a fantastic study under a good institute. What you declared, actually, it should be kept as a secret. What are the actions you want to carry forward?
Sir,
what are your future plans or take-home message?
Similar studies, we can actually there will be many racial and geographic variations among these measurements, sir. So similar studies can be conducted across various communities, and we can come out with the best parameter, and we can implement that, sir, for predicting low birth weight at peripheral centers.
Done.
Thank you, sir.
Thank you.
Thank you, sir.
So may I call upon the next contestant, that is Dr. Lohit, please.
Dr. Lohit. Ready.
Just give me 1 minute, I'll project it. Okay.
Time is up, sir. Can you start? Yes, you can start.
Projection.
Waiting. You want something?
No.
Mic is
Good afternoon, everyone. I'm Dr. Lohit from Gandhi Medical College Hospital, presenting your paper, Comparison of Platelet Indices in relation to thrombocytopenia and severity in patients with dengue fever. So dengue fever is an acute infectious disease which is an endemic in our country, which is caused by 4 serotypes and is the most prevalent mosquito-borne viral disease in the humans. And the one recent estimate indicates 390 million dengue infections per year, of which 96 million manifest clinically with a small proportion progressing to severe disease. And the platelet indices such as mean platelet volume, platelet distribution width, and platelet large cell ratio have been investigated as the prospective platelet activation markers. The mean platelet volume, this normal is 9 to 11 femtoliters, is a numerical marker of platelet function and activity. It is a surrogate marker of bone marrow activity, and low mean platelet volume indicates marrow suppression and increased risk of bleeding. And platelets with increased number and size of pseudopodia differ in size, affecting platelet distribution width. And the normal platelet distribution width was 9 to 13 femtoliters, which increases during platelet activation. And platelet large cell ratio, the normal range was 33 to 42%, is significantly elevated in thrombocytopenia and is directly related to platelet distribution width and mean platelet volume. So the research question is, there is limited data on dengue fever in pediatric population and particularly related to platelet indices. And a study has been proposed to know the correlation between severity of dengue infections in children, particularly related to platelet indices. So our aim is to compare platelet indices in relation to thrombocytopenia and severity, and to measure the trend of objective is to measure the trend of platelet count in patients with dengue and its correlation with mean platelet volume and platelet distribution width, and to assess the severity of dengue fever. So the study design, a hospital-based prospective observation study conducted in children admitted in pediatric department, Gandhi Hospital, and a total of 100 children less than 14 years fulfilling the inclusion criteria were included from September 2018 to November 2019 after taking written and informed consent. And the inclusion criteria, all children less than 14 years of both genders who are presenting with features of suspected dengue or probable dengue as per WHO guidelines, with positive serology like NS1 antigen or IgM or IgG antibody positive established by immunochromatographic steps and ELISA were considered for the studies. And the exclusion was who are IgM or NS1 negative and those who cannot be proven as a probable or confirmed dengue, and children with pre-existing chronic disease which may interfere with the assessment of dengue infection were excluded from the study. So the methodology, the platelet parameters were measured by semi-automated hematology analysis on venous samples collected in EDTA sample, and the children were observed from the day of admission till discharge, and the value of indices were assessed accordingly on 3 occasions. That is, on the day of admission, on the second day of, on the day where the child got the lowest platelet count, on third at the time of discharge. And the platelets were classified, and the children were classified as dengue fever with warning signs, and severe dengue according to the latest WHO guidelines. And the data analysis were analyzed using statistical package for social sciences. And the results in a study, according to the age group, many of the children, they're between 48%, they're between 6 to 10 years. And there is no significance in the gender. The male and female ratio is almost 1.2:1. And the distribution of study subjects according to serology, the NS1 positive were 29%, IgM positive were 48%, and both NS1 and IgM were 23%. And according to the platelet count, on the 3 different occasions from we observed, on the day of admission, the mean platelet count was 77,000. On the day of least count, it was 69,900, and on the time of discharge, it is 1,67,000. And according to the mean platelet volume, on 3 occasions, the mean platelet volume at the time of admission was 9.58. On the day of least count is 9.94, and the time of discharge is 10.31. So we divided the subjects according to the platelet count is mild, moderate, and severe. It's less than 20,000, 20,000 to 50,000, and more than 50,000. And we divided subjects into according to the severity, severe dengue, dengue fever, and dengue fever with warning signs. The association between the severity and the platelet count, there was, of all cases, there is significant decrease in platelet count in severe dengue patients. If the p-value was 0.009. At the admission, the mean platelet count was 62,000. And the severity and the mean platelet volume there was significant decrease in mean platelet volume in severe dengue cases on the day of admission. The mean platelet volume was 8.37 on the day of admission. And the association between severity and the platelet distribution with, there was significant association only on the day of least platelet count and the day of discharge in all cases irrespective of the severity. And the association between severity and platelet large cell ratio, there is no significant association. And the association between the platelet count and the mean platelet volume, because the low mean platelet volume also causes the platelet count to decrease because there is severe bone marrow suppression. So there was a significant association between mean platelet volume and platelet count on the day of admission and the day of low platelet count, because suggesting that low mean platelet volume may have a further least platelet count in the coming days during follow-up. And the association between platelet count and platelet distribution, there was only a significant association only at the time of admission. There was no association between platelet count and platelet large cell ratio. So on the discussion, we noticed that mean platelet volume was significantly decreased in severe dengue patients on the day of admission, suggesting that the subsequent platelet counts on the day of platelet counts were very low due to the low mean platelet volume at the time of admission. And the platelet distribution width was highest on admission in severe dengue cases. And what we conclude from the study is platelet count have no role in determining the need for transfusion in dengue, because the platelet count may decrease due to different varied factors like viral replication in the platelets itself, or the antibodies against dengue, they may act on platelets. So the platelet indices give information on whether platelet distribution is ongoing or whether the bone marrow is responsive. So low mean platelet volume and high platelet distribution width can be used as a probable indicators for thrombocytopenia in endemic areas and also predictor of severity. So when we have a low mean volume with low platelet counts, it indicates marrow suppression. And increasing mean platelet volume with ongoing thrombocytopenia, it indicates peripheral destruction. And increasing mean platelet volume with stable platelet count indicates recovery. So we conclude that mean platelet volume and platelet distribution widths are good indicators of predictor and severity of dengue fever. And these are the different previous studies which are done. Thank you.
Did you include the PCV value to confirm the dengue fever?
So we confirmed the dengue
and
case.
Serology, when you have taken? Within 3 days or 4 days?
So we included all study subjects based on either NS1 or IgM antibodies. Or
NS1 is a non-specific, no, usually.
Sir?
Non-specific, no, that.
The sensitivity of
antibody
NS1
titers is very, very important, reliable, no? That will take time, more than 4-5 days.
You have done IgM?
Actually, we observed patients from the time of admission to till discharge. So we can get either NS1 antigens or IgM antibodies during the course of illness in our hospitals, during hospital stays.
I think you need good lab support for doing all this, is it not? Because the work is so what is your final message in terms of prognosticating the case, or in terms of management? What is your carry-home message?
As dengue is an endemic in our country, during any outbreaks in our countries, we'll have a full of patients in our hospitals or any tertiary running hospitals or any peripheral hospitals, where they're more, they'll get all our patients or any clinicians will assess dengue with thrombocytopenia, and we'll run around all our blood banks with platelet transfusions, because there is a requirement of platelet transfusions, but when we take mean platelet volume, which is done in all hospitals, this normal hematological analyzer, so by seeing whether there is a bone marrow suppression or when there is any actual need of requirement of platelets, we can assess from the platelet indices.
Your time was past, like when you presented, as now also. So I'll have one question to you, like, what changes you want to make after presenting in this conference? Like, do you have anything to change in your study, or to add or to delete something? If yes, say, or if no, you can end.
Time management.
Thank you. So may I call upon the next presenter, Dr. Maria. Maria, please.
Good afternoon, everyone. I'm Dr. Maria, postgraduate, presenting a paper, a study on clinical and laboratory presentation of COVID-19 in children admitted for severe acute respiratory infection in a tertiary care hospital under the guidance of Usha Rani Ma'am, HOD and Professor of Pediatrics, Nilufar Hospital. As you all know, COVID-19 is a global health crisis and is a pandemic affecting since March 11 to 2020. Children of all ages are susceptible to COVID-19, but they appear to be relatively less affected and also have a milder course than adults and also better prognosis. As of now, children account for up to 5% of the total disease burden. Due to smaller number of reported cases in children, it is challenging to delineate the clinical characteristics of children with COVID-19 presenting as SARI, and also as 90% of cases in children of COVID are asymptomatic or mild or moderate. So there is very few data or papers on severe manifestations of COVID-19 in children, especially those presenting as SARI. And also there is a lack of data on biomarkers of severe infection. Aims and objectives of the study are to describe the demographic characteristics of COVID-19 among children admitted with SARIs in our center, and also to study the clinical characteristics and laboratory profile of these children, especially correlating the clinical severity and the laboratory findings. This was a prospective observational study during the period of April 2020 to November 2020, conducted at Nilufar Institute of Child Health, Hyderabad. The inclusion criteria taken was all children aged less than 12 years admitted for SARI who tested positive for COVID-19 by RT-PCR. Exclusion criteria was children who tested negative for COVID-19 by RT-PCR or did not meet the criteria for SARI by WHO. All children who met the inclusion criteria were included in the study, and the clinical features and investigations were studied and analyzed with frequency distribution tables. During the period of the study, in our center, 1,156 children were admitted with SARI, of which 9.8% of children tested positive for COVID-19. So 1 of 10 children admitted for SARI tested positive for COVID-19 during the study period. Distribution based on age and sex, 60% were boys and 40% were girls in the study group. The mean age of presentation was 3.3 years, with 55% of the children being infants less than 1 year. 66% of cases were from rural area and 3.9% of cases from urban area. Coming to the weight-wise distribution, we observed more than 75% of the cases had a weight for age centile less than 50th centile, with a significant 28% of children with weight for age less than the 3rd centile. Distribution based on the clinical features. In addition to fulfilling the SARI criteria, children also presented with sore throat, rhinorrhea, sneezing, myalgia, fatigue, diarrhea and vomiting. 51% of cases had cough, 44% rhinorrhea, 46% of children had gastrointestinal symptoms like pain, abdomen, vomitings, then diarrhea, and 16% of children had seizures and 9% myalgias. Based on oxygen saturation, 40% of cases had a saturation of more than 95%, and 29% of cases had a saturation of less than 90%, and 31% of cases had a saturation between 90 and 95%. Based on involvement of other systems other than the respiratory system, 9% of children presented with myocarditis, 16% presented in shock, 18% with seizures, and 11% had pre-renal AKI. Distribution based on comorbidities, 15% of the cases had comorbidities such as congenital heart disease, nephrotic syndrome, cerebral palsy, and the rest 85% of children did not have any other underlying comorbidities. Distribution based on the lab presentation, complete blood picture, anemia was seen in 44% of the children, leukopenia in 4%, leukocytosis 21%, thrombocytosis 18%, and thrombocytopenia in 20%. And 39% of cases had an NLR ratio of more than 3.5, and 46% had NLR of more than 2.5. 67% of the children had an elevated C-reactive protein level. 11% of the children met the criteria for pre-renal AKI, and 20% of the cases presented with hyponatremia and 13% with hyponatremia. correlation of COVID with severity, correlation of COVID severity with lab parameters. Severe COVID, we took the criteria as SpO2 less than 92%, seizures, lethargy, or severe respiratory distress. NLR was found to be higher than 3.5 in 58% of the cases who presented with severe COVID compared to 39% of all cases. The p-value was 0.02. CRP was positive in 71% of cases with severe COVID compared to 67% of all cases. P-value was 0.4. Thrombocytopenia was found in 37% of all cases, of the severe cases compared to 20% of all cases. P-value 0.03. And 59 cases of the severe COVID were under the age of 1 year. In the study group, the mortality was 15% and 10 of 17 children who died were infants under the age of 1 year. So, to conclude, 1 of 10 children admitted for SARI in our center tested positive for COVID-19. Children under the age of 1 year seemed to be more susceptible, and also the consequential mortality was higher. NLR ratio and thrombocytopenia could be associated with COVID-19, especially NLR ratio and thrombocytopenia. They are cost effective and could be potential reliable biomarkers for markers of severity for COVID, in contrast to inflammatory markers which are very costly and cannot be performed in rural areas. Thank you.
So your study has the more cases less than 1 year of age.
Yes, sir.
So what could be the possibility of the reasons why it is more in the less than 1 year of age? And
No cause has yet been established, sir, but the hypothesis which is popular right now is smaller airways and also immaturity of the immune system.
Any of the study group developed the multi-organ dysfunctions? Liver or brain, encephalopathy pictures?
16% had seizures, sir, but encephalopathy also was observed in a small number of patients, and also liver injury was also seen, but we couldn't follow these patients because after they tested positive, they had been shifted to Gandhi, which was a COVID center. So we could take this data, which was only the presenting data, and these were the complaints with which they had presented, and we correlated the presentation and the lab findings to see if it could predict the severity in these children.
So this was the point I was trying to raise up, like did you follow up? Because
yes, mortality we could follow. Because of the vast number of cases, mortality we could follow up, sir. Like in 17 cases, 10 cases died in Gandhi.
Coronavirus being a novel virus,
yes,
we don't know if the children has been admitted again and whether they have manifested it. You would have been follow-upping the cases because you have the patient contact details. And second thing is, did the comorbidities, what you have mentioned,
no,
did
sir, they
affect
were they did not affect the severity. There was no correlation between severity and comorbidities. That's why it was not included in the study.
So did you invent something? Did you find out something when you did this study?
Yes, sir. NLR ratio is associated with severity, sir. P-value came out to be significant. Even thrombocytopenia also.
Okay.
So the most of the cases, according to you, the infants, what is the percentage you said? 70?
55% of the total cases were infants, sir. And even in deaths also, 58% were infants.
So can you extrapolate this finding to the community, or you think it is because of case clustering, because Nilofer being a pediatric hospital?
Sir, actually, the mortality rate in our study was higher to the mortality of the community, because the cases requiring admission in Nilofer generally tend to be the severe spectrum of COVID, and it could be extrapolated to the community to the severe end of spectrum, because the similar findings were also found in Europe and Italy, sir, where they have taken 2,000 to 5,000 number of patients, where they have also found less than 1 year there was severe COVID. More percentage of infants going to severe COVID less than 1 year. Thank you, sir.
May I call upon the next presenter, Dr. Pratyusha, please. Are you there? The next presenter should be nearer. You don't have to run from there. Maintain the time. You already started time. Can you start the time again, please? I request Rahul and Vignesh to be nearer the stage if you are on the back.
Just give me 1 minute. I'll project it on the screen and then we can start.
Yeah.
Start, please.
Sure. Good afternoon, everyone. I'm Dr. Pratyusha from Nilofer Hospital. Today I'm presenting a paper on a study to validate the MECISAC score to predict group A streptococcal pharyngitis in children presenting with sore throat. Pharyngitis is inflammation of mucous membrane and underlying structures of pharynx with objective evidence of inflammation. Majority cases are self-limiting viral illnesses, but the most important cause is group A streptococcus pharyngitis because it can cause suppurative and non-suppurative complications, especially rheumatic fever. Need for the study: in many resource-poor countries like India, non-availability of culture sensitivity prompts physicians to administer empirical therapy of antibiotics, which results in a rise in drug-resistant bacterial strains. Various clinical predilection models have been developed for identification of streptococcal pharyngitis, and it is important that we use antibiotics judiciously to curb the antibiotic resistance. So the aim of my study is to validate one such clinical prediction model called the MECISAC score, which helps to identify the probability of this pharyngitis being streptococcal in pediatric population of Telangana. So the objectives of study are to evaluate the strength of association of each criteria in the MECISAC score and the total score with microbiological evidence of group A streptococci, and to evaluate the proportion of pharyngitis cases that are actually culture positive for streptococci. Inclusion criteria: children aged 3 to 14 years presenting to OPD. And exclusion criteria: children who are already started on antibiotics for the current infection, presence of another illness requiring antibiotics, history of previous rheumatic fever, children less than 3 years and more than 14 years of age, children with stigmata of particular disease like pseudomembrane of diphtheria or conjunctivitis of pharyngoconjunctival fever, children with medical conditions that are likely to cause deviation from typical pharyngitis treatment like neutropenias or immunosuppressed stage, children who are already treated for group A streptococcus in the last 30 days. So materials and methods: this is an observational study, a cross-sectional study conducted in Nilofer Hospital from January 2019 to 2020, and the sample size is 200 cases. Identification detail: present medical history and physical examination findings pertinent to the study were collected. A disposable sterile cotton swab was used for throat swabbing, and it was inoculated on 5% sheep blood agar. Group A streptococcus was identified by conventional methods of colony morphology, hemolysis pattern, gram staining, and bacitracin susceptibility. Coming to statistical analysis and results, the basic demographic data of the study is sex distribution is almost 1:1, and age distribution ranged from 3 to 14 with mean age being 8.5 years. And coming to the univariate analysis, 29% of the sample size had temperature more than 38 degrees Celsius, 27% had absence of cough, 32% had swollen tender anterior cervical nodes, and 31% had tonsillar swelling or exudate. And the total MECISAC score, maximum was at score 2 and minimum was at score 4. And the prevalence of group A streptococcal pharyngitis, overall prevalence is 3.5%. And the association between temperature more than 38 degrees Celsius and group A streptococcal pharyngitis is, among the culture positive cases, 85% had temperature more than 38 degrees Celsius and only 14% had temperature less than that. And among the culture positive cases, 57% had absence of cough and 42% had presence of cough. And 100% of the cases of culture positive cases had swollen tender anterior cervical nodes, and 100% of culture positive cases had tonsillar swelling or exudate. And coming to association between the total MECISAC score and group A streptococcal pharyngitis, till score 2, as we can see here, there was no culture positivity. And as we go from score 3 to score 5, we can see that the culture positivity is increasing from 14% to 57%. And to strengthen the multivariate analysis, we have used the ROC curve, and the area under the curve was 95.3%, which goes to show that if we apply this score in 100 patients, correct conclusions can be drawn in 95 patients. And because of this high sensitivity and negative predictive value, this is a very good screening tool which can be used in primary healthcare centers where culture sensitivity and rapid antigen detection tests are not available, which is the scenario in our country. And conclusions and recommendations, we conclude that the predictive validity of this score as a screening tool is recommendable. And considering this high sensitivity, low proportion of streptococcal sore throat cases may be missed. So in conclusion, a score less than 3 may be useful for excluding a diagnosis of streptococcal pharyngitis, and a score more than or equal to 3 requires further investigations such as rapid streptococcal antigen detection test or throat swab culture as gold standard to confirm the acute pharyngitis. So this age-appropriate score is a simple primary care management approach that improves the identification of group A streptococcal infection. Thereby we can decrease the diagnostic burden also, and we can decrease the therapeutic burden and antibiotic usage also. And we are living in an era where we need to nip this antibiotic resistance in the bud. These are my references, including the original study done by McIsaac in Canadian population. Thank you, sir.
At community level, the message how to pass the screen out the cases of pharyngitis at the PSC level or the sub-center level when there is no facilities for the culture.
I did not get you, sir. Can you please repeat?
No, at the community level, your study, in what way it is a benefit to screen out your case of the pharyngitis?
Yes, sir. Basically, if a child has sore throat, the parent will take the child to community centers, so to the nearest PHC. They will not take to tertiary care center. And we cannot expect culture sensitivity tests or antigen detection tests in a primary healthcare center. So this score is just a clinical score. We do not need to use any kind of instrument or anything, so just an objective clinical score which has a high negative predictive value, high sensitivity. So maybe if the child has a score less than 3, we can wait and watch for the objective signs to develop. Or if the child has more than or equal to 3, we can refer the child to somewhere these tests can be done. Or if the score is somewhere at 4 or 5, we can start empirical antibiotic therapy. And since only 3% cases are streptococcal, so we can avoid the antibiotic usage in the rest of 97% cases.
You recommend the score because of high degree of sensitivity that is associated, that too, with a clinical assessment.
Yes, sir.
That may obviate the need for doing a rapid antigen test.
Sir?
You agree? Rapid antigen test may not be needed because you do it as a screening for all.
Yes,
Because
sir.
sometimes usage of antibiotics may be harmful. Had it been a case of, say, for example, infectious mononucleosis or something of that sort, the antibiotic may cause harm also. That we all know. So in that way, it is more sensitive. But how it would be to recommend a rapid antigen test to a peripheral center compared to the score? Because to bring to the knowledge of all the peripheral healthcare professionals regarding the score may be a bit tough job.
Yes,
You said it is more useful for screening the cases of streptococcal sore throat, at least to eliminate.
Yes, sir.
It is useful.
Yes,
but how to bring it? How you think you can convey the message to the periphery?
Yes, sir. First thing is rapid antigen test is a specific, sir. It is so if it is negative, we cannot rule out the infection, because if you still suspect clinically, we have to go for throat culture. But if it is positive, we need not go for throat culture. So it is more of specificity, whereas this test, this clinical score is a sensitive tool, sir. So we can rule out the streptococcal pharyngitis rather than saying that it is definitely streptococcal pharyngitis. So up till the score of 3, we can manage the child without antibiotics. At 3 and more than 3, we have to go for antigen detection test. And if that is positive, we can directly start treating. Or if that is negative and we are still at a score more than or equal to 3, then we have to go for throat culture and treat the patient. Or if these tests are not available, then at more than 3, we can give empirical antibiotic therapy to prevent all these non-suppurative complications and suppurative complications.
You have started your study from the age group of 3 years.
Yes, sir.
Am I right?
Yes, sir.
So if that were to be the case, how did you select the cases? A child who is around 3 years may not be able to verbalize the symptom of sore throat.
Yes, sir.
How did you go? Only by clinical assessment or how?
Sir, we took history, sir. History was important because we
History,
considered...
what is that child may not be able to tell?
No, the parents who brought very younger kids, the parents who brought with symptoms like throat swelling or lymphadenopathy, such cases we have taken, sir.
Okay, right.
Although we knew the time is up, but do you have a correct figure of sensitivity? Last question, like you said, it is good
Yes, sir. Yes,
than
sir.
specificity. Do you have the number in your study?
Yes, sir.
How
yes.
much is the sensitivity?
Sir, for a total score of for a score of 3, negative predictive value is 95%, sir. And sensitivity is 78%. And for score of more than or equal to 4, negative predictive value is 99% and sensitivity is 85.71%.
So more the score, you have more specific.
Yes, sir. More the score, more the sensitivity.
Okay, thank you. Can I call upon the next presenter?
Rahul.
Dr. Rahul, please.
Give me 1 minute, I'll project.
Good morning, faculties on and off the dais. Myself, Rahul. I am from Nirafor Hospital and I am presenting a paper on the evaluation of the usefulness of newest version of the Pediatric Index of Mortality 3 predicting score. The scoring system and mortality predictors help in stratifying the patient according to the specified outcome. Current healthcare economic demands the healthcare resources be provided in a cost-effective and efficient manner and doesn't jeopardize the quality of the care. For this, it is necessary to apply the scoring system that objectively measure the clinical status, severity of illness, and risk of specific outcomes. The mortality predictor scores have been developed as the tool for accessing the performance of ICU relative to the other units. And it just not only predicts the individual mortality but also help in comparing one ICUs to the other. It is important to have an international scoring system that allows some comparison between various countries also. The aim and objectives of my study was, the aim was to evaluate the usefulness and validation of the Pediatric Index of Mortality 3 score in the tertiary care setup, and objective was to validate it and to determine the discriminative ability and calibration of the PIM3 score in predicting the outcome of the children admitted to the PICU. The materials and method, the study design was a single center prospective cross-sectional study, and the setting was PICU of Nirafor Hospital. The study period was between January 2019 to the March 2020. The sample size was 402 children admitted to the PICU. Inclusion criteria, all the patients who were admitted to the PICU between 1 month and 12 years of age were taken into the study, and exclusion criteria was the newborn babies who were less than 30 days of life, and patients who had died within 1 hour of the admissions, and those who were referred from the other units of the hospital for any monitoring or any medications, and who went on, who were transferred out to the other hospitals. The variables of the PIM3 score, this score was containing 11 variables. So all were measurable easily, and the only invasive measurement which was required was arterial blood gas. Remaining were like systolic blood pressure, pupils at the time of admission, FiO2, base excess which was available from the ABG, whether the child was mechanically ventilated or no, whether it was an elective admission or no, or whether it had undergone any cardiac surgery or any surgical procedures. This was the formula for calculating the pediatric index of mortality score. So based on the formula, we can come to know that whether the pupils were reacting or no, and base excess were given more value in this mortality prediction. And the risk could be predicted by calculating the logarithm of the PIM3 values. So the performance of the PIM3 score or any of the scoring system can be evaluated by calibration and discrimination. These are the parameters which are used to evaluate the scores. Discrimination is assessed by the area under the receptor operating curve. So what is meant by area under the receptor operating curve is, if the area is 0.75, it means that the score will predict that the non-survivors are 75 times correctly predicted by the score. And calibration helps in comparing the mortality between the various levels, like between 1 to 7%, 7 to 15%, more than 15%, what is the mortality. And standardized mortality ratio, it will help in knowing the quality of the PICU. So these are my results. So the mortality in the PICU setup was 28.5%. And the age groups, the most common age group admitted was between 12 to 59 months, that was 1 to 5 years. The next most common were the infants. And these are the diagnostic categories. Among the diagnostic categories, neurological cases were mainly transferred to the PICU, followed by the infective as well as septic conditions, septic cases, and mainly respiratory cases and poisoning were all of the cases were shifted to the PICU. The age group and outcome. So the maximum death was occurring between the 16 to 119 months of age, but the mortality was more among the infants when we compare the statistics. So these were the disease-specific outcomes. So among the disease-specific outcomes, much of the mortality was seen between the poisoning cases as well as gastrointestinal cases. The gastrointestinal cases were acute liver failure, such cases were included. So this is the graph representing that. So the cardiovascular cases had a high mortality, then accidents had a high mortality, post-operative cases had very high mortality. So this is the mortality according to the mechanically ventilation. So as we can see, the non-ventilated patient, the death were very rare, and when the mechanically ventilated person, the outcome of the death was very high. And the probability range and the outcome among the scores calculated, when the probability score was more than 15, the death rate was very high. So this is the probability groups and SMR. So the SMR, the standardized mortality ratio for the groups less than 7 was 3.15, 7 to 14 was 1.64, and more than 15 was 1.7. This is the ROC curve. The ROC curve in my study was around 0.87. That means 87% of the time my study correctly predicted that the non-survivors were at 87% chances of surviving. So these are the other studies. This Lance Tarney study was the parent study. So there the mortality was 7%, whereas the AIMS, KEM and my study had a mortality was around 34%. That indicates that the PICU quality had to be improved. The limitations of the study was it was a single center study, and we didn't consider the other parameters like other system involvement or else the long-term outcome in the study. And mainly the conclusion, so many such studies has to be conducted in the various centers and over the years so that we can calibrate the study very well and we can come to a conclusion whether the scoring system can be applied to our setup or not. These are the other scoring systems which can be used. Thank you.
Of these cases, you have taken the only mortality aspects. How do you follow up these cases? You have studied the group, study group. Did you follow up the cases, and what message you have to give to the community level
so basically
and the hospital based?
The follow-up was like whether the cases succumbed or whether those were discharged from the hospital, sir. So that was the main outcome. The main aim of the study was to evaluate the PIM3 at the time of admission, sir. So whether the cases had succumbed or whether they were discharged, only those were taken into account, and readmissions were not considered, sir.
You are presenting here for a gold medal paper presentation. Do you know the way how you should project your slides? Like, do you have a guidelines from the university? How a thesis, this is your thesis, right, by the way? Or is it an additional study you are doing from apart from your compulsory MD program?
No, sir, thesis study, sir.
Thesis study. So how the slides should be? See, in most of your slides, there are no headings. You just, maybe because you have more data to present.
Yes.
And I just want to bring out that point. That's a learning point.
Okay, sir.
And the color things and those things you have to avoid. And you didn't tell about the references also.
Other studies, it was a comparison
No,
study
no, no,
between
the references I'm talking about, bibliography.
Okay, sir.
Did you?
No, sir.
That's what I pointed out.
Yes.
Isn't it?
Yes, sir.
So those two mistakes were there. And you slowed down because you wanted to finish on time.
Yes.
While presenting.
Thank you, sir.
Can I call upon Mr. Vignesh, last presentation?
Just give me 1 minute. I'll project it and then you can start.
Good afternoon, everyone. I am Dr. Vignesh from Nilofer Hospital. I am presenting a paper on a study of clinical profile and outcome of pharmaceutical poisonings in children less than 12 years in a tertiary care center under the guidance of Dr. Raikma sir. Introduction. Pharmaceutical poisonings are one of the most common poisonings seen in pediatric population. As a group, they account for almost 10 to 20% of all poisonings in childhood. Knowledge of clinical manifestation and prognosis of poisoning will help to perform appropriate clinical assessments. In this study, we aim to report the patient characteristics, outcome and clinical features of pediatric pharmaceutical poisoning in the emergency department. Need for the study. In spite of being one of the most common poisoning as a group, the knowledge of these studies are very sparse. Exact toxic doses, exact clinical spectrum of many pharmaceuticals are not available in the literature. Most of the information available are from adult studies, and pharmaceutical poisonings in children are mostly accidental injections. Many a times, we don't know the exact amount ingested. Multiple studies are required to get an idea about the exact toxic doses and the doses at which symptoms occur for each pharmaceutical. Aim to study the spectrum and clinical profile of pharmaceutical poisoning in children less than 12 years in a tertiary care center. Along with that objective, to review the common signs and symptoms of pharmaceutical poisonings in literature and compare with those in my study. Study design was a retrospective study, sample size of 49 patients less than 12 years admitted for pharmaceutical ingestion in Nilofer Hospital in the year 2019 over a period of 12 months. I include all cases less than 12 years admitted for pharmaceutical injections. Poisoning due to other substances were excluded. What we did was a retrospective analysis of medical records after getting permission from the ethical committee and medical superintendent of Nilofer Hospital of the 49 cases admitted in the year 2019. Pharmaceutical poison exposure were defined as ingestion either accidental or intentional of pharmaceutical substances at doses other than the therapeutic dose or ingestion of substance not usually recommended for oral intake. These are the results. The mean age of presentation was 2.8 years. Boys were more than that of girls. And most of the cases were of accidental ingestions. Only one case was due to intentional ingestion. These are the category of pharmaceuticals. Most common drugs ingested were hormones, that is thyroxine tablets. Second most common group were anti-epileptics. The next were antihistamines and analgesics. Mean duration of hospital stay of these poisonings were 4.5 days. Antidotes were required for 3 cases, one of iron injection and 2 cases of paracetamol injections. Most common formulation was tablet. We even had a case of suppository injection, accidental suppository injection of Dulcolax. Symptoms, in these cases, almost 44.9 cases didn't have any symptom. And the most common symptom with presentation was vomiting. Outcome was, overall the outcome was good, except for a case, only one case died. It is a case of lice killer injection. Discussion. Pharmaceuticals accounted for 19% of all poisonings in children less than 12 years. A study in CMC Vellore shown that they accounted for almost 36% of poisoning cases in the hospital. In my study, the most common drug was thyroxine, whereas in many of the Western studies, it were psychotropic drugs and analgesics. Indian studies, we have very less data. Only two studies were there. One from AIIMS and another from CMC Vellore. Both showed that the most common drug ingested in their hospital was anti-epileptics. Increased incidence of thyroxine ingestion may be due to the increased presence of hypothyroidism and availability of thyroxine tablets at home in our region. It might also be due to the packaging of thyroxine tablets in boxes than strips, which is very easier for these children to take. And they might misunderstand it to be chocolates. Antiepileptics were the next most common drugs. And phenytoin accounted for the increased duration of hospital stay in my study. Almost all cases were accident injections except for a 12-year-old female child who took the drugs intentionally. Mean age of injection was 2.8 years. Most common age were between 2 to 3 years at the age where mouthing and oral experimentation usually occurs. Boys were more than that of girls. Of the 20 drugs ingested, only 7 drugs in the literature had a known toxic dose or toxic blood levels. Exact toxic doses are not known for the rest of the drugs. Many of the manifestations of the drugs were from adult studies. These were the drugs, individual drugs. Coming to phenytoin, it accounted for the most increased duration of hospital stay. Sir? Carbamazepine. We had 2 cases of carbamazepine injection, and the classical description of anticholinergic symptoms were not seen in both of these cases. Thyroxine accounted for the most common injections. We didn't have exact details of the toxic dose of thyroxine. In many studies, we found that any dose less than 3 mg injection didn't have any symptoms. In my study, most were less than 1 mg. Most cases ingested less than 1 mg, and they didn't have any symptoms, except for 2 cases which had vomiting and loose stools. Ranitidine, classical description of hypotension and gait abnormalities were not seen in my case. In my case, I had a normal BP with giddiness and vomiting. These were the other drugs. Only these 7 drugs had a known toxic dose in the literature. To conclude, the clinical profile of pharmacological poisonings were present analyzed in my study. The drug thyroxine was responsible for majority of the case, and phenytoin was responsible for increased duration of hospital stay. The knowledge of pharmacological poisoning very sparse in literature. Even in many of the standard textbooks give mostly iron and paracetamol injection. Most common drugs like antiepileptic injections were not available in many of the literature. We need a multi-center studies to get to know the exact toxic dose and the exact symptoms, and which study needs, which persons need ICU admissions of the knowledge of the drugs. These were my references. Thank you.
The references are not nicely placed. And the second thing I want to say is how do you calculate the sample size in a retrospective study?
Sir, actually...
your sample was 40?
49.
How much is the study time period?
1 year, sir. We took all the cases admitted due to pharmacological injection in my hospital, sir.
Okay.
We didn't limit sample size, sir. We just wanted to know the incidence and spectrum of pharmacological poisoning in our hospital.
And the same point as I was focusing, every slide should have some heading, and some, in the last you need to give some message when you are presenting for a gold medal, right? So these things were my concerns.
So what is your final message with regard to poisons?
Sir, we usually get, we accounted for 30% of all poisonings. Still, we don't have exact symptoms and toxic doses. We are not aware, sir. Even in many standard textbooks, they just mention about iron poisoning and paracetamol poisoning, which were very less than those common poisonings like antiepileptics and thyroxine. So we need multi-center studies and multiple studies to get to know the exact toxic doses, because many cases we get, they don't know the exact amount ingested. They just bring the boxes and they say the child has taken these tablets, what to do.
Poisoning is common in children. Many times children are inarticulate, they cannot verbalize their symptoms. It is a very important and pertinent also, because we do come across cases of anti-epileptic drug poisoning. Very commonly, previous days we used to get confused. Child has got some organic problem. Actually, it was a case of phenytoin toxicity. Child used to swallow too many tablets once they are there. So therefore, poisoning is often missed. just now we have had a discussion on mysterious illnesses. One thing we need to keep in mind is possibility of a poisoning, especially in children. It is good you have taken such a topic for this presentation. We should appreciate that. Regarding the merits of presentation, other things we will discuss and settle. But it's good, and I congratulate you for having chosen that topic. Right?
Thank you, sir. Thank you.
Very good presentation.
So we'll take some more time, the judges, and actually behind the scenes there are a lot of people who helped, and Dr. Ajay Mohan sir and Bhaskar sir and a lot of other people, I don't want to name them. They have helped in shortlisting and make this possible. And thank you once again, CN Reddy sir and Bhaskar sir, for giving this opportunity. We'll take some time and let them know results.
I want to thank the judges and the coordinator. I would request them to come to the side stage for felicitation. I request Dr. Bhaskar to kindly felicitate our three eminent teachers from just now. The next item is Dr. P.S. Murthy quiz for practicing pediatricians. I request Dr. S. Sri Krishna to kindly come up onto the stage and take over the proceedings about the quiz. In the meantime, I would also like to kind of request all our organizing committee members of this conference to kindly stay on for the valedictory function. It is an honor to be able to be a part of the organizing committee of IAP TCB PEDICON. And it will be a privilege of all the office bearers to be able to provide and give some awards and thanks to all the organizing committee members. Thank you.
A very good afternoon to all. This is the last session of the conference, a unique conference, ending with a variety program. That is a Dr. P.S. Murthy quiz for private practitioners. And I would like to invite Dr. P.S. Murthy sir to the dais, sir. Youngsters should know about him. Is a walking encyclopedia of pediatrics. That's what I can say. When I met him for the first time, I saw his knowledge excellent, and he used to know which topic is there and which line is there in Nelson. After retirement also. It's not in the thing. After retirement from Nilofar Superintendent, he used to tell to the students for the DNB in Mahavir Hospital, I was surprised to see his knowledge and his experience. Then we thought that there should be some good program, variety program on the name of Dr. P.S. Murthy sir. And the moment when we thought of this, immediately all his students contributed the money and donated to TCB to have this special event. And we have started this first quiz in 2015 antimicrobial conference with the TCB, and since then 5 years over, and this is a 2020 quiz, and I request P.S. Murthy sir to say a few words.
Dear academicians and friends, all our discussions and all our deliberations for the last 2 days are towards helping the child and the parents. For the last 2 days we have been doing this exercise only to help the child and the parents. And most of the children and the parents, they go to the pediatric practitioners in the community. And so it is absolutely the pediatricians, the practicing pediatricians are doing wonderful work in maintaining, protecting and curing the children's ailments, and maintaining the health and curing the children's ailments. We have to be grateful to the practicing pediatricians for preserving our children in the best of the health. I have also one suggestion here. Now, this quiz is being conducted for the last 5 years, and the prize winners of the quiz are absolutely top in their academic knowledge and the practicing methods in pediatrics. So I have a suggestion to the professors and heads of the departments of the medical colleges here, and also to the administrators of the medical colleges to consider the winners of this practicing pediatricians quiz, and they take these winners as honorary faculty in their medical colleges. That will help, and feedback from the community and their experiences in the community will enrich the medical students further. This is my suggestion.
And we have 5 teams, and very enthusiastic persons came forward. And actually I expected much more also, but because of this present COVID rules, I think very few have come. But thank you very much for all 5 teams, and I request all 5 teams to come to the dais. And today's quiz masters are Dr. R.S.V. Sri Krishna and Dr. Pavan Kumar, who are the students of Dr. P.S. Murthy sir. R.S.V. I request the teams to come to the dais.
They need to come and then we can take it. We have 5 teams today. Request you all to please occupy your chairs, and we'll be taking a pick of lots, and then whichever is the team name, you can then move on. You can sit anywhere and then we'll start. Dr. Pavan, if you can quickly put up A to E.
Almost all these who are participating are really very busy practitioners also.
A to E. So I'll quickly describe the rules as we start. So we have 5 rounds, and the purpose of the quiz is not to find out the toughest question on the planet. It is not to test your intellect. It is not to test my knowledge either. It is just a celebration of pediatrics. It is just to refresh our knowledge and to probably look at that small point which we would have otherwise missed. So the intent is more of celebrating the subject than trying to assess each other. We'll have 5 rounds. Each round will have a direct question. We'll try to randomize as much as possible, and this randomization will try to blur the aspect of luck. And like it happens in life, you might get a question which you don't know the answer of, and you might get the answers of all the other questions for other teams. So it is just again down to what you have picked up literally with your hands. So had you been in any other of the teams, probably you would have got it. So the luck component is definitely going to be there, but it's very subjective. All the questions are probably easy, probably tough. There might be one odd tough question, but it's not the first question of every round anyways. So we try to put it randomly. In case you cannot answer a question or do not complete your answer within the 10 seconds, other teams get a chance to answer, and their answer will be in the form of writing it on the chits. The answers are not paragraphs, they are hardly 1 or 2 words. So make sure you just write a quick answer in the time which is given for others to answer it verbally. And we'll be giving you 10 seconds to write this down, and we'll take chits from you. In case you get the correct answer for a past question, when the main question was not answered, then each of you will get 5 marks based on if your response is correct or not. And we will definitely have some questions for audience, and I request all the people who are having your lunch outside, please come back in very, very quickly. Your chance to win some money immediately as soon as you answer it. So and I thank the organizers to go the extra distance and make it very interesting. So we'll definitely have audience questions, and Dr. Pavan will determine who gets the correct answer and how do we distribute it. Any queries from the participants, please let us know. So if you have...
So I request the participant to come and take the slips of their team wise. So in that I request the senior most Dr. Deshpande and Anil Kumar Tiwari to come and take the slip. Give a big hand to them. Really, the moment when I asked, immediately they accepted. Yes, please come. Slips is come. Srikanth. Which one? See, this. Center of attraction.
Dr. Sri Krishna sir, if you could announce the teams.
Which is it?
Team, no.
A.
So team A, yeah. So A starts from here. Team A, B, C, D and E. Oh, great. So you chose your seats yourself when you landed here. Great.
How you got as they are sitting?
One quick round of introduction, starting from team A, and then we can directly go to round one.
Okay. You can introduce.
Yes, sir. Chepan, sir. So we'll have top 3 prizes, 3 cash prizes for the top 3, and also answers given by the audience. They will also get a prize. We'll also give some special books because we can't really give you cash. For those of you who are watching this online, please type your answers in the chat box on YouTube. The participants really won't have that much time to look at the chat box on YouTube and then answer it. But please feel free to answer it. As I said, the purpose of this quiz is to celebrate the subject. So if we have a quick round of introduction, we go to round 1. The whole process will take about 40 minutes, not more. Team A.
Yeah, Team A, Dr. Amarnath Kulkarni from Lotus Hospital.
I'm Dr. Vinay from Muslim Maternity Chadagar.
Yes. No, sir. The prerequisite, and Sri Krishna sir has done the verification. The prerequisite is a student is not allowed. So anyone who is not a student is eligible, because once you finish your subject of pediatrics, you are now a practicing pediatrician. So in case you guys are students, please let us know. Second team.
I'm Dr. K. Swapna Reddy, working in Apollo Medical College, Jubilee Hills.
Hello, I'm Dr. Abhinav, practicing at Vidyanagar.
Go to mics.
Sir, Dr. Deshpande, private practitioner in Kachigoda area.
I'm Dr. Anil Kumar Tiwari, practicing in Kachigoda.
Hello, I'm Dr. Varaprasad, practicing in Malkasgiri.
I'm Dr. Sudhir Reddy, practicing at Secunderabad.
I'm Dr. Arvind, practicing at Sheikhpet.
I'm Dr. Srikanth, I'm practicing in Tolichoki, Medipatnam.
Okay. So I think we're good to start. Request to the audience, please do not prompt the wrong answer as well. And we're all good to start. The first round will start with team A, second round B, third round C. So we'll again randomize the start point as well. So are we all set? Quizmaster is ready. Co-quizmaster, Pawan? You're ready? Right.
Yeah.
I think Sri Krishna sir has also given us the go ahead. Organizing secretary sir, we can begin. Thank you. So round 1, the first question. Team A, are you ready?
Yes.
A little loudly?
Yes.
Yes, that's the Josh we want. So your first question, which is a direct question, all the other teams, please write down your answer in the time that they get to answer. So make sure you write it so that in case of need, we'll pick it up from you. We'll need one volunteer.
Volunteer, yeah.
One volunteer from the AV team to please help us in picking up the chits. Madhu, if you can send someone to just assist us in picking the chits. Yeah, thank you. So the first question.
Gopi. Ananda?
Yeah, so first question, team A, round 1. You can be here, ma'am. You can write. As per recommendations by IAP, name one contraindication for closure of patent ductus arteriosus.
Associated with...
Time up. So I heard associated with. I can't give you marks for that. So the other teams, please stop writing and hand over your chits. Please take it. Dr. Tiwari, please don't write any further. Whatever you have written, that should be fine. Audience, See, the first round is all, this is IAP quiz, and we picked up the recommendations which have come in Indian pediatrics over the past 1-2 years. So this is the recommendation on the timing of intervention of the common congenital heart diseases. So what is one contraindication for closing PDA? Yes, please. No prize, but please, yes, go ahead, you can say your answer. No? Anything else? So let's look at the answers, and the correct answer is this: PDA which is associated with severe PAH or a silent PDA. So I'm looking for the words PAH or silent PDA. So team B has written PAH, B for Bangalore. Pavan, team B gets 5 marks. Can we have a round of applause for team B?
Yeah.
So this is the ideal age of closure, and if you see the last line there, contraindication for closure, PDA which is associated with severe PAH and also a silent PDA. This is a class 3 level of recommendation. So the first question, team B gets 5 points. Team B, are you now ready for your direct question? If you're ready, please say it in the mic.
Yes, sir.
Yeah, loud and clear. So second question, direct question to team B. As per recommendations by IAP, what is the scoring system recommended for scoring severity of illnesses in PICUs?
PIM, PRISM, Apache 2.
Yes, I'll give it to you. PRISM is the correct answer. So this is again from the IAP guidelines for PICUs, which has been released in IAP very recently. So two scoring systems, PRISM or PIM, which are recommended for assessing the severity of illness in PICU. Big round of applause for team B as well. So B gets 10 marks. Team C, are you ready? In the mic.
Okay.
Yes. So team C, this is your direct question. As per recommendations by IAP, what is the advice during a COVID pandemic for a patient of chronic kidney disease on angiotensin receptor blockers for hypertension?
There is no specific thing. They can just be as it is, just like.
Yes. So the answer I'm looking for is whether to continue it or to change the drug or to stop the drug. The reason why is this relevant? Because of the ACE2 receptor, which is the focal point for the entry. So as per recommendations, we continue ARBs. So full marks to team C. Pavan, team C gets 10 marks. Team D, are you ready?
Yeah.
Yeah. So team D, this is your direct question. As per recommendations by IAP, what is the most commonly used scoring system for screening of cow milk protein allergy in developed countries? Others, please write the answer. They choose their chairs.
Pass.
Pass. So others, please. Yeah, both of you stand on the other side. It's easier to pick up. That's all, please. Anyone giving the chit? So cow milk protein allergy, there are guidelines on management given by Indian Pediatrics again. So anyone from the audience?
Team B, sir.
No one from the audience? Request those online also to please type in your answers in the chat box. As promised, we'll get back to you and give you a gift for the correct answer. So the correct answer is cow milk related symptom score. So there are scoring systems, and the most commonly used one is the COMISS. So please read the consensus guidelines on management of cow milk protein allergy. So only team B has written this. So team B gets 5 marks. Now fifth team, team E, are you ready for your direct question? So the direct question to team E are, as per recommendations by IAP, till what age in months should radio and TV sounds be avoided at home as part of auditory stimulation for early childhood development?
2 years?
I heard the answer 2 years. You would like to just modify it to the question? 24 months. So yes, 24 months we'll give it to them. 24 months. So team E gets 10 marks. So this is the new guidelines on ECD, again by recommendations by IAP. So visual stimulation, decoration of surroundings, auditory stimulation, it mentions talking, singing, recorded mother's voice, and then radio, television, etc. sounds should be avoided in the first 2 years. So till 24 months, try to avoid radio and TV sounds. This is recommendation. Yeah. So that finishes the first round. So while the co-quiz master prepares the scores, this is the audience question. Pavan, are you ready to identify people from the audience?
Yes.
So what we'll do is, so we're going to give this question up. Whoever would like to answer it and win 100 rupees on the spot, please raise your hand. As instructed by the organizing committee themselves are not eligible to answer this, but we would love to hear from you, but you don't get a prize for it. Right, so the question for the audience is, what is the most important clue on echocardiography in Kawasaki disease in the first week of fever?
You need to stand up and answer, please.
Anyone who wants 100 rupees on the spot? Yes, please.
Instant cash prize. Yeah.
Yes, please come forward.
Come forward and
you can say it. Yes, quickly. Your answer, aneurysm, is wrong.
Yeah.
The question is very specifically first 1 week of life. Please, 1 second. 1 second, sir. I need to know eligibility. Organizers, is the president Pats eligible? Lakshman sir, చెప్పండి.
PV Rao sir.
చెప్పండి సార్, చెప్పండి. Dilatation? No. PV Rao sir? No. Anyone else wants to take a guess? The catch is in the first week, and I'll show you the guidelines also.
Left ventricular dysfunction, reduced ejection fraction.
Yeah, somewhat nearer. So let's see the answer. The answer is myocarditis. See, this is the echocardiographic changes in Kawasaki. It is clearly written early changes, subacute and late changes. So early changes in the first week of fever, coronary changes are uncommon in the first week. The important clues are myocarditis. Myocarditis is the clue for Kawasaki disease in the first week of fever. It is not coronary. Coronaries will come later in the subacute and in the other changes. So if I had heard myocarditis, we would have given it. Can I pass this and put up the next question? Right.
Yeah.
So next question. This is a much easier one. Whoever wants to answer, please be ready to stand up.
Otherwise it will go to my
As per recommendation by IAP, what is the specific role of IV gamma globulin in symptomatic newborns with confirmed COVID? What is the role of IVIG?
Anyone? Stand up.
Anyone? No role is correct, and that is correct. So, Lakshman Garlapati sir, big round of applause for Dr. Lakshman Garlapati.
But I think sir is objecting that. Yeah.
Ichchedan sir. Decision by the organizing team is to give. Right. So that finishes the first round.
Yeah.
Thank you. Pavan, if you could read out the scores.
Yeah. At the end of that exciting first round, the scores are like this. Team B is leading with 15 points. Team C and Team E, they are with 10 points. And Team A and Team D has yet to start their innings.
So good luck for all the teams. I'm sure we'll be able to make up in the subsequent rounds. So here we go. So now Team B will get the first question. Yeah, you get the first question. So we further randomize it. The first one, if you think is the tougher one, now you have it. Team B, are you ready?
Yes, sir.
Yeah. So first question. Name the catecholamine which is indicated in warm shock, refractory to fluids and inotropes.
Noradrenaline.
Yes, noradrenaline is correct. So Team B gets 10 marks for the first question. Big round of applause for the direct answer. Team C, are you ready?
Yeah.
What is the mainstay of treatment for a child hospitalized with acute bronchiolitis?
it is basically supportive care with humidified oxygen and IV fluids.
Wonderful. So we are looking for the word humidified oxygen. I wouldn't have given it if you had just said oxygen. So team C also gets 10 marks. Big round of applause for team C. And for those who are seeing this online, even if you are seeing it later, please type in the answers in the chat box. I'm sure you'll enjoy it once you know your answers are right. Team D, are you ready?
Yes.
Yeah. Which trace element deficiency causes reddening of hair, weight loss, and hypocholesteremia?
Copper.
I heard the answer copper. Copper is wrong. So the others, if you could please write down which trace element causes red hair. Red hair is very significant. Audience? Anyone? Yes, please. Zinc? No. Zinc doesn't cause red hair. No, it's not selenium either. Yeah, so team B has written it correct. Manganese causes red hair. So team B will get 5 marks. Pavan? Team B, Bangalore, 5 marks. Now we go to team E. Are you ready?
Yeah.
Yeah, so this is your direct question. Name the term that is defined as the ratio of deaths between 22 weeks of gestation to 7 days of life to the total number of live births into 1000. So, the period between 22 weeks of gestation to 7 days of postnatal life.
Perinatal mortality.
Yes, so this is the correct answer. Perinatal, extended perinatal mortality rate to be specific. So, team E gets 10 marks. Team A, are you ready?
Yes.
Name the drug recommended in chikungunya fever with unresolved arthritis refractory to NSAIDs.
Naproxen.
I heard the answer naproxen, that is wrong. Other teams? So we see this very common. Earlier, probably 5 years back, we used to have a lot of cases of chikungunya which used to get better, but then the joint pains would never go off. They would continue to be there. So the drug recommended, again this is from IAP textbook. What is it that we give for unresolved arthritis even after they get better? Chloroquine is correct. So which team has answered chloroquine? B, D, E. So B, C, D, E. Dr. Pavan, all the 4 teams get 5 marks each. And also Dr. Arjun, but no prize for Dr. Arjun. The next question will come for him and also others for the prize. Audience, are you all ready for the question? Instant 100 rupees. Organizers, is Dr. Lakshman Galpati sir eligible for this question? After second question. Okay. Right. So name the national program that aims to achieve single-digit neonatal mortality rate and single-digit stillbirth rate by 2030. Whoever said it, if you could get up and say it, you might win a prize. Sir, please. Newborn Action Plan. That's right. So it is India Newborn Action Plan. So big round of applause.
Sir, cash prize. Thank you.
Instant
sir.
cash prize.
Instant cash
Thank
prize
you.
is nice.
So that finishes. We'll have another question, but no prize for this. The FAB classification refers to which disorder? Those who are online, please type in your answers. Yes, AML, specifically acute myeloid leukemia, not just leukemia. So AML is the correct answer. So that finishes round 2. Dr.
Yeah.
Pavan, scores at the end of round 2?
Yeah, scores are like Team B is leading with 35 points, and Team C and Team E both are at 25 points. Team D has opened their account with 5 points, and Team A has yet to open their account. Yeah. Team B is leading.
Great. So this is the most interesting round. We have endured 9 months of COVID all around us. Now time to quiz ourselves on COVID. So we begin with Team C. Team C, are you ready?
Yeah.
Yeah, so your first question in the COVID round, very specific on COVID and the vaccines. Your question is, in the current COVID scenario, what is the shortest acceptable interval between 2 doses of inactivated primary vaccine? And I have put up the recommendations by Indian Academy of Pediatrics. This is very specific from this recommendations which have come in December 2020 on immunization during COVID-19 pandemic.
21 days.
I heard the answer 21 days. I can't give it to you. Can the other teams quickly write down? What is the shortest acceptable interval? This is a very important recommendation released just a couple of days back on immunization during COVID. Those who are online, please type in your answers. If you get it right, you will get a wonderful prize. Audience? 14 no. No. Again, even as I was going through the guidelines, it was a little surprising number. So the answer is 24 days. So if you read this particular paragraph again from the same recommendations, we may use the shortest acceptable interval between 2 doses of the same vaccine if the prospective vaccinee reports to the health facility and is unlikely to come for a follow-up, be it that they are from a different place or may travel. What is the minimum period for an inactivated primary vaccine? This is 28 minus 4 days, that is 4 days. So you can just subtract only 4 days from the period of 28. So anyone who has written 24 gets it. 23 I cannot give you. 23 will become ineligible actually. You have to wait for 24. Anyone else who has given? 4 weeks is 28, 7 into 4. He has written there, sir. The minimum possible. I think we will not be able to give this. We'll try to adjust it elsewhere. Right. So no marks for anyone, but a very good learning point for us on COVID. The next question.
The gap between 2 doses practicing in West is 21 days. It should be more than, less than 21 days. How can it be more than 21 days?
Yes, sir. So we'll ask this question to the ACVIP committee, which has written this particular recommendation. So from our end, from TCB conference, request the organizing secretary to please pass on this query to the ACVIP. This has come in the recommendations and I've directly picked it up from the recommendations. So it is 28 minus 4 days. Thank you, Dr. Arvind. Next direct question to Team D. Are you ready?
Yeah.
Which 2 vaccines have been shown by observational studies to have association with lower mortality due to COVID?
BCG and MMR vaccine.
Yes, BCG and MMR are correct. So BCG and MMR clearly mention that they have some role in controlling. Just an extension question, you get your 10 marks. Does IAP suggest to give these vaccines? Yeah, so there is some role, but evidence is not strong enough for us to recommend putting it into practice and giving a vaccine, at least as yet. So Team D for Delhi, gets 10 marks. Direct question, Dr. Arvind and Dr. Srikanth. Read the question carefully. What is the recommendation on hepatitis B vaccination for an asymptomatic COVID positive newborn born to a COVID positive mother? Very common scenario. A COVID positive mother, no symptoms in the newborn, absolutely normal, but when you test it, COVID positive.
Continue the regular universal immunization program. There is no need to alter it. We can go ahead with the hepatitis B vaccination.
So when you say regular, which day of life would you like to give it? Which day of life hepatitis B vaccination?
At birth we can give.
So your answer is at birth?
Yes.
Shall I take that as an answer? Ask the other teams to please write down your answer. So, asymptomatic COVID positive newborn born to a COVID positive mother. Now the baby and the mother are in front of you. So when do you want to give the hepatitis B vaccine? Your answer was at birth. We will just look at what the exact table shows. So the table shows us like this. So you have different clinical scenarios. So sorry, yeah. So if you see DA, it is COVID positive mother, COVID positive but asymptomatic newborn. You continue, the status is, it's a confirmed case. Hepatitis B is given at the time of discharge, but any time less than 15 days. So we delay hepatitis B, BCG, and also OPV to be given at the time of discharge. So the words birth we cannot really take, because at birth will be for those with only the clinical suspicion. These are scenarios where it is proven COVID positive mother, COVID positive asymptomatic newborn. So the learning point is it needs to be given at the time of discharge, not exactly at the time of birth. Yeah, but I think the word is very sir, you have a strong support for team E, but very clearly it is at the time of discharge. So if I find discharge written by any of the other teams, then we'll try to look into it. So team B has written before discharge, so we'll have to give it to team B. That's a fair answer. So team B, 5 marks. At the time of discharge. No, sir. I think we will. No, none of them get any marks, because at the time of birth is actually wrong. We won't be able to give at the time of birth if it is COVID positive newborn. Yeah. So yeah, I think the point is at the time of discharge. Before is a wrong word. So no one gets any marks. Thank you, Team E, for clarifying it. Team A, are you ready for your direct question? Yes, sir. No. It is very clearly written at the time of discharge. Now, Team A, are you ready?
Yes.
Yeah, your direct question is, name the digital platform for COVID-19 vaccine delivery. Time up. Anyone from the hall, online? This is going to be the Swiggy, this is going to be the WhatsApp of 2021. This is the app all of us will end up having in our mobiles. If you want a vaccine, you will need this. Even if you don't have it, at least this app is going to be used by all the hospitals, all the vaccine deliveries. Everything related to COVAX is all digital. And what is the vaccine delivery digital platform? Anyone? Answers? No one? So, audience, anyone? Yes, sir. Yes, CoWIN. So, win over. I think this came up late, or did you collect it in time? You took it in time. So, team B gets 5 marks. B for Bombay or Bangalore. So, CoWIN is the digital platform for COVID-19 vaccine delivery. Everything is on this platform, right from identification till session site preparation, AEFIs, getting a digital result. Everything is on this digital platform and on the CoWIN app. So, the next, yes, sir, all that will come up probably in another 1 week. Everything will be clear on this. No, sir, this is all government. We are supporting only the framework. Next, team B, are you ready for your direct question?
Yes, sir.
Name the 2 receptor proteins which are expressed in enterocytes which facilitate entry of the SARS-CoV-2 virus from the GI tract.
ACE2 receptors and serine protease for TMP.
Yes, that's also right. So, ACE2 receptor and the serine protease 2 receptors. So, team B gets 10 marks. So, we finished round 3 on COVID. One audience question, co-quiz master, are you ready? So, for those who are online as well, so we have often seen how COVID will occur or mimic flu. So, the question for the audience is, what is the drug that needs to be considered in all patients of COVID-19 in case there is an outbreak of seasonal flu? We didn't have an outbreak, but if there is an outbreak, and a patient of only COVID-19 symptoms and with a confirmed diagnosis, what is the drug that Government of India had clearly written to be given?
Stand up and 10, please.
This is in an outbreak of seasonal flu.
Yeah.
Yes, please.
Yeah. Oseltamivir?
Yes. So oseltamivir becomes a
Dr. Vijayalakshmi gets
prescribed drug in the case of
Dr.
seasonal
Jayalakshmi
flu.
gets cash prize. Yeah.
Yes. So in case there is an outbreak during the COVID season, oseltamivir becomes the drug to be considered in all patients of COVID-19. So whenever there is an outbreak of flu, this needs to be given. So thank you, audience. So another question for the audience: how can you minimize aerosol spread during intubation and suction of a newborn born to a COVID positive mother? Yeah, so COVID positive mother, baby has got some distress, you need to intubate. How do you reduce your risk? What is that particular small apparatus that you use? So you need a barrier. Shield won't be enough. Shield will not be enough. Anyone online, please type it in the chat box. So the answer is a plexiglass box. So you need to use this, again from the recommendations of Indian Academy of Pediatrics. Routine suction is not indicated for clear or meconium stained amniotic fluid. Endotracheal administration for medicines should be avoided as much as possible, and indications for intubation will not change. If the child needs intubation, we'll do it. But plexiglass box with access potholes can be used to minimize the aerosol spread, specifically during intubation. So that finishes the COVID round. Co-quiz master, if you could read out the scores.
So after that exciting third round, we see Team B is still leading with 50 marks, and there is a tug of war going on between Team C and Team E with 25 marks, and Team D with 15 marks.
Yes.
So give a good round of applause.
So big round of applause. Now the last one, this is no pass round. So this is a visual round. And Team D, are you ready for your first question? Can you see it here and also there? Yeah. Right. Team D, your direct question, and it doesn't pass to others, so you all can just see the image.
Right.
What is the scoring system that is depicted here with mean blood pressure, temperature, birth weight, serum pH, urine output? What is the score? Your time is up.
Birth asphyxia.
No, there's a specific name, and in IAP textbook of pediatrics, this score is specifically mentioned. So this is called the SNAPPy-2 score. So score for neonatal acute physiology and perinatal extension. There are many scores. There are only two scores that find mention: PRISM and SNAPPy-2. Next direct question, Team E. What is the diagnosis of this condition in a preterm with RDS?
HMD, hyaline membrane disease.
HMD is correct. So this shows diffuse haziness, blurring of the cardiac margins at the broncho and air bronchogram. So Team E gets 10 marks. Team A, are you ready?
Yes.
Name this condition.
Cephalid spot.
Condition. Yes, so neurofibromatosis 1 and the cephalomacules in NF1. So Team A gets 10 marks. Team B, are you ready?
Yes, sir.
Name the component in the center of the foot square for the young child as depicted here. So you have the staple, the protein food supplement, vitamin supplement, and energy supplement. What's in the center? Time up. Anyone from the audience? Very interesting, very nice question. Again from IAP textbook of pediatrics. So this is the core of the foot square. So you have a foot square and something that is very important in the center. Anyone? Any quick guess? No, no. I'm asking for an infant or a young child. Yes, breast milk is the correct answer. So look at this. This is from the IAP textbook, adapted from Elizabeth's book. Breast milk is at the center of this. Who answered it? Thank you, ma'am. Thank you. So next, direct question to Team C. Name this condition which is evident on contrast enema.
Hirschsprung's disease.
Hirschsprung disease is correct. So 10 marks to Team C. So that finishes the last round. So no questions will be screened on the screen. So we have a very quick rapid fire of 30 seconds for each of you, and then we'll be able to close. So the end of fourth round. Co-quiz master, scores please.
So still it's going excitingly. Team B is leading with 50 marks. And there is again tug of war between Team C and Team E at 35 points. And Team D at 15 points. And Team A has opened their account with 10 points. Give a good round of applause, please. Yeah.
Yeah. AV team, you don't share my screen. So let just my visual be on the screen. Don't share the screen. So we'll do the rapid fire, starting with Team E. Yes, I'll tell you. So we have 6 questions for you, and we have 60 seconds to answer, which is 1 minute. 6 questions, and I'll put the question to you. I'll wait for you to answer. You can take full 60 to answer 1 question, or complete them in due time. But I'll be able to go back to the first question or the second question only if I finish the 6th question. Each question has 5 marks. So this round is worth 30 marks in just 1 minute. You have to take a judicious call whether to skip the question or to answer it. No negative mark. So whatever you know, you can say it. Whatever I hear first, I'll take that as your answer. So, yeah, you can pass it. I'll come back to it. Thanks for asking. Pass has no marks. So you can pass, but I'll come back to it as long as we can finish within 1 minute.
Very interesting round. Results may topsy-turvy. So we'll see what will happen. Any miracles happen, we'll see.
Right. So let me just start the... Team E, are you ready? Your 6 questions start now. Expand the COP module by IAP. COP. Pass. Expand CPR. Low C3 is an indication for renal biopsy. True or false?
Yes.
I heard yes. Most common...
No. Sorry, no.
I heard yes, and I'll take it. Most common malignancy in childhood is... Most common
ALL.
malignancy in childhood.
ALL.
I heard ALL. Which hypervitaminosis causes hyperostosis of long bones?
Vitamin D.
I heard D. Last question. Dose of oral acyclovir in varicella is?
20 milligram per kg per day in 80 milligram per kg per day in 4
I heard
doses.
20.
4 doses.
Yes, fine. I asked, okay, right. So 20 mg per kg per dose. So that finishes your 6 questions. First question, expand the COP module by IAP.
Which module?
COP. COPP.
COPE.
COPP. We had a workshop, I believe. No, it's a past question. Come back to you. Time is up anyways. All right. Anyone from the audience? COP module, COPP. So this is common office pediatric problems. No marks for that. CPR is correct. Low C3 is an indication for renal biopsy. I took it true. True is right. Low C3 is an indication. You can do a renal biopsy. Most common malignancy, ALL, is correct. Vitamin A will cause hyperostosis of long bones. So you said D, so no marks for that. Oral acyclovir is correct. So you get 1, 2, 3, 4. 4 questions, 4 into 5, 20 marks. Team D, are you ready?
Yeah.
A big round of applause for Team E. That finishes their session. Next, Team D, your time starts. Now, expand the EPIC course by IAP.
Pass.
I heard pass. Expand BLS. BLS.
Basic life support.
I heard basic life support. True or false? Anemia and chronic kidney disease is normocytic.
True.
I heard true. What is the most common cause of Cushing syndrome in children?
Drug induced.
I heard drug induced. What is RDA for fiber per day?
Idea?
Fiber.
10 grams per day
I
per
heard
kg per
I
weight.
heard 10 grams. Last question. Duration of benzathine penicillin in acute rheumatic fever primary prophylaxis. Duration. How many doses or how many times?
If there is no underlying heart disease, it's for 5 years until the last episode. If there is underlying heart disease, you continue it at least until the adulthood.
Right. So that finishes their answers. You want to take EPIC, you have 5 seconds.
No.
Time is up. Right. So EPIC course, anyone from the hall? Excellent, excellent. Big round of applause. So that is EPIC. BLS is correct. Anemia is normocytic in CKD, that is correct. Prolonged drug use or steroid use is also correct. RDF for fiber you could not say, and then benzathine is correct. So you get 4 correct answers. So 4 into 5, 20 marks. Yeah, fiber RDA is 0.5 grams per kg per day. So now we come to Team C.
Yes.
Are you ready? Your time starts now. Name the IAP module for early intervention and child development.
Pass.
I heard pass. Expand WPW syndrome.
Wolff-Parkinson-White syndrome.
True or false? Oral nifedipine is used in hypertensive emergencies.
Yes.
I heard yes. Most common rheumatological disorder in childhood is?
Idiopathic infantile idiopathic arthritis.
Okay. Steinberg sign is positive in?
Pass.
I heard pass. Name the antiviral drug used in Nipah virus management in India.
Pass.
I heard pass. You want to take up IAP module for early intervention and child development? Steinberg sign is positive in 5 seconds. Antiviral drug in Nipah virus management. Sorry, your time is up. So you got 3 questions right. WPW is correct. Nifedipine is correct. JRA is correct. And where do you see Steinberg sign? Marfan syndrome. What is IAP module for early intervention and child development? We had this last year in January. Dr. Bhaskar sir, I remember his messages. This is Cradle to Crayon. Cradle to Crayon is a workshop. We had it in Hyderabad. What is the antiviral drug used for Nipah virus management? We didn't get this case, but no. Ribavirin. Ribavirin is the antiviral drug used in Nipah virus. So 3 questions correctly answered. Quizmaster, co-quiz master, 15 for Team C. Team B, are you ready? So big round of applause for Team C. That finishes their innings. Right. So next, Team B, are you ready?
Yes, sir.
So name the patient education service by IAP.
Next.
You said pass? Next. Okay, say pass so that it's easy. Expand HOCM.
Hypertrophic cardiomyopathy.
I heard hypertrophic cardiomyopathy. Thalassemia is also known as Cooley's anemia. True or false?
True.
I heard true. Most commonly fractured bone in a newborn is?
Clavicle.
I heard clavicle. Death from thiamine deficiency is secondary to which organ system involvement?
Cardiac.
Cardiac. Mention definitive indication for use of Lorenzo's oil therapy.
Alexander disease.
I heard?
Leukodystrophy.
I heard Alexander first, so I'll have to take Alexander as your answer. So that finishes your innings. Big round of applause for Team B as well. So what is the patient education service by IAP? It's called the IAP Potion Project. HOCM you missed O, so I can't give it to you. You said hypertrophic cardiomyopathy if you missed the obstructive part, so no marks for that. Thalassemia answer is correct, clavicle is correct, cardiovascular is correct. You got adrenoleukodystrophy, but you said it second, so I can't give that either. So 3 correct answers, 3 into 5, 15 marks for Team B. Now, Team A, are you ready?
Yes.
Yeah. So this is the last segment. What is the objective of 10 by 10 capsule of IAP?
Pass.
I heard pass. Expand SVT.
Supraventricular tachycardia.
True or false? Target cells are seen in post-splenectomy patients.
True.
I heard true. Most common genetic cause of osteoporosis is? I heard pass. Which trace element deficiency causes Keshan's cardiomyopathy? I heard zinc. What is the dose of adenosine in the management of SVT following the failure of the first dose? I heard 0.1 mg per kg. You want to take up the other questions?
Yes, repeat please.
Yes. 10 by 10 capsule by IAP.
Next.
Most common genetic cause of osteoporosis.
OI.
OI is correct. Osteogenesis imperfecta. That finishes it. So 10 by 10 capsule by 2020 by IAP. What is it for? For newborn survival. They couldn't answer that. SVT is correct. Target cells is correct. OI is correct. Keshan's cardiomyopathy, I heard zinc. I can't give it to you. It is specifically selenium. And adenosine in the management of SVT after the first dose is 200 micrograms per kg. So 0.1 would be very less. We can't stick to 0.1. So it will be 3 correct answers, 3 into 5, 15. And that's the end of the quiz. Thank you, audience. Thank you for your patience and your very active participation. Now I request Dr. Pavan to please announce the scores and let me know if there is a need for a tie break.
Yeah, fortunately, that's a big relief for the quiz masters. There is no tie break. It went tug of war from the beginning. But the results are, I think I request Dr. Sri Krishna sir to announce the results.
First, I appreciate the quiz master, Dr. R.S.V. Sri Krishna, for taking so much of strain to collect the questions. In fact, the pain for the quiz master is much, much higher compared to the participants here. I know that because previously, that's why I just switched over my job to him many times. So, the team A. Yes, I invite the president of IAP TCB, Dr. C.N. Reddy sir, to come to the dais. Secretary, Dr. Bhaskar, and Treasurer, Dr. Sridhar.
Please share your comments.
And P.S. Murthy sir also, sir.
P.S. Murthy sir, we invite you to come on to the stage, please. C.N. Reddy sir, few comments for you, for the quiz masters as well as the participants.
So the total score is that the team A got 25 marks, team B got 65 marks, they are the winners. Team C got 50 marks, the third position. Team D got 35 marks, and Team E got 55 marks, that is second position. So the winners are Team B with Dr. Swapna and Dr. Abhinav. First prize. Photo, sir. The second prize goes to Team E, that is Dr. Srikanth and Dr. Aravind. Every participant here is getting cash prize. మాస్క్ పెట్టుకుంటే ఫోటో దిగి లాభం లేదు శాస్త్రి తీసేయి ఛాన్స్ లేదండి అవునా అక్కడ ఫోటో తీస్తారు లేదా హైఫై సార్ హైఫై పాంచ్ పటాకా And a third prize goes to Team C. This is Dr. Deshpande and Anil Kumar Tiwari. The senior practitioners, really, when I asked immediately they accepted. I should thank them. Really. And even other participants also have the cash prize. I request Team A, Dr. Amarnath and Vinay. And Dr. Sudhir and Varaprasad. Yes, that is for ఒకసారి ఫోటో తీసుకుంటారు ఫోటో ఇక్కడ కంగ్రాట్స్ యాజ్ యూజువల్ ఎవ్రీ టైమ్ పార్టిసిపెంట్స్ ఆల్ ఆఫ్ యూ ప్లీజ్ స్వప్న సార్ ఆడియన్స్కి 100 రూపీస్ ఇచ్చారు సార్ స్పెషల్ అప్రిషియేషన్స్ టు క్విజ్ మాస్టర్స్ కొంచెం అప్రిషియేట్ చేయండి.
So really, I thank today's quiz master, main quiz master Dr. Sri Krishna Garu, yes, and quiz master RSV Sri Krishna, and Mr. Pavan, who had done the scoring system very well without having any confusion for the participants. And in between also we had some breakfast.
some cookies and other things. But he was not at Kaliga aithe ledu. So went very well. Thank you for the quiz masters, 3 of them. So now comes to the, please. This is the certificate of merit to the quiz masters also from PS Murthy sir. Yeah, please go ahead.
I request all the participants who are there in the hall, please remain seated for another 5 to 10 minutes, because we are going to announce the
Please
gold
stay
medal
back.
paper.
We are going to have a valedictory function after completing the exciting Dr. P.S. Murthy sir's quiz. We enjoyed academics. Now please stay for at least 5 to 10 minutes only. We will complete the valedictory function. Good afternoon to all of you. On completion of these 2 days, 26th Annual Convention of Twin Cities Branch by IAP TCB, we thank you all for your participation. First of all, I thank all the respectable seniors who has given academic support throughout the year and also in the conference. I sincerely thank all the respectable seniors, and I also thank all the organizing team who has taken part and who made this conference a great success, a memorable event in the history of IAP TCB. This 2020 was very, very rich, and we have contributed a lot of academics with the support of our team, our dynamic secretary, Dr. Bhaskar. Always he was thinking of the quality of the academics, and he was search of speakers and moderators. We thank all the about 100 speakers and moderators who have supported us for this webinars. I thank Dr. Pawan Kumar, President 2020, who has given an extraordinary academic support to us. I also thank Dr. Sridhar behind this, all the events, and he has taken lot of pains. He has spent sleepless nights and organized the conference and made it memorable in the history of Twin Cities branch of Indian Academy of Pediatrics. Thank you, Sridhar. Thank you, Dr. Bhaskar. And I also thank President-elect Dr. E. Arjun Garu, and he has supported like anything, and he was with us, and he was very much cooperative during 2020. I thank all the EB members of Twin Cities, Dr. Vaidyam Chakravarti, Dr. Suchitra, Dr. Laru Prasad Yadav and Dr. Ajay Mohan, and PATS President Dr. Lakshman Garu. Also, he was very cooperative, and now this organizing team, without which we could not have success. Organizing chairperson, I invite Dr. Darul Ranganath Garu. If he is in the hall, please come on to the dais. Dr. Ravi, please take on behalf of Dr. Darul Ranganath Garu, organizing chairperson. Who is, no, you take, please come, Dr. Ravi. Jigri dost of, Dr. Ravi is Jigri dost of Darul Ranganath. And on behalf of Darul Ranganath, we will hand over the memento. Hello. Thank you very much. Thank you very much, Ravi, for handing over the memento. Next I call on reception committee chairperson, Dr. E. Arjun. If he is in the hall, please come on to the dais. If he is not there, anybody is Panch Pataka, what you told? Srikanth Manda. Okay. Next, election. Now I request election committee. Election Committee, Chief Election Officer, Dr. Naunihal Singh, who has contributed a lot and made the elections unopposed. After a long time, he made the elections unopposed. Please come and take the moment. Now, I call Anil Kumar Tiwari, Dr. Anil Kumar Tiwari, election officer. Lunch lo unnadu, okay, afterwards. Dr. Dayal Singh, he was another election officer, if he is not coming. Okay. I request Dr. Naunihal to hand over the movements on behalf of Dr. Dayal Singh and Anil Kumar Tiwari. Please hand over. Thank you very much. Registration committee. Registration committee. Now I call registration committee Dr. Vaidyam Chakravarti. If he is in the hall, please come and take. Dr. Vaidyam Chakravarti is not there. Dr. Lalu Prasad Rathod, Dr. Srikanth Manda, Dr. Srikanth Bhatt, Dr. Srikanth Sandanala. Scientific Committee, Chairperson Dr. Sanjay Srirampur, Dr. P.V. Rao, Venkateshwar Rao. You can come and take the memento on behalf of scientific chairperson Dr. Sanjay Srirampur. Please come and take the moment.
అంటే నిన్న ఈబీ మెంబర్ది కూడా ఇప్పుడే ఇచ్చేస్తున్నాను.
Thank you, Dr. Venkateshwar Rao garu. Now I invite co-chairperson, Scientific Committee, Dr. S. Sri Krishna. Dr. S. Sri Krishna, please come on to the dais. Thanks for your contribution. Next. Convener, Scientific Committee Convener. Now I request Dr. Ajay Mohan, convener of the Scientific Committee. And throughout the year, he has helped us in conducting PG classes and clinical meetings. He is our EB member, and academically, he has given a lot of support to team IAP TCB 2020. Ajay Mohan. Thank you. Thank you. Thank you. Thank you. Now I call the members of Scientific Committee, Dr. Alimelu. Madam, please come on to the dais. Next, Dr. Basavaraj. Dr. Preetham. I request now Dr. Lakshman Garlapati garu, Chairperson, Trade Committee. Lakshman Garlapati garu. Thank you, madam. Thank you very much, madam.
Thank you, sir.
Please.
Dr. Lakshman Garlapati, Trade Committee Chairperson, and PATS President, and also EB member. He is holding. He is three posts. Thank you, sir. Thank you, sir. PATS President, EB member, past President. Next. Venue Committee. Venue Committee member. Now I request Venue Committee Chairperson, Dr. Srinivas Kalyani. Kalyan Srinivas. Thank you very much. 2 days you have restlessly worked for us, managing the conference, especially time management. He is an expert in time management for the conferences.
Thank you, sir. Thank you.
Thank you. Thank you.
Thank you.
Now I call Chairperson Dr. Pavan Kumar. Chairperson, Venue Committee, co-chairperson. Pavan is the chairperson. So thank you, Pavan. Thank you, Pavan. Now I call Dr. Suchitra Madam, Venue Committee, convener of the Venue Committee. Madam, thank you very much. For your continuation, రండి.
Thank you.
You did a wonderful job. Thank you very much, Suchitra madam. Now I will request Dr. R.S.V. Sri Krishna to come on to the dais. He is the convener of venue committee. Expert in event management, time management, and expert in technical expert in conducting webinars. He has contributed a lot to our webinars, and also he has contributed a lot to IAP TCB. Thank you. Now I call Dr. Nitesh. Since yesterday he was organizing live programs with the expertise comments. Thank you, Dr. Nitesh.
He deserves a big applause.
Yes. Wonderfully managed.
Yeah.
Very well. We expect all the support from you. Next name is Cultural Committee. Dr. Srilata Martha garu. Please come on to the dais. Okay. Next. అయిపోయింది. Next. Come madam. Next. Our Kala Prapurna IAP, Dr. Krishnamurthy garu, Cultural Committee Chairperson. Please be ready. Come to the front. Cultural expert of IAP TCB. Oh, no. Okay.
No, he's a true cultural secretary.
He is the guide to Krishnamurthy.
Yes.
He is guide
Krishnamurthy.
and is the guru of the Krishnamurthy.
First Krishna, second Krishna, third Krishna laga.
Vice President 2021, Dr. N. Ravi Kumar garu. National. See? In charge of. He is the in charge of Central Zone IAP, consisting of 5 states. He is representing 5 states. He is the Vice President of 5 states.
Thank you very much.
Neil Ramchandar Nayan Reddy garu unnara? Yashwantrao, Dr. Yashwantrao, Dr. Narahari.
మీరు మాట్లాడండి, రిమార్క్స్ చేసేయండి, క్లోజింగ్
మోస్ట్ అవైటెడ్.
ఏం చేద్దాం? థ్యాంక్స్.
పోస్టల్ ప్రెజెంటేషన్.
Postal presentation.
వంశీ ఉన్నాడా?
Vamshi Gondle. Please come on to the dais. Dr. Vamshi gold medal papers. Postal presentations.
At the outset, I thank the President, Chief Organizing Secretary, Dr. C.N. Reddy sir, Dr. Bhaskar sir, who is the Organizing Secretary, and all the members of IAP. And it was our pleasure that not to discourage any of the PG, we have accepted all the posters. We got total of 16 posters. Yes, the guidelines were correctly followed, and we did not have any disparity, though it was from my own institute. So the judges were U. Narayan Reddy sir and Tilak Chandrapal sir, and unbiased, they have given their judgment. So we'll start with the participants to collect the certificate. I request all the poster presentees, whoever are here, please come on dais one after the other. All the poster presentees, please come and collect your participation certificates. And finally, I'll announce the winner of the poster. Participation was more rather than getting a prize in it. So IAP TCB has encouraged all the postgraduates. So it is a very good thing. So next year, we will see much more posters coming up.
I'm Dr. Pooja from Malareddy Institute of Medical Sciences.
I'm Dr. Manasa from Nilofer Hospital. Dr. Haripriya from Nilofer Hospital.
Dr. Jayasandesh from Nilofer Hospital.
Dr. Rufus Rajkumar from Medicity Institute of Medical Sciences.
Dr. Lohit from Gandhi Hospital.
I'm Dr. Soumya from Gandhi Hospital.
I'm Dr. Sai Babu from Gandhi Hospital.
Thank you.
I'm Dr. Aravinda Lochani from Ankura Hospital.
Dr. Raviteja from Ankura Hospital.
Dr. Anusha from Apollo Medical College.
Dr. Sneha from Apollo Hospital.
Dr. Tahira from Apollo Medical College. All the posters were best. I think all the audience have seen whoever present here. Online, of course, we could not show them, but there is a virtual room that was created, as said by Dr. RSV Sri Krishna, sir, that once you log into that, then you can go through all the posters as you are in the virtual room. So that link will be shared soon, and the comments also can be posted accordingly. So that's the biggest thing, sir. That is a suspense. We need to wait for that. So. Yes, the poster presentation for the year 2020 IAP TCB PEDICON. The best poster goes to Dr. Manasa. Institute of Child Health, Nilofer Hospital. Second, we have Dr. Jaya Sandesh for his presentation on diabetes mellitus gateway to something bigger from Institute of Child Health, Nilofer Hospital. Institute of Child Health, Nilofer Hospital. Yes, sir. Thank you, one and all, for giving this opportunity.
Actually, all of them, all the posters were so good. Judges had tough time to decide. So somebody has to win. Yeah. Thank you for helping me. Yeah. Yeah. Now I invite Dr. Vamshi kindly. Yeah, the coordinator for this. Dr. Chandrasekhar Chaudhary, gold medal. Please make some remarks and.
26th annual convention of IAP Twin Cities have been held successfully under the leadership of President C.N. Reddy sir and Sunkosh Bhaskar sir and N.L. Sridhar, my friend. And it's time for now for announcing the gold medal paper presentation, Dr. Chandrasekhar Chaudhary gold medal paper presentation. Can anyone guess? Okay, sir is saying Nilofer. Anybody can guess?
Now I request Dr. G.V. Subramanian garu, please come over to the dais, and Dr. T. Anant, another judge for this Dr. Chandrasekhar Chaudhary gold medal. And I invite Dr. Ajay Mohan to be on the stage. He had contributed a lot for this Dr. Chandrasekhar Chaudhary gold medal. May I invite Dr. Usharani? That might give you some clue. HOD from Nilofer. President, మీరు అనౌన్స్ చేయండి. ఎవరికి వచ్చిందో చెప్పండి. అందులోనే ఉంది కానీ ఎవరికి వచ్చిందో చెప్పాలి కదా. ఫస్ట్ ప్రైజ్ సెకండ్ ప్రైజ్ ఒకటి మెడల్ గోల్డ్ మెడల్ డాక్టర్ గ్రీష్మ ఫ్రమ్ నీలోఫర్. And now I am announcing Dr. Girishma from Neelafar Hospital. Dr. Suchitra, please come on to the dais. Dr. Alimelu, please come on to the dais. Preeti Nagaraj, Dr. Preeti Nagaraj, please come on to the dais. So many are. Dr. Srilata Martha, please come on to the dais. Congratulations.
Yeah, on behalf of the institute and my faculty, I congratulate Dr. Girishma. She is one of the finest way she presented, and she has, of course, all are equal. 0.001, she is better. I think because the weighing machine is with the Subramanian sir. He is a one person. I cannot influence, you know. Sri Krishna, you understand? Huh? So he is known for his simple thrust balance. So like that, he will measure like a gold. So in spite of all the tough competition, she could able to win. So this victory is, though it is for the postgraduate, but all the faculty, all the postgraduate has to celebrate. And I encourage all the postgraduates and the Sri Krishna, within a short period, he could able to produce 4 papers from the Apollo. So excellent work. I want everyone to encourage the postgraduates, like how the Sri Krishna, ninnu pilavaledu, akkade undu nu. Da. Anyway, he is also product of Nilofer. Come. So I want all the faculty, please encourage your postgraduates in this way, so that you will get immense pleasure. Thank you very much for giving this opportunity.
Thank you, Ravi.
All the postgraduates who have presented here, they have done very well. It was in fact a tough job for all the 3 of us. There was a discussion, we tried to do our best. There was absolutely no scope for any influence or bias by any of us, honestly speaking. We were just going by the fact of how far it is utility, community perspective, what is the degree of utility, and also to what extent it is cost effective in a country like ours where it has got a larger application. So with that point of view, I think we have decided, we tried. There are other things also meeting these criteria, but I think this is the one. But others are also have done well. My congratulations to all.
Dr. Usha Rani, HOD, can you reveal the secret of the success of your students?
Teamwork, sir. Teamwork, I would say. And the hard work of the students and also the encouragement of all the faculty. All the faculty work together like a team and we've encouraged. And of course, the main initiative is from the student itself. Inherently, it should come, then only it will work out. So I congratulate all the PGs. And I'd like to congratulate the organizing team of IAP TCB, Dr. C.N. Reddy Garu, Dr. Bhaskar, Dr. Sridhar, and all the others who have conducted such a wonderful conference in spite of the COVID challenges. Actually, I was hesitant to come yesterday, but today I felt a little free and confident to come out in this gathering. So we are socializing. Thank you so much. And at the end of the conference, I'm a happy person. There was a very good representation in the organizing committee, academics, as well as in the gold medal papers, and also the posters. I'd like to congratulate all the candidates. Thank you.
No, sir. This is also, I think the credit goes to Krishma also. I did guide her. Yeah. But she did lot of statistical analysis and she used the software in a very good way, and even whatever improvement I did, she did a step ahead in that improvement. So I think Grishma also deserves. Yes, sir. Thank you, sir. Thank you.
Thank you, but organizing committee has forgotten to bring the medal, the gold medal. I'll search my pockets. If it is there, I'll give you.
We'll send it.
Our office, it is there. Appeared. Magic.
Magic. Yeah, great. Good. Congrats, Amma. All the best.
I'm responding.
Dhamma, you want to tell me?
I have no words to say. I'm extremely thankful to Dr. Isharani ma'am, Dr. Alivelu ma'am, and Dr. Ravi Kumar sir for always encouraging us for these academics. They always say us to present posters, papers. Now we have come to know that value. I'm really speechless. I'm very thankful to my guides.
That's great.
Thank you, Grishma.
So, అది పర్లేదు. Dr. Srikanth came now. Sir, Srikanth Manda, please. Sir, Randi, sir. He is one of the organizing committee member in the reception committee. Yeah, thank you.
Thank you very much.
Thank you.
Paper presentation. Excellent. Thank you, sir.
Thank you.
Quiz lo participate already. Sir, thank you, sir.
Poster ikkada undi, sir.
Excellent show.
Poster ikkada undi.
Thank you, sir.
Paper presentation. మీ దగ్గరనే పేపర్స్ ఉన్నాయి సార్.
అందరు గవర్నమెంట్
మళ్ళీ బోర్ కొట్టేసా అందరూ వెళ్ళిపోతున్నారు సార్ వాటర్
Mr. Lohit, Maria, Pratyusha, Rahul, Vignesh. You can say your name. What's your name?
Dr. Pratyusha.
Participation certificate. Participation certificate.
Yeah, Itrama, please. Done.
Just on the stage, I want to, I take only 1 minute I have to take. I congratulate and I thank all my postgraduates from Gandhi Medical College. A big round of applause to them because they have been working very hard all these months. Despite the COVID situation, it was only them who have been working for the COVID children. I'm really proud of all the postgraduates of Gandhi Medical College. They have come forward to present the posters as well as papers. I request all the Gandhi Medical College postgraduates, please come on the dais. It's a proud and a privileged moment for all of them. Thank you, sir.
Paper presentation, certificate ఇవ్వలేదు, only medal ఇచ్చిండు అంటున్నారు.
అది వేసుకోండి,
మెడల్ వేసుకోండి.
పేరెంట్స్ ఆర్ వాచింగ్. Your parents are watching this?
యూట్యూబ్లో కూడా చూసుకోండి. యూట్యూబ్లో గుడ్, కంగ్రాట్స్. థ్యాంక్ యూ సార్.
వీళ్ళందరూ పోస్టర్స్ ఒక గ్రూప్
అందరూ పోస్టర్స్ అండ్ పేపర్స్ అన్ని చేశారు. And they were the COVID warriors for this year.
They need more appreciation.
A word from for them.
On behalf of IAP TCB EB 2020, honestly we salute you because you are the COVID-19 front warriors. You did so much service to the children suffering from COVID-19. As a token of respect and gesture, entire EB team salutes you. And you would have been more happier if you had made some more achievements in some of the activities today. But I'm sure next year, I'm 100% sure, Gandhi faculty is so fantastic. You will get all these prizes, poster, gold medal. Don't get discouraged due to COVID-19. Academic activities were a little disturbed, but it doesn't happen next year. And my sincere thanks to you all. Once Dr. Abdul Kalam said, failure is a step for the coming success. So with these few words, we are with you and all the very best. Dr. Suchitra, Madam, representing the entire Gandhi faculty, PGs, and she has contributed so much for IAP TCB EB activities. We are thankful to you, Dr. Suchitra. Thank you. Thank you very much.
Thank you, thank you, thank you very much. Thank you. No, I'm calling you. Just wait for 1 minute. Now I call Gopi, IAP Executive, IAP TCB Executive to come on. Come on to the dais, Gopi. Next, I am requesting to Javed, Dr. Javed, Event Manager, to come on to the dais. Javed and team,
Javed and team.
Javed and team. Excellent event, and you have made a nicely wonderful event. We should honor you because the success depends upon event manager. Any event. Gopi.
Gopi first.
Gopi. ఓ చాలా కష్టపడ్డావు, చాలా కష్టపడ్డావు. నిన్ను అప్రిషియేట్ చేస్తున్నాం చాలా. వెల్ డన్. నెక్స్ట్. ఓకే ఓకే పర్లేదు. Mr. Javed and his team. बहुत अच्छा काम करे. Thank you so much, sir. Adnan? नहीं, एक minute. Next. Adnan, come on.
రాజేష్ నేను మధుని పిలువమ్మా. మదన్. రాజేష్, మధు.
Rajesh, Madan, Mr. Madan, Mr. Rajesh.
See, he is the main for the live streaming.
Sir, live streaming.
Mr. Rajesh is main for the live streaming. Everyone, all who have viewed the live streaming, they appreciated like anything, and their appreciations are like giving us boost up to go ahead with these type of presentations. Thank you, Rajesh. Thank you so much.
Rajesh, you made it a history in the IAP academic activities. It is first of its kind to have a hybrid conference. When Rajesh approached us, I had my own worries regarding live streaming, but he had surpassed my expectations. He had done a wonderful job. Thank you, Rajesh. Thank you very much.
Thank you, sir. Please. Thank you so much. So the next person, Madhu. He's a video jockey, VJ. Without him, the mixing up on the screens will not be made possible and make it a success. See, doing is a thing, but doing a colorful thing behind us on the screens in the during live streaming and composing. We have 4 panels. On the 4 panels, 1 presenter and slides and mix up. These things are done excellently by Mr. Madhu, who is the VJ of today 2 days conference. Thank you, Madhu. Sir, Bhaskar sir, please.
Madhu, very handsome boy, a Tollywood actor, did a wonderful job. Thank you.
So, next, Mr. Madan. See, he was very strict in issuing the ID cards, doing the registrations. So many problems. I think since 2 days, maybe around 50 to 60 doctors would have cursed him, but still he had a cool head and down head, and he never gave a harsh words to any delegate. So everyone are happy, and at the same time he conveyed everything message to me or Bhaskar sir, and he had done a great job, and his team had done a great job in the registration, and it's a flawless service. Thank you. Please, sir.
Yeah. Thank you, Madan. You have done a wonderful job, really. You made the proceedings so smooth at registration counter. Thank you.
One second. అయ్యో కరెక్ట్ నువ్వు ఉండు and sir Mr. Srinivas, please. LED. He is the light designer. So without light, it will be dark. But with these colorful lights, the event becomes more colorful. So he is the light arrangement man. So we have to give a big applause to him. Thank you. He is the Nagesh, Mr. Nagesh. He is also a VJ, because having these many screens, these many console and these many activities, we need more manpower. So he is one of the Nagesh VJ. Thank you, Nagesh.
In fact, he is the main key person behind the conferences of BJP all over India on international level as well.
Okay, great. So we opted a good quality person so that our conference was a huge success.
3 days back, we had a BJP conference here in the honor of
Venkaya Naidu. Yeah.
Yes, late Atal Bihari Vajpayee.
Yeah.
He was the key person behind all the LED screens and the mapping on that.
That's great. So, anyone more of your staff? Anyone more in your staff?
No, sir.
So, I think Shiva?
Audio engineer, sir.
Audio engineer, run fast, please. So, is Shiva? Audio engineer. Okay. Now, Purushottam Reddy is the man who, who is toiling since 2 days, and he is a travels person. He is my close friend since 25 years, and he takes care of our secretary, Dr. Sunkoj Bhaskar sir. Sir, please. IAP TCB bonded pilot. Thank you. And now I request none other than Banu. Come on. Banu. So, without Banu, we will not be able to complete the task. Yeah. So, his team has done an excellent job in giving the photos, pics and everything. I think within 2-3 days, we'll load everything in the YouTube and you can see that we'll send the link. Thank you so much, Banu. Banu and his team.
Thank you.
So,
next time, we'll see that we'll invite you first, after that our medical colleagues.
Yeah, Javed, any word?
First of all, I don't have any kind of words, but we are honored to get associated with an esteemed organization like IAP TCB for a second time in a row. We are speechless, we don't have any words. Thank you so much for giving us the opportunity.
Thank you. Thanks for all the team and service. Anyone I missed for this rendering services? Okay. Now, yeah. I thank Marriott Convention Center, Marriott Hotel Management, who had done a great job for us, arranging for this 30 hours program of our IAP TCB PEDICON. And a special thanks to my organizing team, Chief Organizing Secretary, Dr. C.N. Reddy Garu, Organizing Secretary, my Sunkoj Bhaskar sir, and other delegates who are all in the organizing team. I thank everyone because they have given a lot of efforts, giving idea and other things to make this huge success, this conference. And coming without pharma, trade, the conference will not be able to happen. The first sincerely thank Veritas company who had the major role in sponsoring, and next comes to the Johnson & Johnson, biological events, and Pfizer, Juventus, Sanofi, Aristo, Bharat Biotech who had sponsored the night dinner, and Medmenor, and Serum Institute, and this Sun Pharma who had hosted the presidential dinner. I thank and Fine Arts School who had participated in the trade, and really we are overwhelmed with the support given by the pharma. And thank you very much for all the things, and I thank electronic and print media also a word. So thank you. If I miss some name, just apologize me. So because without intentionally, I don't want to miss, but still I'm just exhausted. So please, next time also, we'll show the things in a very colorful and fruitful way. Thank you one and all. Thank you.
Long live IAP.
Long live IAP. Jai Hind.